Check. Hello. Check one. Hello. Hello. Check test.
Hello, hello, check one. Hello, 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 check. Hello, 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 check one. Hello, 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 check. Hello, 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 hello.
हेलो। एक नंबर। हेलो हेलो चेक बड़ा हेलो हेलो चेक हेलो 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 चेक हेलो 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 बढ़ाना हेलो चेक हेलो 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 चेक वन हेलो 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 चेक हेलो हेलो चेक हेलो ठीक है। हेलो हेलो चेक हेलो हेलो चेक वन हेलो पूरा माइक चालू ठीक है बड़ा पोडियम बड़ा हेलो 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 टन टन ऐसा कुछ आ रहा है हेलो 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 चेक हेलो ज़्यादा बड़ा मत हेलो ठीक है हेलो हेलो चेक हेलो 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 चेक हेलो 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 चेक हेलो हेलो चेक वन हेलो हेलो चेक हेलो 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 चेक हेलो 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 चेक हेलो हेलो चेक वन हेलो हेलो चेक हेलो हेलो चेक हेलो हेलो इतने पास में बोलना चाहिए यार माइक हेलो हाँ क्या हुआ भाई माइक जबकि इतने में रहना चाहिए कभी भी हेलो आ रहा ना बराबर हेलो हेलो चेक एक फोटो वोटो निकाल दे यार अच्छा लग रहा हूँ निकालना ये नाम डाल गुलशन मेरा दीपक शाहू डाल दे वहाँ नागपुर से हेलो हेलो चेक हेलो 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 चेक वन हेलो 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 चेक एक सेकंड ना हेलो हेलो चेक हेलो हेलो चेक हेलो हेलो हाँ हेलो ठीक है सहन ठीक है ना ओके हाँ कैमरा वैमरा क्या सेट कर रहे थे अभी करो फिर हाय गाइस फोटो लेना भाई हाँ लेना हाँ भाई तो उससे क्या हो रहा लिखेगा तभी तो करेगा ठीक
all from ijcto Hyderabad. We start the morning session of CD, planned retrograde but finished antigrade. I invite the chairpersons, Dr. Raja Ramesh, Dr. Prakashveer Parekh, please take, Dr. Jeet Ram Kashyap, and Dr. Sharad Chandra. I invite the discussants, Jayanti Bantu, Dr. Satyajit, Dr. Suraj, and Dr. Gaurav Chaudhary. I think the first presenter has not reported, so we'll go with the second one. I invite Dr. Gaurav Verma to present her first.
Good morning to respected chairpersons, discussants, and my dear colleagues. Whenever we do complex cases, especially CTOs, they're full of unpredictabilities, and sometimes you feel that you are playing like a 2020 match in which sometimes match is in your hand and other second you feel you have lost it. So this was one of a kind where at the moment I felt that we are too close, and at other instance I felt that I may not be able to finish it. So it was not just as the sessions name is started retrograde and finished antigrade. It was like which completed with antigrade, then retrograde, then antigrade, then retrograde, and finally we could do it with antigrade technique. So patient was a 67-year-old male who had a old history of angioplasty done to diagonal branch in 2018. When he reported before that, he again had a event of inferior wall MI, but he didn't do anything, and this time presented with early heart failure with EF was 35%, with mild MR and mild pulmonary hypertension. He was stabilized medically, and after 3 days, angio was done. So there is some disease in the circumflex, but the mid LAD is tied with 2 lesions. More importantly, the RCA CTU. So you can see there's a branch coming at the site of occlusion, and there's a blunt stump, and we know this old inferior MI, and you can also appreciate there calcium along the course of RCA in the CTO segment.
Is there a stent in RCA?
No.
What is
These
that?
are calcium, sir.
The whole calcium.
Yeah, these are only plastic done to diagonal in 2018.
Yeah, it looks like there is a stent in RCA.
There's nothing. This is all calcium.
Okay.
So options were given: bypass versus plasty. Patients were not willing for bypass, so we started with angioplasty. The issues were blunt stump, angulous cap, and the calcium there. So plan was to first revascularize RCA, then tackle LED. And we started with the antigrade approach. These were the wire which I chose to start, and it failed and retrograde, but not very optimistic because the collaterals were not that great.
Can we discuss it simultaneously?
Definitely.
Is that okay? So the symptoms were acute heart failure.
Acute heart failure.
And if
EF
we
was
Okay. And if you see your angiogram, it looks like that LED may be the culprit vessel which is causing symptoms.
Of course.
So, my take would be that I will first revascularize LED. What about others?
My contention was that you should go for a complete revascularization. It was a viable turret inferior wall, and if you don't succeed RCA, then the case is for
So
CAV.
actually, you have not told us the viability neither by echo nor by any perfusion scan.
Because the
So
time
that's
issue,
why.
sir, I couldn't.
Yeah,
It's
the
a
other thought is that
intervention meet.
if he's not able to succeed RCA CTO, then the plan of giving the case for CAB.
Means we are not discussing which is the better option, right?
No, no. Just for the sake of
Of course.
discussion,
Then
because
I
we
would
should
have
not see
shown-
that we are
I
just
would
doing
have shown you
CTO.
the echo
We
as
should
well.
see patient as a whole, actually.
Of course, sir. I could have shown you echo and then regional wall motion abnormality and the wall thickness, everything we could have discussed.
Okay, that's.
So basically, we were dealing with the RCA C2 and LED. Our contention was just first to open RCA. If we are not successful, then there's no point doing LED, isn't it? Unless the thing which came in this case. Let us discuss that.
Actually, LED supplies 2/3 of the heart. So I think symptoms definitely will improve LED. So even if we leave RC looks like a small vessel here. And there is only one good branch supplying RV free wall. So I think still I will say that I would have done LED first, and I might have left RC if I don't succeed.
Fine.
And while doing retrograde or antigrade, if you have good supply to the left side, you are more comfortable in doing CTO.
Fine. So we started with the integrated approach. Started with these wires. First cross it, then Gaia 2. Then took a micro and over Gaia, that took a Gaia 3. But after 25 minutes, we thought that we won't be able to do it, and thought that I will go for a retrograde now. Found some collaterals in septal branch. Easily crossed a micro over soft wire, then crossed to Gaia 2. You can see the calcium there in the distal part. It's a long CTO, diffuse disease. In the second shoot, you can appreciate, and the third shoot, that is a long diffuse disease. And took Gaia 3 finally to enter, but was not able to advance. Then thought that let us try with the integrate also, keeping the micro there, and thought that now we'll try with a hybrid approach, going with the integrate approach. So took Gaia 3 over a micro, but again the wire couldn't bunch further after that mid segment. Again thought that we'll go back to retrograde, and this time I could cross the wire, but it seemed that I'm not in a true. You can see that both the wires are not in the same plane. So now wire crossed, but it was not in the true. As you can see, that wire not going into the guide catheter, which I like to do it. So one procedure is to do a reverse cart with a small balloon to make a channel, so that the true false true can make a common channel you can cross. But again it did not work. The other technique which I tried was using a guide liner. When you put a guide liner from true to false to true, then the retrograde wire can easily cross, and it helped. The guide liner you can see is still the mid segment where there was issue in crossing the retrograde wire. And now in this shoot you can see clearly that the wire will go inside this wire will go inside the guide liner. You can appreciate that in the guide catheter. So I thought that okay, we were happy that now you can easily succeed and you can complete the case. Suddenly patient had bradycardia and angina, and there was some sort of drowsiness, and immediately we have to withdraw everything. So now we are there where we started. So immediately code blue was activated, and this was called. We gave everything for the life-saving measures, and we did emergency echo to rule any mechanical complication, but what it caused this thing. So we thought that maybe a sort of vasovagal, and whenever we pull a wire from retrograde to antegrade, sometimes it do happen. It's been reported. So patient got stabilized after 5-10 minutes. We thought we'll start afresh, and like sir said that LED was a viable, and we thought that it's not a chance now to go with retrograde because that is already infarcted artery. So let us go LED. So like sir suggested, we planned that way, and now we fixed 2 stent in LED. And then we thought now we'll try RC or we'll leave it. So now retrograde is not an option. Why? Because already you have put a stent across, and now it's difficult to go retrograde. So we thought let us take a chance and go antegrade, and we were quite unfortunate that we could succeed and cross a guy to over Corsair into the RCA. Then it was not a very difficult job. We could dilate antegradely with multiple balloons. Finally put a long 348 stent, and in the distal LED RCA we did a DEB. And like sir said, there was initially thought that we will leave this. Why? Because it looks like a small branch, but see how the arteries grow and see how the RCA is. So it's a dominant RCA, it's not that small what we thought of. And we were quite happy that we could, after all this hard work, we could do it. So the take home message is retrograde, integrate, both are good options. We have to be careful in selecting the route, as well as we should be aware of the complication at each step. Keep your calm, and perseverance is the key. Thank you.
So finally got good result. But as I said earlier, actually, whenever we want to go retrograde, we should not select a channel which can cause ischemia. So that has to be taken very good care of. And probably you had disease. I don't know which channel you selected.
Just
The distal one or first one?
This one septal only, sir. I'll just.
No, there were two channels, and
collateral-
both were actually
collateral-
arising from a disease segment. So there were high chances that it will cause ischemia. And your RCA is such a big RCA, it has turned out.
Yes.
So already such a big RCA is totally occluded, and you are causing ischemia in the LED territory. So this was supposed to be
And
happening.
if I
What
put a
happened?
stent, then I thought that we would.
No,
just
I
close
think
out.
you can still go through this
open the
stent.
stud and
Ah,
we
we
can
can
You
do-
can
we have
still
done
go
that
through this
also.
stent.
Yes, of course.
So the best option would have been that you reverse the LED, and then you could stage the RC for next sitting.
Fine.
So I think I would have gone like that.
Thank you, sir. Any comments?
What was the reason for that decompensation? It's only
We
vessel
thought that there was some sort of vasovagal. This was not ischemia as such, because there's nothing to do cause ischemia at that time. Because it happens sometimes when you pull the wire from the
tension.
with the tension, it happens. It has happened and reported also. Thank you.
So the first, no, yeah, whether the first speaker has come. First speaker, yeah. The RCA, third one. The micro dissection technique in failed antegrade wire acceleration by the Shamshad Alam. I think.
Yeah, good morning everyone. Today we will be discussing about a novel technique, although not that much used, but day by day when the CTO techniques are evolving, this is coming again in use, although it was introduced in long back 2008. Earlier thought that we can get a lot of complications and we were not used to, but as years passed, as expertise is developed, this technique again came back into use. So let's summarize the case. We had a 50-year-old hypertensive female with effort angina. Even she was on optimal medical management. Angiogram revealed a proximal RCA CT with collaterals from left system. Echocardiogram, the LV was preserved, minor renal wall motion abnormality in RCA territory. This was the coronary angiogram. It was a proximal CTO, and the collaterals were from the left system. Left system was, there was a disease, but it was not that much significant. Grade 2 collaterals were there. So we planned to go for antegrade approach for RCA. The JR was sitting well. It was initially we thought that it will give good support, although it was a osteal lesion. We were able to escalate Gaia 2, but every time we thought the movement of the wire, it all every time it made us felt that we are not moving in the right track. It is always moving in the subintimal space from the proximal portion only. So finally, after uh, almost 40-45 minutes, we thought that no, we might have to move for retrograde, but the channels were not very big, and also the length of the segment, CTO segment, it was very long. Then we thought that we can give a try for Carlino's technique. So we placed our microcatheter just inside the proximal cap of the segment, although still we were with JR2, JR guide. So after micro dissection, after injecting 0.5 ml of contrast, we did it with a controlled force through the microcatheter. Some disruption in the tissue, in the CTO tissue proximal cap occurred, and we were able to see that disruption, and dye had dissipated into the RCA, whether it has dissipated in the subintimal space or through that material. But then we thought that now we will have to take good guide support. We have chosen AL1. We had a microcatheter, and then we were able to track our Gaia wire through the lumen. And after confirmation of our Gaia wire in the lumen, uh, from the contralateral injection from the left system, we tried to advance our microcatheter. Corsair microcatheter was there, but still we were unable to advance it. So finally we removed our microcatheter, and we used a 1 mm Roure balloon over that our Gaia 2 wire, and then after getting the flow, we exchange it with whisper wire, and the further lesion preparation was done with a 2.25 balloon, after which we noted that there were multiple dissections all over the RCA. Although the lumen of RCA, we were not able to see a very good lumen of RCA which was achieved. But anyhow, we stented the distal segment with 275 38 synergy, and the same stent balloon we used to prepare our proximal segment. Again, a 338 synergy stent was deployed from proximal to mid RCA, overlapping with the distal stent. Well, good post dilatation was done with a 315 NC balloon followed by a 3.25 at high pressures. And finally, this was the result, which revealed a good distal flow. Stent supposed to be well expanded, and no significant dissection was noted all over the segment. So few things we learned, that novel techniques at times they can be useful if we are failing our conventional techniques. And guide catheter, it should have been changed earlier, just applying the Carlino's technique. And in blunt stump CTO, as I said, micro dissection technique can be used, and usually if whenever we run a CTO program, in initial phase it is not advisable to use the novel techniques. One, you have mastered various antigrade techniques, and if you are familiar with the STAR techniques, the STAR technique, the hydraulic method which was used, it was almost 3 to 4 ml of contrast, forceful contrast injection was used in that STAR technique. But day by day, when it was modified by the Carlino's technique, the amount of contrast gradually came down. It came down to 2 ml, then 1 ml, and then 0.5 ml. And the controlled dissection, it always it is a concern for the operator. The day by day operator gets trained, then the way he can apply that controlled force, because this controlled force is very important. If your force is very low, then that dissection which we intend to create could not happen. And if we apply more force, then obviously if we are in subintimal, that dissection will progress to the distal segment, and it can also compress the retrograde collaterals which are coming from LED. And third thing, which is most important, is the kind of the CTO segment which we are dealing with, whether it is a severely calcified segment or not, whether we think that it is a fibrous soft component is more predominant. So the amount of force also depends upon that kind of composition of the CTO component. Thank you. Thank you.
Is there any specific reason not to start with the AL1 catheter?
No, actually, the JR was sitting well, and it was not moving back in antegrade wire escalation. So we thought that we can succeed. Initially, when we were able to track down our Gaia beyond the mid segment of RCA, but after that we were unable to track down with that kind of when we do a CTO. So we thought that every time we are entering in the subintimal space.
So I think good demonstration of the technique, but I think as in we see in the both the cases, first one in Leo's also, both of you took JR. Whereas I think whenever we are trying a CTO, we should from the beginning start with a good support. And I think for RC, most of the RC CTO, we should take a good support guide. So AL is one or AL 0.75 is the guide of choice for RC CTO. And secondly, I think when you had crossed, you have dilated, IVS would have helped you to know whether it was true lumen and to size the vessel. So the imaging is very important once you cross the region. So, and third thing, I saw some blush coming out of the one of the channels. Was it a perforation or is there a fistula? Can you show us the last slide? Last one, please. Okay, so is there some fistula or is it some
it was a fistula
wire-induced perforation?
Because our CTO wire it didn't reach that.
It looks like
It was
coronary
a
cameral
small
fistula,
coronary cameral
small
fistula.
coronary cameral fistula. Okay. Thank you.
Thank you.
Yeah, we'll go with now case number 4. Yeah, stable vascular access is essential for successful outcome. The CTO of RCA by Habibur Rahman. It's not error. Then we'll move to the case number 5. No, this is the same thing. Yeah, that's a slightly different order. Antigrade re-entry made simple with the latest penetration wires by Nimisha. And next, the RCA C2O PCI antigrade approach in triple vessel disease by Jekula Ramakrishna.
Good morning, sir. I am Dr. Jekula Ramakrishna, a secondary resident at Mamta Medical College. My case scenario is a 70 years female who has no history of hypertension and diabetes, no comps. She came with anginal pains in 6 months. And on evaluation, ECG shows evolved inferior MI with the echo shows RWMA in regional motion abnormalities in inferior wall with the mild LV systolic dysfunction. And plan for CAG. CAG shows it's a triple vessel disease with a syntax score of 34. And the proximal RCA CTO with the bridging collaterals and septal collaterals. And JCTO score of 2. Here, this is my patient angio. Here, RCA, proximal RCA CTO with bridging collaterals. And an LAD also, proximal LAD discrete lesion, and LCX also diffuse disease with septal collaterals filling the PD and PLVB. Initially, we planned for dilemma because of we first treat the left system or right system because the RCA is the CTO. and left system is discrete lesion. But as ECG and echo shows general motion abnormalities in inferior wall, so we thought of treating the first target vessel of RCA. Initially, we treat the left system LED as it is retrograde filling the RCA, and it will lead to improving the patient symptoms. But after, if we plan for CTO, if it fails, there is no option of CABG. So that's why we plan for RCA CTO. Here, right coronary artery was cannulated with 6 French guiding guiding catheter, and JR3 or guiding catheter taken. And for crossing the proximal cap of CTO lesion, initially we tried with field refs or in-house workhouse wire, but it does not give the support. And after using the microcatheter, fine glass microcatheter, we extended with initially with Gaia 2, and it is also unable to cross the proximal cap. And finally, we use the Gaia 3 guide wire that crosses the CTO segment. And branch, after that, we extend to workhouse of wire of field FC. And after using Gaia 3, we are successfully crosses the CTO segment and enter into the digital branch. Then the lesions were pre-dealt with high profile balloons with 0.75 initially, then followed by 1.25 and 2 into 10 mm balloons. And we further progress with stenting with the digital RCA 2.5 into 40 mm stent. And proximally with 2.7 into 40 mm, that is overlapped with the previous one. Then post dilation done with 3 into 10 mm NC balloon with the high pressures. And the final results was very good with no evidence of dissections. So my take-home message from these CTO cases: the successful CTO interventions has been associated with symptomatic improvement and better long-term outcomes and improvement in the mortality and ventricular function and quality of life. But choosing the optimal hardware like guide wire, microcatheter, and low-profile balloons are critical in CTO interventions. Yes, thank you. Here we are not having any image-guided procedures at our center, sir. That's why we are not using any iOS.
So I think that is okay, but again, to start with, you start with the JR.
Yes,
it was backing back, not giving good support, and the CTO was the tortuous one.
Yes.
It was not a straight segment.
Yes.
So I think we should always use a good support guide, and always take a bilateral injection. That was again one thing which was lacking. You should take bilateral injection to see the distal part.
Absolutely.
What will happen once your microcatheter or catheter wire will cross? You'll lose the contrast to this. You'll not know where you are. So I think bilateral injection, there's certain rules of CTO intervention. Bilateral injection always, and a good support guide always. So I think we should not break the rules of the CTO intervention. That is very important. Otherwise, you'll do 1 or 2 CTO, then you'll not progress in your. If you have to run a CTO program, I think basic rules are to be followed.
Yes.
Thank you.
So we'll move on to the next case. When there is a cap, there is a way by Kunalu, sir.
Good morning, everyone. I'll be presenting a LED CTO case where there's a cap, there's a way. So our patient was a 64-year-old male with history of hypertension. He was a tobacco chewer. He presented to us with left-sided chest pain radiating to arm since 2 years. Initially, his pain was class 2, which was only on exertion, which later progressed to routine regular activities, which were like climbing one flight of stairs. ECG showed normal sinus rhythm. His troponin was negative. The rest of the lab parameters was normal. So we made a diagnosis of ACS unstable angina with mild LV dysfunction. The ECG was remarkably normal. He had an angiography done in 2002 in some other institute, which showed 100% LED occlusion. They tried a PCI, but they could not cross the wire. So he was kept on medical management. But since his symptoms kept on progressing, he presented to us with the same complaints. So his day CTO score was 3, progress CTO score was 1. Our plan was, since it was a long CTO segment, seeing from his old angiography, we planned for a hybrid approach from LED and RCA, first to identify the proximal cap via the lesion, and then with the help of imaging, choose the appropriate stent strategy. So this was a first shoot. We could see that there were adequate antegrade collaterals. We could see the LED tract. So in the first look, it looked like a fairly easy CTO with the tract completely visible and a short CTO segment. So we went ahead with a dual lumen microcatheter. Since we wanted a landmark for the LED, so we kept a workhorse wire in the diagonal, and then we progressed with the CTO wire in the LED. Yesterday we learned a lot about the dual lumen microcatheter in the lecture, so this is a example of it. We took a retrograde injection also from RCA, but most of the collaterals that were being given were from the diagonal itself. So there was no need of the RCA injection. So we went ahead with an antegrade approach itself. So after repeated trials, we could not access the true lumen of the LED. So if you see carefully in the next image, the LED takes a curve around the diagonal and then it goes downwards. So it was very difficult to access that tortuosity, wire that tortuosity, and then progress towards the true lumen of LED. So we escalated the wires. We started with feeder XT, Gaia 3, Pilot 150. None of the wires could negotiate through that tortuosity, even with the help of a microcatheter. Finally, we went to Gaia 2, and Gaia 2 could take the shape of the tortuosity, as you can see in the slide. It negotiated the tortuosity, so then we could progress to the true lumen. After that, using parallel wire technique, we took Gaia 2 and Whisper MS, through which we could negotiate through the CTO segment. And after that, once a wire reached the distal lumen, we removed the microcatheter. We again put a workhorse wire in the diagonal. Then we pre-dilated with a 1.5 and a 2 balloon. Once there was adequate space in the lumen, we removed the Gaia 2 and put a cyan blue, on which we then did the imaging. So this was the IVIS run. It showed a fairly fibrocalcific lesion. There was no dense calcium or thick calcium. The lumen was around 2.5 to 3. This is the distal segment. So a lot of fibrous plaque can be seen. And there was some amount of plaque in the left main as well. So this was a proximal reference segment and a distal reference segment. The lesion morphology was fibrocalcific and the lesion length was around 40 mm. So we took a cyan blue and we deployed a 2.75 into 48 DES, and then again we did a post-stenting imaging. So this was a post-stent IVUS. The stent showed fairly good expansion. There was some areas of under expansion which we further dilated the proximal segment with a 3 mm NC balloon, which you would see in the proximal segment. So no dissection and good expansion of the stent. So this was a proximal and distal segment post-stenting. Well, good expansion and no edge dissection and no malapposition. And this was the final result. So some of the take-home message from this case was, number one, which is not mentioned here, that the careful evaluation and study of the angiography before taking a CTO case is of the utmost importance, because during this case, we had to again and again go outside, study the angiogram, look for the tract, where is the LAD arising from. Then only we could figure out that there's a bend which is leading to the LAD, and to negotiate that bend was the most important step of this PCI. So studying the angiogram before taking the case is of utmost importance. And after that, we all know that we need hardware strategy selections, and hydrophobic wires, though instrumental for piercing the proximal cap, may not be able to track through the CTO segment due to wire fatigue and entrapment in the CTO segment. So once we have pierced the proximal cap, we might need to get switch to hydrophilic wires to track through that CTO segment and reach to the distal lumen. Thank you.
Okay, so good demonstration of the IVUS. So this was a case for IVUS guide entry. Actually, you had a IVUS. So why didn't you use the IVUS for entering the CTO segment?
Because at the initiation, sir, we did not anticipate that it would be difficult to enter the lumen, because the bend was
That's
hidden
why
behind
you were
the
finding
branches.
difficulty. So I think IVUS could have been used for entering. And second, I have observed that you, after dilating the vessel, you have crossed the work of wire without microcatheter. I think we should not do that, never ever, because sometime we'll have a dissection and you will lose the whole case.
Yes, sir.
So I think wire should always be exchanged with a microcatheter, especially in CTO. These two observations. Thank you.
With the loop we have entered.
Yeah.
Yeah, that's what
Yes,
it's
sir.
telling. If any dissection plane is there, it would have a tracker down. That's why always exchange over the microcatheter.
Yes, sir.
Then one more comment. In the post stunting in angio, there looks like some area of under expansion. What is the minimal area you got in LAD proximal? Can you show the lines?
Yes, sir.
I think, and you lost the diagonal, I think.
No, sir. The diagonal is
Just,
that is where we kept the wire throughout the
Okay.
procedure in
We'll
the diagonal.
show the last scene.
The presentation has changed. Diagonal is there, sir. Sorry.
So where is the proximal edge
There's
of the
some
stent?
under expansion at ostium of the LAD also. You came back into the left main.
No, we do not extend into the left main. It was from the proximal LAD only. The left main, as we saw in the IVUS, the distal left main also had some plaque. So we did not want to extend into the left main. We have placed it from
origin
the...
of that first diagonal, it looks like maybe if you take a caudal view, then you could have.
We've,
but
sir,
okay.
expanded with the 3
But
balloon
you
also
have done.
after
I was
entry.
could you have satisfied with the MLS what you got in the
Yes, sir.
proximal? Yeah,
We
then
were
okay.
satisfied
Yeah,
with the
fine,
MLS.
Thank you.
Thank you,
We are moving on to the next case, the stumpless ostial LAD CTO PCI by Dr. Ganeshan Ramachandran.
Ganesh is not there, Dr. Stalin is there in place of him. He will be presenting.
Yeah, Dr. Stalin will be presenting in the stumpless ostial LAD CTO PCI.
Yeah, good morning to all. Dr. Ganesan couldn't make it, so I'm presenting on his behalf. This case was done at a center where there were a lot of limitation in the hardware, like there were no microcatheters apart from the fine cross, no intravascular imaging, only few CTO wires, and it's the beginning of the CTO program. But this patient, who is a 67-year-old male who presented with exertional angina class 2 for 1 year, he was on medical management, But medical management failed him. He had recurrent admissions with acute pulmonary edema, and the troponin was positive. The pro-BNP was very high. The EF was 35% with mild MR. So this is the angiogram. You can see that the LAD is totally cut off from the ostium, and there is a critical lesion in the OM. Probably that could be the reason for his heart failure symptoms and as well as his mitral regurgitation. So we took a dual injection. We can see that it's a fairly longish CTO, around 20 millimeters, and you can see that the distal cap is very blunt. It's just at the origin of the diagonal. The LAD is the proximal cap is blunt as well as the distal cap is blunt. You can see that. And this is the JCTO score. It was 3, and the progress CTO score was also high. So this is a quite difficult case. So we thought that we'll go primarily retrograde because we cannot see the stump and there was no IVUS. So the RCA was engaged with the Sun Front JR, and the field ref C guide wire was taken to the PDA with the fine cross support and exchanged to a SO3. Then the microcatheter was easily tracked across the septal channel, almost reaching at the distal part of the LAD CTO. But however, even with multiple wire escalations, Gaia 2, Gaia 3, it all failed to penetrate the distal cap. As we saw, it was quite blunt. And there was no working space for the wire and microcatheter to engage the distal cap. The wire was easily prolapsing into the diagonal. You can see that in the diagram, the wire was repeatedly hitting the distal cap and getting deflected into the diagonal, despite multiple wire escalations. So we had to come from the antegrade. But it was quite difficult from the antegrade. Again, another fine cross was taken, Gaia 2, Gaia 3, multiple subintimal space entry. And since we had hardware limitations, we couldn't do parallel wires, or as we already exhausted multiple of our guide wires. So we had to just redirect the wire into the true lumen, just using the RCA chute as the reference. But we can see the distal LAD clearly. So with that, with the help of that, the re-entry was successful with Gaia 3. So once the re-entry was done, then the steps were easy. Microcatheter was advanced distally and exchanged for a routine work cause wire, that was the field ref C. And then the routine steps, the predilatation was done. You can see that predilatation. But after predilatation, you can see there is a staining. You can see the contained perforation near the origin of the diagonal. And nasty dissections were there. So we had to immediately stent the circ and then secure the LMCA to LAD. This was the chute after securing the LMCA to LAD. We can see a contained perforation at the ostium of the diagonal. After that, the optimization of the stent was done. The balloon dilatation was done. Gentle balloon tamponade was done for 5 minutes just to be on the safer side, even though there was no active extravasation and echo did not show any pericardial effusion. And then after that, we thought we'll just give a try of wiring the diagonal. And the diagonal was wired with a polymer jacketed wire, and 1.25 into 10 millimeter balloon was used. But you can see that, just a minute, it's not playing. After the balloon dilatation, the extravasation increased. So we had to, we couldn't salvage the diagonal, we had to stop it there. This is the final result. The LAD was flowing, except for the first septal and diagonal, which got occluded by the dissection planes. The RCA donor check injection was done. It was fine. There was no collateral injury. You can see that this first septal was filling from the RCA. So take-home learning points. Ostial LAD is one of the most challenging CTOs, and especially if there is a side branch at the distal cap, again, retrograde options are also limited. One option would have been a Suzuki microcatheter, which can be tracked through the retrograde gear, and that would have given support, but unfortunately it is not available even in India. And perseverance is the key to success of CTO. You should have multiple options. One option fails, you have to try the other options available. Thank you.
So I think nicely done case. This was a real case for primary retrograde as we had a flush occlusion of proximal austerity. So one thing is that I think you could have chosen some distal collateral so that we had a space. You had a distal collateral also in LED.
Yes, sir. We had
So
distal
we could have
collateral
a
also.
space for crossing to have a support to the wire. And I think this recrossing of the diagonal, perforated diagonal was should not have been done at all, because you already were saved actually, and now you are again poking in that, so that should not have been done. I think there's nothing, you lose the diagonal, I think the patient didn't have any symptom, so already diagonal perforated, we should not have crossed.
Yes, sir. That's true.
You are again lucky that it didn't
Cause more
convert it
problems.
into pericardial tamponade.
Good morning. Sir, Stalin sir, you did not, microcatheter did not cross the collateral, no sir?
It crossed the collateral.
Okay,
It was kept even at the distal end of the CTO cap, multiple positions. I mean, there were lots of images. I didn't keep everything. But despite the microcatheter being very near the CTO cap, it was not able to penetrate. It was the angle, actually. You can see that in that, even though there was a working space, around 5 millimeter was there. As sir told, if you had come from a distal septal, some more working space would have been there. But despite the working space, we were not able to negotiate that. There was if you see the initial angiogram, there was just a deflecting cap. It was just deflecting into the diagonal. That was the problem.
Sir, cause for perforation, sir, that wire?
Not sure. It's not wire, probably
initially-
aggressive balloon dilatation.
Maybe
No, I
the
think,
initial Gaia wire might have caused.
Yeah, dissection planes would have
Yeah.
been there, but the perforation was visible only after the pre-dilatation.
No. I think it was the proximal dissection by the
Yeah, yes, sir.
subintimal dissection by the wire that has extended into the diagonal. And I think you didn't have IVS, but once you are doing osteal LED, especially osteal LED, you should have IVS, because you'll come back into the left main, and if you come through a flap, it may cause disaster. So I think ideally, whenever you're doing a LED osteal CTO coming retrograde, we should have IVS.
Yes, sir. Thank you, sir.
Thank you. Well, we'll move on to the next case. LED osteal CTO PCI flush CTO by Pratish George method.
Good morning, honorable members of the dais, my dear colleagues. It gives me immense pleasure to present this case before you. This is a branch flush occlusion of the LED, and what we do to solve that. So we need to insonate the stream to find the path. This will become relevant as I discuss. So this is his story. This is a 53-year-old man, hypertensive, non-diabetic, non-smoker. He had exertional angina for 3 years, which was on medical therapy, treadmill positive. He underwent an angiogram elsewhere, which showed a flush LED CTO after diagonal origin, after an early diagonal origin. They advised CABG as a first option, and he came to our center for further management. When I reviewed the angiogram, there were good interventional collaterals from the RCA. Nevertheless, RCA was non-dominant, and so we thought we'll give an attempt for PCI. As you can see, he had a normal LV function with preserved R waves in the anterior precordial leads, indicating a viable myocardial territory. So this is our planning and our dual injections. So the target vessel was LAD. The proximal cap was ambiguous, and it was flush after the origin of a reasonably large diagonal. There is around 20 mm length of the CTO. There is no significant tortuosity or obvious calcification. The distal vessel was diffusely diseased or underfilled. There were good collaterals, CC1 from a non-dominant RC RPDA. There was an epicardial from the RV branch from the RC. The JCTO score was 1. In view of this flush occlusion, we thought a primary retrograde approach would be the appropriate therapy, followed by a wire escalation, IVS guided, or an ADR as a last option, because we don't want to lose that big diagonal. So the first challenge started, so we go radial and femoral most in our center for most of our cases. That's a standard treatment. 7 front JR from the right. I didn't think that a AL or AR will sit there. However, because of a non-dominant RCA, the wire just would not go into the non-dominant RCA vessel. It will keep on tracking into the RV branch. So this we tried for around 15 minutes. And following this, we thought that we'll move on to the next So there was a 8 French EBU35 from the right CFA with a long sheath. So this is an antigrade attempt, 014 cyan blue into the circ, not into the circ, sorry, into the diagonal to prevent, first we put the, into the circ to prevent deep throating of the guide. If you notice, the left main is very short, and we don't want the guide to go, such a heavy guide to go into the LAD constantly, so we put that. And then we put a run through wire into the diagonal. We always we try to predilate the branch which is giving the stump of the CTO. So dilates, there are 3 reasons we dilate. It enables open sesame. This is described by Sensei Saito. It changes the geometry between the vessels, and sometimes it opens up the lesion. In fact, it allows the IVUS catheter to cross and prevent crowding of the equipment. There are times when there is significant crowding, and actually when we do this IVUS gate puncture, the IVUS sort of gets kinked and we lose the IVUS catheter per se. It can also be used as a blocking balloon if the CTO wire constantly prolapses into the side branch. So this is the IVUS run from the diagonal. So if you can see, the diagonal is diffusely diseased. This is a Boston IVUS. How can I pause? So, however, in 1 to 3 o'clock position, there is a good large cap which can be seen, which will come shortly. Yeah, you can see that the cap starts there, 1 to 3 o'clock position, and there is a good sized LAD cap. There was no calcification in the cap. That again enhances success for a cap puncture IVUS guided. Proximal to the LAD, that is in the osteoproximal LAD, there was 2-quadrant calcification, which will become relevant later. So this is the real-time IVUS guided cap puncture. So because we set up the patient for success, we took an upfront 8 French guide. We could take a dual lumen catheter on the same wire as on which the IVUS is there. The IVUS will real-time image, and we can puncture under real-time IVUS. I've done with several wires, but for me, I have a lot of success with Miracle 12. So Miracle 12, the advantage is that it is a shapeable wire which maintains its angle of attack. Even if you shape it, it doesn't sort of prolapse. It doesn't lose the tip strength. And being a non-hydrophilic wire, it tends to stay intraplaque. Many of the cases, what happens, it punctures and then punctures out into the subintimal space. So this is an example of this thing. So the puncture should be mainly angiographic. You should not think that the puncture is, it should also use angiographic this thing, and also complement that with IVUS. And in IVUS, as Professor Nagamatsu presented yesterday, the most important thing is tracking the wire and seeing whether it stays intraluminal. So we have punctured the cap and we have to track it distally and make sure, like in this case, that it stays intraluminally. This is the key for antegrade success. And even, in fact, in this study also, it shows that IVUS guided puncture, the success is determined by following the wire and seeing that it stays intimal. In generally, we have to de-escalate to a softer wire. However, because it's a miracle and we could drive the same wire down to the distal LAD, we confirm distal LAD position. And we have a technique called, it's again described by Japanese operators, called the slipstream technique, which allows the IVUS to be removed, and then we can progress with the PCI. So this is done by pulling the wire back, the diagonal wire back, and it disengages it from the distal part of the catheter. Then you push the wire back in. The dual lumen catheter was removed with balloon trapping, and then we use a Corsair microcatheter, standard microcatheter, to exchange to a Grand Slam wire. I tend to put Grand Slam for most patients because taken the effort to cross it, you have a good supportive wire, subsequent things will be easy. So we predilate the LAD with a 2.5 NC balloon. This established good antegrade flow. Sorry. So this was the predilatation, and following this, there was good antegrade flow. We tried to avoid coming into the left main. So this established good antegrade flow. And you can see that the diagonal is deceased, which was anyway obvious on the IVUS. Good size LAD. So complexity begets complexity. So you do a complex CTO, you have to follow it up with a bifurcation. Mini crush of LAD D1. So these were dilated with 2.5 NC balloon. You stent the diagonal, take out the wire and balloon, make sure everything is okay, stent the LAD. Then do a first pot. We had quite difficulty in recrossing, which is a challenge with mini crush. So what do? We have the DLC on the table, we open it and use that to cross. We do pots again and recross easily once the dual lumen is in. Yeah, so the wire crosses easily. Some single guide technique to allow the 1.5 mm balloon to go, and this is our final result. This is how it was started with. Procedure time was around an hour. Contrast volume was 260 ml. Most of it we used to actually try to engage the RC and try to this thing. So this was a final result, and of course we complement complex PCA with IVAS. Very good areas both in the LAD and the diagonal. So take home points: retrograde CTO PCA, there may be challenges even in the presence of interventional collaterals. Up to 25% of cases fail even if they're interventional collateral when you are not able to get into it. Flush CTOs can present with several challenges. However, the side branch, as in this case, offers unique opportunities. Considering balloon across the cap location branch occlusions, IVAS capturing is a viable option in the presence of adequately large side branch, absence of calcification or stent. These two are the enemies. 8 French guide gives a possibility to IVAS and DLC on the same wire. Dual lumen catheter, as I saw demonstrated, there are several uses in complex PCA, and complexity begins complexity. We have to follow up, so a CT operator has to be good in other aspects of complex PCA. And we always use imaging to optimize long-term results in CTO and complex PCA. Thank you.
I think it was a perfectly done case, good demonstration of IBUS guided entry into the CTO, and I think good case. And only thing, left hand was very short. I think you extended from the ostium of the LD.
Ostium of the LAD. Circ was a large normal vessel.
Yeah, it was large, but probably I could have extended from left main ostium because it was very short, 2-3 mm. So no point in leaving 2-3 point.
There was a disparity in the size that would have been a challenge.
No, I think these days stents are very good.
Yeah,
You can go 3 stent, you can take up to 5.45 sort of thing. So that is not a problem, I think. Otherwise, very nicely done case. Thank you.
A good demonstration of IVAS guided puncture. Well appreciated.
Thank you.
Maybe the initial speakers, anybody is there?
No speakers as of
Initial 2 speakers, they are not turned out. Yeah, I think we are concluding with this session. Thanks for the presenters and the CRO chairperson. Sir, any final?
No, I think it was a good session.
He came. Yeah.
Okay. So we can invite the first presenter, Damodar Reddy. Is he there?
Yeah, he just came.
Yeah.
Okay.
we have one more.
Yeah.
Mr. Habib Rahman.
He came.
We'll go ahead with it.
Who sir is come? Who sir is ready with the case? We can.
Yeah. The next case, the stable vascular access is essential for successful outcome of CTO of RCA by Dr. Habibur Rahman.
Good morning. I am Dr. Habib Rahman from National Heart Foundation Hospital, Dhaka, Bangladesh. So my hospital is a private sector hospital. It's a high volume hospital. We do more than 8,000 PCI per year in 5 cath labs. So for doing CTO, we get lesser chances. So, however, we do some CTOs. I'm presenting nothing to disclose. 56 years old businessman presented with crescendo angina of class 3. His ECG revealed old inferior myocardial infarction. LVEF was 45% with raised serum creatinine. His CAG revealed significant proximal LAD lesion. 80% stenosis in OM3, which is of good size, and a short segment CTO in codominant right coronary artery. From here, you can see the short segment CTO in RCA, it's a codominant vessel. One of my junior colleagues started first the RCA to open it and do the PCI, and she felt some difficulties in engaging the RCA catheter, and that's why wire introduced into the first wire introduced into the conus vessel to stabilize it, and with the help of microcatheter, she somehow crossed the CTO. But difficulty starts as she was trying to push the microcatheter, is not going. Rather, catheter is coming back. So called me, and I entered the cath lab. I saw the situation, and looking at the vascular access sheath, patient was a little bit obese. Looking at the vascular access sheath, it was somehow steeper, and possibly it's kinked. So through this kinked sheath, she was trying to do all the things. So as it is not going and coming out, and also look at the sheath, there is some clot and blood is sticky. So trying to pull out the micro is not easily coming out. So fluoro shows the catheter kinked and twisted at the 7 French sheath just after the entry. Tried to pull out the microcatheter, but it's not coming. At this time, all the catheter, microcatheter, guide wires pulled out. Fluoro shows severe kinking of the sheath. So I abandoned the procedure for that day and scheduled it for as an investment procedure in the next day or after some time. After an hour, vascular sheath removed without any hematoma. So after 2 days, we started the case again through femoral road, and where easily passed through the previously created channel, and balloon dilatation done. .5/48 DES from ostia deployed, because after manipulation, the proximal part got injured. That's why we had to cover the ostia as well. So keeping a hanging wire, we ensured the ostia. Ultimately, the final result shows good. So, what is the lesson from the case? Stable and appropriate vascular access sheath is essential for any type of coronary intervention, not only CTO. For CTO intervention, operator needs to be more vigilant to the patient, hold devices introduced, and anticipate the possible complications. If blood becomes sticky, or wires or the microcatheter do not move as expected, needs to be checked everything rather than progressing forcibly. Halting the procedure and keep it as future investment procedure make their life easier. Thank you.
So I think you're right that your access has to be clean. So what we could have done, probably use longer sheath. So we could have used longer sheath instead of short sheath. So that could have been one thing which could have been done, I think.
Yes, the patient was exhausted and also operators exhausted.
Yeah, yeah. Thank you. But I think, I don't know whether your wire were intertwined, that's why the microcatheter was not coming out. Because it's unusual that through microcatheter is not coming out of a through a king sheet.
Because it was some
So
twisted.
maybe
That's why.
there, maybe the wire which you have kept in the conal branch, it might have got intertwined with your LED RCA main
Yeah.
branch. So that
Could have
may be the reason that your whole assembly could come out and
It's one of
microcatheter
the
was
possibility, right?
not coming out.
Thank you.
Thank you. Is Dr. Damodar Reddy is around? I will have a final check, otherwise we'll conclude.
Till then you can discuss about the do's and don'ts of the CTOs, what are the precautions we are supposed to do. Yeah.
I think
Precautions we are supposed to take, it is better for the juniors to.
okay, so madam is saying that till the time case is ready, we can discuss some do's and don'ts of CT intervention.
Writing and all you were saying.
Yeah. So I think the rules of CTO intervention are clear that the most important that reading the angiogram. So you should spend good time in reading the angiogram, how to plan, which if you are planning retrograde or antegrade, see, evaluate the microchannels, which channel you want to select. So reading the angiogram is very, very important when you are doing a CT intervention. Then selecting the access and having a good support. So you should not start half-heartedly. When you are starting a CTO, do it with that you have to use, or you may have to use all the technique. You should be well versed with all the techniques of the CTO intervention, integrate, retrograde. So you should not start as a ad hoc procedure that, oh, okay, I'll start and then see. So if you want to do a CTO, I think you should start with full backup. So using good support guide, and whenever necessary, use long sheets. When you find that CTO is tortuous, there's calcification, it's better to use good long sheets, and always use a bigger guide. 7 French is the minimum guide, I think, which should be used. Some of the cases we have seen that 6 French guide was used. So I think 6 French is not the guide for CTO intervention. It has to be minimum 7 French guide, because you might be using IVERS, you might be using exchange, not exchange, but extension guides or microcatheter, and sometimes dual lumen microcatheter, and sometimes you may have to use IVERS along with the dual lumen catheter. So I think we should use bigger guides, 7 French or sometimes maybe 8 French. If you are planning IVERS guided entry, dual lumen catheter, then 8 French should be used. And bilateral injection is must, I think, for any CT intervention. Even if you have ipsilateral collateral, they will diminish after you cross the lesion. Until unless you don't have any supply from the retrograde, then you may avoid. Otherwise, there is no harm using bilateral injection. That is very important, I think. And as in one of the cases, we have seen that you should be ready for any eventuality. So in one of the case, he was forced to do bifurcation standing. So you should be aware of the other techniques of other intervention.
Sir, always better that we go for an antegrade rather than the retrograde initially.
Yeah, I think antegrade, most of the cases you should always start, you should give a try antegrade. Primary retrograde only wherever you have a flush occlusion, there you can go primary retrograde, or already previously attempted PCI, or you have a lot of branches, proximal cap is blunt, there you can go primary retrograde. Otherwise, I think antegrade is a good option, and there are lots of now hardware has improved. You have good wires now, and you have good dual lumen, triple lumen catheter, and you have IVS guided guidance now. Good IVS have come now. So I think antegrade success rate has also improved to the tune of 80-85%. You can cross antegradely. Retrograde, I think it has its own problem. We should not think that retrograde is a very easy option. I think in your case, I'm sure it might be ischemia actually, because
The culprit vessel is an LED,
yeah,
so
yeah.
should have
So we should be
started
very
LED first
very
and then stage PTC to
cautious
RCA.
while choosing retrograde option. And then retrograde, there are sometimes retrograde options are not the good options, even if you have good collateral. Like if you find that the vessel, donor vessel, uh, is the only vessel and it will cause ischemia, then maybe we can avoid retrograde even in those cases, because losing a patient on table gives a very unsatisfaction, dissatisfaction to the operator. So I think that is very important where to choose retrogrades.
So imaging techniques either should be used initially for the puncture of the cap, or we need to wait.
No. I think it's not that you should always use IVS for the puncturing. If you have a straight segment, you have a stump there. But whenever you have a blunt stump and you have a good side branch there, so it's better to use IVS guided puncture. It will help you.
The role of the CTO in these patients.
CT.
Role of OCT.
I think OCT will not give much information. There's lesser data with OCT. Only if you have crossed the lesion, you have dilated, if you find there's a lot of calcium. For calcium evaluation, I think you can use OCT. Otherwise, IVS is a better modality in CTO patients. And another point is contrast use. Already you must be using very large amount of contrast while you're giving retrograde injection. So saving on the contrast, I think IVS is a better option rather than OCT. No, we don't do CT in all cases, but when you find that there is a tortuous T, you see tortuous T on CT angiogram, or you see calcification, then we do CT scan. Not in all patients, but in some of the patient we do get the CT angiogram pre-procedure.
In chronic renal failure, you prefer retrograde?
Chronic renal failure is altogether a different subset. I think there you have to take a call whether you really want to do PCI, or you want to send the patient for CABG, or you want to continue with the medical therapy. Some of these patients will do good on medical therapy. I think we should not say that we want to revascularize. Revascularize only for symptoms. I think if you have significant symptoms, that's the aim of angioplasty. You only improve the symptoms. So if patient is symptomatic, then revascularize. Otherwise, many of the patient will do well on the medical therapy also. So we should not underestimate the medical therapy, I think. So first operator has come or not?
He has uploaded the CDs, but
It's not running?
not reported again.
Okay. So I think we close this session now. Thank you everyone. I think we had a good discussion. We saw good cases. I think we must have learned from each other. So thank you all. Thank you very much.
Thank you, chairpersons, for sparing your morning time of the Sunday. And it was very excellent discussions with all. We thank once again your chairpersons. The next session will start at about 10 o'clock. We have a gap.
This should be visible. Excuse me. Can I have
তাহলে ওখানে আসছে আপনার কাছে, ঠিক আছে? আমি B2তেই আছি, ঠিক আছে? আপনার ফটোগুলো আমি পাঠিয়ে দিচ্ছি হোয়াটসঅ্যাপ। ও very less people.
Yeah, I think most of the
Most
people
of
have
them
gone left. Yeah.
Sunday.
Yes, yes. It's time for everybody's flight to.
Sunday everybody wants to be home.
Home. Yes. Yes. People are active only on Saturday.
So you are in Manipur also.
I'm in Udupi, Manipal, University Hospital, main hospital. Yeah.
Bangalore में भी कहाँ काफी जगह है अभी.
Yeah, now they have in a few
Pune
places,
also.
3-4 places. They are starting another one in a few months.
Where?
Bangalore. So I never say Manipal, I say Udupi, Manipal. Otherwise people will get confused.
Yeah, yeah.
Yes.
That is the first one.
That's the first one. So that is the Apex University Hospital.
So that had, because of that it is mushroomed.
Yes. So even when they start in Delhi, they call it Manipal.
So this is how many beds?
Ours is 2,000. And more than almost 100% or more than 100% occupancy, because the ICU beds are not included in the bed strength of the hospital. So it means more than
So we'll start after 5 minutes. Everybody is leaving.
Yeah, yeah.
Because Sunday.
But we have to do what we have to do. So
Yeah.
rather than waiting too long, we would rather have our own
Shall we
discussion
start,
and
sir?
then
Yeah, so after this. We'll go for the next session. I invite the chairpersons, Dr. Devasiya and Dr. Pramod Kumar Dhar. This session will be on turnpike and trap liner. I invite Dr. J.S. Duggal for his presentation on turnpike.
Good morning. We recently had the opportunity of having Turnpike with us, and it lasts about 4 weeks, no, 8 weeks. We have it, and we have used most of them. So Turnpike catheter, how do you go for? So CTO, which you have heard over the deliberation over the 2 days, you have various approaches: the anti-grade, the retrograde, and an anti-grade is you have the anti-grade via escalation, subintimal tracking, or you use a ADR. So the various methods, and whether you use an anti-grade or a retrograde, you have to use these support catheters. Now, the Teleflex and microcatheter they have is basically the Turnpike catheter, the Turnpike LP, which is for retrograde. Then you compare this when you have a wire. Unfortunately, these wires are not available with us. The banded wire, but this is they have shown that a banded wire, which is 0.8 grams, goes to almost 4 grams when you support it, and compared to a Corsair Pro, it goes to 3.6 grams. The Raider, which is 4 grams, can go to 13.3 grams as a tip load when you have near to the catheter. And similarly, Warrior, which is almost 14 grams, can go to about 32 grams tip load. So these catheters give a wire much more gram weight when you use them to go through a lesion. So what is Turnpike? So Turnpike is a dual layer coil. It basically got 5 layers. You've got a braided shaft design, a superior flexibility and torqueability for delivery in complex anatomy. So there are 4 types available. There is a Turnpike standard, which is a flexible tip for tracking in tortuous vessel. You have Turnpike spiral, which is of course rotational assisted trackability. Then you have Turnpike gold, which has got a metallic tip and is more for using for very fibrotic, and you can even go through a calcified lesions. And then Turnpike LP, which is low profile, which can be used for retrograde. So this, you see, you have a polymer only, like a transit catheter. That catheter, which is a fine cross, or they have only a polymer. Whereas only braid is for supercross microcatheter, which is angulated catheter. If you have a braid and coil, this is like Turnpike. So this become workhorse in complex PCI cases. Its torque response and flexibility, and external threaded coil adds rotational assistance. So these are the different. Now this is the 5 layers which I have said, which the Turnpike has. If you see the first is the tensile strength. Then the second is the liner. Inside there is a PTFE liner. Then there are you see three braideds over it, and this is a dual layer. Now this dual layer is very important to add the torque to the catheter. So this is bidirectional coil and this kink resistant. And then they have outer polymer. So these are the 5 layers. With this, such a small catheter having 5 layers improves its torque and deliverability. So the tip construction, if you see, is non-tapered section followed by a tapered section, highly flexible for guide wire tracking. Entire tip is tungsten loaded polymer for radio opacity, and PTFE lining extends to the distal tip for durable and wire movement. So this is the standard, which is provides ideal combination of robust torque. If you see cars, sports car, they have very high torque. So this is what it increases the torque to 255% if you increase torque if you rotate it clockwise. So the torque increases on clockwise rotation and pushing, whereas also it increases to 75% compared to Corsair catheter when rotated counterclockwise. As you know, Corsair, we always rotate it counterclockwise. This is clockwise rotation. So a standard version is the flexible tip, a workhorse anti-grade device with retrograde escalation device for increasing torque, power and guide support for resistant septal collaterals. This is what I have used number of times. This is termed Pike spiral. Now this is a spiral shaft with a flexible tip. Now this is 3 centimeter external nylon coil on a distal shaft, and this nylon coil adds rotational advancement assistance when rotated in a clockwise manner. This is gold. Now gold is basically, it's got a metallic tip, and it is only used for highly resistant lesions which are not crossable, and you want to use it and change to whatever strategy you have, maybe a rotational atherectomy or. So this is a leading edge rotational advancement in challenging lesions. Nylon coil adds to the rotational advancement assistance when rotated in a clockwise manner. So this is LP, which is basically used for retrograde. This is the same multi-layer available in both the sizes, 135, also 150. This is a dual layer coil, tapers to a single coil at the distal 21 centimeters for distal tip. Benefit is 15% reduction in crossing profile compared to Turnpike standard and Corsair catheters, and increases distal tip and distal shaft flexibility. Maintains comparable torque response to a larger Corsair even in smaller crossing profile, even with smaller crossing profiles. So this is the LP. You see, this is a little different. If you see, it's tapering, and this also has the layers at the same time, 5 layers. Now this is the different product specifications which are available: LP, spiral, and gold. But you see the spiral, the distal tip OD is 1.6, whereas gold is little more, 2.1. Now this is what adds to the torque, and if you see the chart on your right side, the static friction force and the dynamic friction force. Now this is very important for tracking down the catheter. Now this is one of the I can show you animation. Sorry. So this is the animation of how this device works. Just small, so this, tortuosity and highly stenotic creates a friction which can prevent catheter. So by torquing it clockwise, you can see how it crosses. So this is the most important aspect of you can see while rotating. So it's most important to do simultaneously. While you are rotating, you should push. Not rotate and don't push, or push and don't rotate. So this should be simultaneous process, and therefore This is what I said, 5 layers. And this layers, I have a locking mechanism. You know, you see, this is how, when you rotate it clockwise, the outer coil and the inner coil expand, and therefore it increases the torque. And that is the most important aspect of this catheter, and therefore it is highly deliverable. So these are the 5 important points. So first is you focus on spinning the catheter to facilitate torque, not relying only on push. The Turnpike Standard and Turnpike LP provides torque response that can rotate both in clockwise as well as counterclockwise fashion. Replace device. Now this is very important. When you're rotating and you're pushing, if the wire gets caught, so you see that the wire remains free. So if there is a movement of the guide wire stops, that means you should stop and see what has happened. So that is the most important thing. And Turnpike, spiral and gold catheters are rotated clockwise to advance and counterclockwise for removal. Do not move more than 10 times in one direction. That is another important aspect. And alternating direction of rotation on Turnpike Standard and Turnpike LP catheter, releasing torque buildup when against significant resistance, is a good practice. So this is how it is rotated, which you have all have done in Corsair, but this is, you can see how it is rotated, this catheter. So you, near the valve, you have the left hand, which is important for pushing, and for the right hand you torque it. And this should be a simultaneous process. You see this? This shows how to advance it, and that is how to also bring it back. So this is very important. Both should be done simultaneously. And in between, you keep on checking the wire movement is there or not. If the wire is getting stuck, you should consider review what has happened. So this is the few cases. This was a radial artery anastomosis, which had a total occlusion to the anastomotic side, and we could wire it with a stabilizer wire and Turnpike spiral, beautifully with clockwise rotation. It crossed, and then we could, achieve dilatation and stenting of that anastomotic site. Now this was a very tortuous LAD, and it was calcified, and we wanted to do a rota, and we could not cross it. So here we used Turnpike Gold over UB3. We crossed the lesion with UB3 wire. Turnpike Gold, it took a little time, but we could cross it. And in the last, you can see we exchanged the rota wire and did rotational atherectomy in the torches with a 1.25 bar, and we could achieve a good result, and we stented this. Thank you.
Thank you very much. Excellent presentation, Dr. Duggal. A couple of doubts for the sake of the audience. Because it is newly launched in India, I'm very sure many of the operators have not used it. So there are a few Turnpike series of catheters. So if you would recommend one of these series to be available, which would you recommend?
The Turnpike spiral.
Turnpike spiral.
That is the workhorse, But if that is for antegrade. If you retrograde, then LP. So these Turnpike spiral and LP, both catheters should be available. And if you have a difficult lesion where you cannot cross very, fibrotic, probably then you have to use a Turnpike Gold.
So for a fibrocalcific lesion, we have used in our labs, we usually keep Corsair series, the Fine Cross, and the Caravel. So suppose there is a fibrocalcific lesion, which among these series would you choose, or would you give preference for the Turnpike series, Turnpike Gold?
It's very fibrotic, very narrow. Probably these Caravel and Fine Cross won't work. Probably then you need one of the catheter where you can rotate it. And out of the two catheters, which has rotational and pushability, we have the Corsair, and now we have this Turnpike. But Turnpike Gold, I would say, where you're using your Tornus, where is a calcified torches, you cannot, like Tornus we use sometimes to, deliver a rotational wire or rotational atherectomy. Probably that cases, probably you can compare with Gold. Otherwise, spiral works in most of the cases.
Excellent. Thank you very much. One more final question. suppose somebody has Corsair, Fine Cross, and Caravel in their lab. Would you recommend Turnpike as a substitute of any of these or as an additional catheter?
It is at the moment additional, and probably when you get used to it, we are very used to Corsair catheters in our lab, and I've been using Corsair for many years, but now I've started using it. I find it very good, and if you have in this lab, because torque transmission is very high, if you have it in lab and you consider all the steps properly doing it, so probably it's a good catheter to have in lab.
Yeah, so it is, as per your suggestion, it is good catheter to have, maybe as a substitute or when there is availability problems or when there is cost issues. How is the cost of Corsair versus Turnpike?
That you can.
What do you say? What is your price of?
We don't have anybody from Teleflix.
Oh, okay. Oh, okay.
You can wait.
So it's competitive pricing and rather economical than the Corsair catheter.
Okay.
The MRP varies from around 35,000 rupees to
45,000.
Okay.
52,000.
So Turnpike spiral cost would be MRP of?
MRP of Turnpike pipe will be around 47,000.
Okay.
So it's less than the Corsair.
Any other doubts from anybody? So thank you, Dr. Dugal. It was an excellent presentation. We all enjoyed it. One more talk, Dr. Pratap is not available. So we'll close the session then. Thank you very much.
This is a new device.
You want to show because I have not seen the slides at all.
I know I have not seen the slide, but there are slides here. So
Trapliner company, anybody is here?
Yeah,
Yeah.
we are here. So can you please have Dr. Pratap Kumar's present? Yeah, Dr. Gupta.
That's okay, he will present.
this is got some. So we are using, basically catheters where when we have to remove, we have to exchange the catheters, we do a balloon entrapment. So this catheter has got a built-in entrapment. So this is the advantage. Just show you this. Now after doing a procedure, now this is a trap liner which is going across into the, so this we are using lot of catheters, but this catheter has, on that wire it has got a balloon. So therefore, when you have done your work of a guide liner or any other support catheters, when you see this, when you have crossed, you have done. Now the removal, you have to take another balloon and remove your hardware. But this has a balloon which is inflated, it entraps the wire which is going, and you come and remove. So without using a trapping balloon, here you can do most of the procedures multiple times, and it's a very good, if you see the end of this has got, you can inflate through that wire, a balloon inflates and it traps the. So this is an advantage of this, and it is shown in how you can remove it. There is an animation there.
So just go back and replay it.
So this is the, how it is made. There is a micro catheter, there is a balloon. Now you can see it play. So this is the, so you have taken over the wire and then you want to remove it. You can, you can see a trap liner holding it, the wire, and then you take whatever you want, crosshair, fine cross, turnpike, whatever you have taken. And while taking it out, again you can do the same thing. Now it is out through the, now here you trap it again. It's trapped again and you remove it. So basically, the whole process becomes easier. And then you can go ahead and do your angioplasty. So this is instead of you having two, one catheter and one using a separate balloon, this is 2-in-1. That's what I think. Built-in trapping balloon. Yeah.
So, what is the cost of this? Company people are there. You can.
Yeah.
So the MRP is 55,000.
Hmm.
Yeah. So it's a combination of a trapping balloon and a guide extension catheter, both the devices together. Yeah.
This is a very good picture showing both. So this is a 6 French, that is 18 centimeter, and this is a trapping balloon.
So you have to use it with a 7 French guide, or it goes inside a 6 French guide.
6 also it goes, but 7 more
7 is comfortable. Okay.
Yeah, it's 6 French compatible, but you can anyhow use it with whatever you feel like. Yeah. So it comes in 3 sizes: 6 French, 7 French, and 8 French. All the 3 sizes are there. But at the moment, I mean, looking at the requirements, so we are just promoting 6 French at the moment.
We have it only 6 French in our lab at the moment.
Yes, thank you very much.
I thank Dr. Dugal
Yeah.
and Dr. Devasia.
So we take a group photo. If you can also join us, sir. You come. Thank you.
Thank you.
Thank you. No, B2. B2. तेरा क्या है? To be or not to be? To know. Large bore access. नहीं नहीं नहीं. 10:30 बजे कुछ था. B2 में ही है ना? या B1 में है? कुछ पता नहीं. Next is IBL, no?
No, B2. We have ministry
Transfer. So then I'm B1.
Transformer से भी कोई भी नहीं है. Speakers.
Yeah, cut and crack. Correct. IBL.
Cut and crash idea do that.
Yeah, you'll see as it goes.
I just saw that.
I saw something. Where is SMT? Transrubina भी बाहर था.
Transrubina और बाहर है. Should I call someone?
Yeah, yeah, call it.
So Dr. Anuj Kapani is also not here. He is not taking interview, and his presentation is also there. So probably is not coming.
We'll go with the doctor.
Chairperson, people chairman.
We start the next industry symposium. I invite Dr. Jayanti to take as chairperson, and the speaker is Dr. Ajay Swami. Cut or crack, IVL Bay launch. I invite you.
Morning, everybody. Can I see the slide on the screen, please? Fantastic. So before I begin, my salutations to my teachers who are not in the audience. So we're just going to look at best practices using IVL. Coronary calcified lesions are an unmet clinical need and represent the largest cause of an unsatisfactory PCI result worldwide. Now, what to do about this calcium? We've been working on it especially for the last 25 years or so, especially more in the last 5 to 10 years, because this represents the most important and the commonest cause of PCI failure in the short term, intermediate term, and long term. There's a safety risk, doesn't allow the stents to get delivered, it doesn't allow the stent to expand, it doesn't allow the drug to elute properly. Now, lithotripsy is a new technique that has come about in the last 6 years or so. There's no requirement for a specialized wire. The same coronary wires that we're used to can be used. The shock waves are selective for disrupting calcium. They're not going to touch any other part of the anatomy except the calcium. They pass through the plaque and vessel wall and enable modification of deeper calcium, for which we actually have no other tool. Calcium can be superficial when it's close to the intima or deep when it's close to the adventitia. When it's deep, it's going to impede the expansion of the stent. But apart from IVL, we have no other technique to modify this calcium. And the disrupted calcium actually then becomes a kind of a soft toothpaste-like material, which remains within the vessel wall, and there is no distal embolization. All the other techniques that we have for atherectomy, that is the rotational atherectomy as well as the orbital, is going to fragment the calcium into tiny particles which can go and block up the microcirculation and cause a significant problem with no reflow, the greater the amount of calcium that's there. But this particular technique doesn't allow the calcium to embolize. It just softens it and leaves it there and allows the stent to expand and gives the best possible result. It allows calcium modification at very low balloon pressure. So you can actually control what size of balloon you need to deliver into the particular lesion. You're able to protect the second side branch with the second wire, which is something you can't do with any of the atherectomy devices. That means if you have a bifurcation lesion at the left main and you have to do a rotablation, somewhere at the back of your mind or an orbital, the back of your mind is always the fear if the side branch ostium is badly diseased, because you can't put a wire because the rota burr is going to cut off that wire if you go past it. So these are all the advantages of the intravascular lithotripsy. It is safe. It doesn't require much of a learning curve as far as delivery of the hardware is concerned. The only question mark is that you need to prepare the vessel enough to deliver the balloon there. This is something basic that we all need to know. The balloon has the emitters, which are 4 millimeters and 2 millimeters from the two tips, 4 millimeters from the distal tip and 2 millimeter from the proximal tip. And that's why when you have to ablate a long segment of the coronary, your overlap has to be modified accordingly. It's not just from the marker to the marker. You need these 4 millimeters to be accounted for as well. And these emitters must be as close to each other. That means about 6 millimeters apart. So your third emitter or the position of the third emitter, which can easily be seen on the stent enhancement mode in all the 3 labs. And thus the optimized overlap is 2 millimeters. That means you don't keep the marker to marker. You keep a 2 millimeter at least overlap between one balloon position and the second balloon position, which you must memorize. The working length is 12 millimeters from the inner edge of the marker bands, and the 6 millimeters between the emitters ensures that this is where we get the maximum modification. The acoustic pressure declines about 3 millimeters away from the emitter, and that's another important consideration to remember. And there's a smooth energy profile over the center 12 millimeters. This is the data that we have got that shows that IVL actually works and that we end up delivering better results in the short term, intermediate term, and long term. Short term as far as stent thrombosis is concerned with gross underexpansion, intermediate term as far as the expansion is concerned, and in the long term as far as in the intermediate term as far as safety is concerned, and the long term as far as efficacy is concerned, because you end up with a larger luminal area and you end up with a better lesion at the end of it. Now this has been shown both on statistics as well as on imaging, and you can see that the calcified length is also not short, it's 43 millimeters, and you end up with an excellent 103% stent expansion with 0 procedural complications So there's an early excellent 30-day safety and efficacy, and unique, the IVL achieves consistent excellent MSA and stent expansion across all arcs. It can modify nodular calcium. One of the criticisms of the IVL was that it would actually work in eccentric and concentric calcium, but it wouldn't work very much in nodular calcium. But this has also been proven to be inaccurate. Nodular calcium is actually modified very, very favorably by IVL. You can see the cracks and you can get good expansion with the IVL balloon. With expected higher acuities, vascular compliance is also restored when we soften this calcium, especially in eccentric calcium distribution. And because of its safety profile, both genders benefit equally in severely calcified lesions. I'm going to show you some examples. These are extreme examples, but they don't summarize where it can be used. So this is a 78-year-old lady who had presented with cardiogenic shock, and when the first time was brought to the lab, had an occluded circumflex, they managed to wire it and deliver a 1 millimeter balloon across the ostial circumflex, but nothing else would go. An IBP was placed. She was shown to the surgeon because her BMI was 17.5 and she had multiple comorbidities. The surgeon ran 20 miles in the opposite direction. I am not going to touch this patient with a barge pole. And so she was referred to us, and you can see that this is a heavily calcified left circulation with a left dominant circulation, non-dominant right, no protection at all from anywhere. And the calcium is distributed extensively from the left main into both the LAD and the circumflex, and the circumflex is retroflexed at 120 degrees. Now this is an extremely difficult anatomy even without the calcium to negotiate. But the addition of this calcium makes it very, very challenging. So this is what we did. Our bailout was first to get a good flow into the LAD. So we wired it and it realized there's a lot of calcium, and then did a rotablation for the LAD, mid to distal LAD, and then did an OCT run. And this was very important because it showed us exactly where the problem was and what was the distribution of this problem. You can see the distal part has been ablated well, but as we come into the proximal LAD, you see this thick circumferential intimal plus deep calcium, especially where we come close to the proximal LAD. Here the thickness is more than 1000 and it's really deep. The rota has not done anything to this part at all. So we're pretty much stuck after this because you've ablated the mid to distal LAD. So this is what it shows us. We've got some crack in the distal part, but there's a nodule post-rota. This is superficial circumferential calcium. This is our distal reference diameter. That means the distal part has been ablated well. But if you see the proximal segment, it's very, very heavily calcified and very, very large calcium, and there is a huge eruptive nodule, very eruptive calcium, very close to the ostial circumflex. This is what the map shows us. So since we needed an outflow into the LAD, hemodynamics were unstable. So we put in an IVP and finished the mid to distal LAD angioplasty, right? Now after that, we started working on the circumflex. This is a retroflex circumflex that has been wired with an XTR. We sent a microcatheter down, and it is so badly calcified that no balloon would go. So then we went ahead and first did a rotablation. Now this, I've just summarized the views, but you can see how difficult it is. And we have done a half rota, gone millimeter by millimeter. This has taken nearly 13 millimeters of burring. And then finally we have crossed, and then after that exchanged that for a support wire with a microcatheter, and then started working on this and did an IVL to the LAD, the left main and the circumflex, and then did a DK crush for her. In the conventional way, this is the first stent being delivered with an anchor, being crushed, being kissed. This is a recross, the second kiss, again the LMLAD being prepared, the stent in the LMLAD deployed, the pot done, the recross, the rekiss, the repot, and that's our final result. This patient is now about 24 months, 2 years post-procedure, and she's absolutely fine and stable. LV function has become normal, and she's become a real pain for her family because she keeps telling everybody what to do all the time without cessation. This is our final result, which looks perfectly all right. This is a second case that was attempted outside, and they have failed because they tried to use their NC balloons, and they've gone to 24 atmospheres, and the mid RCA simply wouldn't open. And the left circulation was normal, but you can see heavily calcified RCA with throughout its entire length. So after a small pre-dilatation, this was just to deliver the OCT catheter because even the OCT would not go otherwise. This is the OCT, and we'll just let it run through before I summarize it. We don't have a second speaker, so I'm just going to take a little bit more time others. So you can see that there is extensive superficial and thick calcium right across, especially in the two segments here and here. So arc depth of 360, a depth of 1000 microns, circumference of 360 degrees with an eruptive calcium nodule and a depth of more than 1000 microns in 3 places in this RCA. So first, this is what we used. Now we know what size of the vessel is. So we've used a 3.5 into 15 IVL and then dilated it all the way through. This was in the days before we had the 120 pulses catheter. This is the 80 pulses catheter, which was improved, but still there. And then we did a post dilatation and then did a second OCT pullback. And this is also revealing because if you look carefully, you can see the fractures right across where we've used the IVL balloon. So from the beginning, especially in the Morse calcium, those are all the fractures that you see, even around the eruptive nodule. So we'll play it again. Yes. That calcium you can see being fractured. That's another fracture. And this is what it looks like. You can see fractures all across. Now this tells you that the lesion has been prepared adequately. The fracture tells you that your stent is going to expand. There's no problem. And this is the comparison before and after in the same segment, and you can see the breaks in the calcium that we see in the OCT after we've put in the IVL catheter. Now we've used a 315 in the one place where we did not see calcium, and that is why it is important to assess the OCT carefully, because it will tell you where you have done a good job and where you have not. So the post-IVL OCT run in heavily calcified lesions is very important. We've gone ahead and used an OPN 315. So we normally downsize the OPN when we are using it inside a segment which is heavily calcified, because there is a significant creep in the balloon beyond 20 millimeters. So the creep is the change in size as you start increasing the size. And we have gone to 50 atmospheres with this balloon, and you can see on the right side of the screen that there is some acceptable expansion. And then put in a 3.538 and another 3.538, and then post dilated it at high pressure, and then again did an OCT pullback. And this looks perfectly well expanded except in one place with no dissection, good apposition. So you'll still see the calcium behind the stent, but now it is soft. So it's allowed the stent to expand. If we hadn't done this, they were even unable to get even a 315 balloon to expand at 24 atmospheres with a significant waste. And this is our final result after the post dilatation, which looks perfectly well, and the patient is free from all angina. This is the third case, a 71-year-old hypertensive dyslipidemic crescendo angina for 4 weeks on maximal medical treatment, outside angiogram done, reported as calcified left main bifurcation and advised surgery, refused the same. This is what his angiogram is like. And you can see a heavily calcified left main bifurcation, calcium extending more into the proximal LCX, into the proximal LAD, and one segment in the proximal circumflex. So this is our pattern. This is what we do. We did the LCX OCT run, and you can see an eruptive nodule there before it comes back into the left main. I'll allow it to run again. That is the distal normal segment. That's the calcium beginning. That's the eruptive nodule. Yeah, that's the eruptive nodule that you see at the ostial circumflex, and then the left main. And the same thing that we saw earlier, I've just summarized it in single images. This is the distal landing zone, followed by where the calcium begins, the eruptive nodule that is encroaching into the lumen, a 180-degree arc of calcium at the bifurcation, and the left main size. And this is the OCT into the LAD. Again, we let it run. There you see circumferential calcium here, from the mid to the proximal to the ostial LAD, and then the left main where there is some calcium at the distal part where the proximal part seems to be perfectly all right. This is what it looks like, and this is what we've got. A 360-degree arc of calcium with 1000 microns thickness in the proximal LAD. This represents really thick and hard calcium. This is another one of the places where the rota is not going to work, because there's a decent size of vessel that's there, and the rota will just pass through and come back. It's not really going to modify this vessel much. You need something that is going to break this calcium and allow the stent to expand. So after initial dilatation, this is our IVL catheter. This is a 120 pulses catheter that we've used for the ostial proximal circumflex. And you can see this is a perfectly good expansion that we've got after about 30 pulses or so in the same place. It recoils, but at least it expanded. And then that's the LAD. We had to work a little bit to deliver the LAD balloon, but it's worked perfectly well. There was also a subtotally occluded diagonal, and we've just done a ballooning to that diagonal that you can see on the right extreme of the screen. We didn't want to put a stent there, so we've just ballooned it and left it as provisional, that part. And then did a DK crush. This is our first stent that goes into the circumflex. That's expanded. We pull back and do a good ostial expansion. Then we do a half kiss, then the first kiss, then the crush. Prepare the LAD properly. Circumflex is again kissed. Then the LM LAD is stented, as you see on the right side of the screen. And we elected to use 2 stents because there was a significant size discrepancy between the LAD and the left main, and we didn't have the stents that could reach that particular size. So we elected to use 2 stents and overlapped it in the proximal LAD where we had modified it. This is the LM LAD stented. Did a pot and then the kiss and then the repot that we do in 2 places. This is the circumflex run. In one place we found a little under expansion, which we corrected later, but the ostial circumflex and the bifurcation looks beautiful. And same thing for the LAD. Now the thickest part of the LAD where we had really heavy calcium, you can see how well that has expanded, where we had in fact chosen the overlap there, but our areas are excellent in that particular area, in that particular segment. And this is a very good expansion, and you can see how we've got good expansion in the distal left main and the ostial proximal LAD, which was the most heavily calcified part. This is what the bifurcation is. We don't have any strut across it. We've managed to open it perfectly, and that's the left main. This is our final result. I'm sorry, the right side, there's something gone wrong with the video. It's put the whole lot together from beginning to the end. Thank you for your attention, and I should be glad to answer any questions.
Very well presentation and very good job done, sir.
Thank you.
So IVL has become a recent, very advanced calcium modifying management like. So in the first case, sir, you have used a rota before.
What we call
so
rotatripsy.
So how often you're doing it? Like for what cases? Like you do rota first and then IVL?
So the role of rota in where the IVL is available is mostly for us to enable delivery of the IVL balloon. And this is a slightly more bulky than a normal balloon. It's much better than what it used to be, but it's still a little bulky. And also we don't want to damage the balloon when we deliver it. So when you have a subtotal occlusion that's heavily calcified, sometimes the IVL balloon is going to find it difficult to cross. So if you have access to the IVL, the only role for rota is to permit the catheter to reach where you want it to reach. But having said that, the patient hasn't read the book. So you must always try to see, but as a rule of the thumb, if you can deliver a non-compliant balloon that is 0.8:1 size, then the IVL balloon will go. There's no problem. Additional tortuosity, especially in the circumflex and the distal RCA, beyond the C of the RCA, you sometimes need a guideliner. But in my hands, the rotablation is, since I've been using it for more than 10 years now, and I'm really comfortable and confident with it, I use it now only to deliver the IVL balloon. So I think you have to study the calcium and the distribution in the individual patient. If you have intimal calcium that's about 1000 microns and your imaging catheter shows that the wire is going through the calcified segment, then I would do a rota and then use a 1:1 NC balloon dilatation, see in 2 orthogonal views. If it is expanding, you can just do an OCT and decide whether that's good enough. If it's not expanding, you need to use the IVL. Some patients you see upfront tram track calcium without any contrast in that vessel, we have got to use IVL. So if the IVL balloon will go straight off, you use it right at the beginning, like the RCA that I showed you. Vessel size was very large. The rota is not going to do anything at all there. So you need to go ahead and straight away do the IVL. You just have to decide whether you can deliver the balloon or not. So work on it a little bit, deliver the IVL balloon. I hope that answers your question.
Yeah. So what are the precautions we are supposed to do, especially with tackling left main with the rota? And
Okay, left main with rota for precautions mostly are with when you have to burr into the circumflex. So when you have to burr into the circumflex, it's a little challenging with rotablation because the burr has a tendency to go along the outer curvature when you go. And very often calcium is on the inner curvature. So you try to push it, it will go on the outer curvature, it will exit the vessel. So we don't use extra support wires across the ostial circumflex ever, because that permits the burr to remain in the center as far as possible, and we take the stretch away from the wire at the time of delivering the wire so that the burr is able to center exactly. If you saw the example that I showed you, we have kept the guide in the aorta so that the burr is able to turn 90 degrees, because it was 120 degrees. It's an extremely challenging rota, and I don't recommend anybody to start with that kind of rota. So I turn the burr down, and after be extremely patient. For other segments, we go 5 millimeters at a time when we peck. But when we do the ostial circumflex, I will go 1 millimeter at a time. And you must pay attention to the speed of the burr. I mean, I usually have some music playing in the background, so I fix the frequency of the burr at which the music is playing. So it tells me if I'm at sa, pa, sa or something. So it will tell me when it is decelerating so that I can hear what is happening. And if it decelerates more than 10,000, then I will come back and then restart again each time. It's impossible to tell you all the tips and tricks in a few seconds. But remember, in that patient, if we had not managed to do the rota, the IVL balloon would not have tracked. And so the role of the rota was essentially to ensure that the IVL balloon tracks. Because the OCT of the left main had shown us that there was a huge calcified nodule at the ostium of the circumflex, which would have been impossible to modify with any other technique but the IVL. So, I mean, I tried to throw 3 examples. I've picked on 3 different situations. There are certain others in which we can use. I tried to show one rotatripsy. I tried to show one big vessel for which we use an IVL. And I tried to show one left main bifurcation for which we used IVL alone, because the IVL catheter will easily track with a little bit of support. And how in 3 different patterns of calcium, diffuse, superficial plus deep, concentric deep calcium, and an eruptive nodule. In all 3 situations, the IVL functions extremely well. Imaging showed us the pattern and the distribution and whether we have done a complete job or not. So
it was a good result after IVL. Thank you.
I have a question. Suppose you have not prepared the calcium bed properly and your diluted stent is not expanding. Okay. Now we can use IVL, and what will happen to the stent? The polymer will get damaged, or some idea about it?
Yeah, it's a great question, and this is probably regret, stenting regret, what we used to say rota regret is now stenting regret, because IVL represents, I've done it 4 times. That means when the stent has not expanded, that I have put in an IVL balloon inside it, and the IVL has worked all 4 times. There has been some work on what happens to the stent. The polymer does get damaged, the stent does get damaged, but it's better to have an expanded bare metal stent rather than to have a grossly underexpanded drug-eluting stent inside that segment. Especially if the calcium is eccentric, it's an even bigger problem, because if it's eccentric calcium and inside that you put in an OPN and expand it, your likelihood of perforation becomes dangerously high. So I think it's a great option. What we used to do earlier was to burr with a rota, because the heat created by the rota would sometimes make it soft enough for us to be able to expand it thereafter. But with the IVL, you just IVL it, do an imaging. If you have a fracture, put another short stent inside it and leave it. That's what I would say.
Did you use for ISR, sir? IVL, yeah.
So I did have one case which I've edited out, but this is a case I had done outside in Vijayawada. Patient had undergone stenting to the RCA. Somebody had put one stent. It had not expanded. They didn't realize it. Inside that, they put another stent. And even that did not expand. And then he came with a completely occluded RCA. So we have crossed that. First done an NC balloon, then done an OPN. The OPN did not expand, so we took it out at 20 atmospheres. I knew that 2022 it is not expanding. Inside that, we have put in an IVL and delivered all 80 pulses at the same place. And then after that, put back the OPN balloon and then expanded it, and then run a drug-eluting balloon. It still didn't fully expand, but our areas were like 5.1, 5.2 millimeters square. So that's the best possible chance. So you can use IVL, as long as you have calcium that you're going to modify. It's not the stent that's going to expand, it's the calcium that becomes softer. The only thing is that the ability of the emitter to reach that calcium is modified by the stent in the way. And that's a little bit of an issue. So I mean, there's no way around it. Once you put a stent inside if you're doing it acutely, it's fine, but later it doesn't work all that well. It's the only tool you have.
Okay, sir. Thank you, sir.
Thank you.
Very well present.
Thank you, Dr. Ajay and Dr. Jayanti. We'll go for the next industry symposium, that is vascular access. Do we have Dr. Abhishek or Dr. Sudhir Goganti? I invite Dr. Abhishek for his presentation on large bore access management, and I request Jayanti to continue as the chairperson in this session also. Please.
Actually, chairpersons are there in hall A. I called them. Everybody said there. Other than We'll call them again. I'll call them again.
seemed like I broke something. We come to the last industry symposium of vascular access. I invite chairpersons Dr. Manoj Kumar Agarwal and Dr. Jayanti to join. Please take the chairs. We have one presenter, Dr. Sudhir Koganti, and we'll go with angioseal first, and then will be the Dr. Abhishek. Please come. If Dr. Abhishek is here, we can also. Anup is there. Anuj. Come on, please come. Dr. Kapardi, Dr. Manoj Kumar Agarwal, Dr. Anuj Kapadia, Dr. Anup Agarwal, and I invite Dr. Jayanti also to join them. Please, Dr. Sudhir.
Good morning all, and thank ijcto2024 for giving me this opportunity to talk on angioseal. How many of you use angioseal? Yeah, we all do. I think with the TAVI going with one ProGlide and one angioseal, the way we're going minimal angioseal usage seems to be increasing in India. Back in my days in UK, I'm sure that's probably Anup's experience as well. Even angiograms we used to angioseal in the UK, 5 French, 6 French, everything was vascular closure device because we never used to manually compress because of lack of workforce really, which is not a problem in India. So which is why a lot of us for angiograms and even for PCIs use manual compression, but in the next 15 minutes or so, I'll try to make a case for angioseal. So when you look at vascular closure, there are two types, active and passive. By active, I mean it's ProGlides, things like ProGlides, sutures, clips, angioseal kind of collagen-based plug devices. And by passive, I mean manual compression and also devices such as FemStop. I don't know how many of you use FemStop. FemStop is a kind of device where you, it's a kind of concave disc-like thing which you put on the puncture site and then inflate the bladder to, usually 60 to 70 millimeters of mercury, or maybe sometimes up to the systolic of the patient. It does the job, but it gives you a false sense of security. For example, if somebody is bleeding retroperitoneally, they continue to bleed where you don't see what is happening externally. So you do have these kind of issues with passive closure devices. So this is what I mean by manual compression, which is what we routinely do. And assisted manual compression is devices such as TR band, Helix for radials, and devices such as FemStop for femorals. And then we also have this hemostatic patch. And then you have vascular closure devices such as ProGlide and angioseal. So manual compression is basically not reliable. It depends on the training, and it varies from person to person. It's not uncommon for us to see, despite of this, regime, to see patients with hematoma and also bruising. And also don't forget patient discomfort, pressing somebody for that long, they tend to become vagal usually, and then you're running around trying to give atropine and such. So let's look at angioseal in detail and look at the anatomical considerations. We all know the femoral triangle and anatomy. The one thing which you need to worry about when you look at femoral puncture, and also in terms of angioseal or any vascular closure for that matter, is location of the inferior epigastric artery. So I think you would be able to do that in avoid injury to the inferior epigastric or get an accurate puncture site, which is right on the femoral head by doing fluoroscopy. But those who use ultrasound would know, when you do a femoral angiogram, just puncturing based on the fluoroscopy has also got its pitfalls. Not always your bifurcation is at the level of the is below the femoral head. Sometimes it is at the femoral head. Sometimes it's also above the femoral head. When we audited our patients in UK at the time, I don't have the data to show it to you, but in about a quarter of the people, it's not below the femoral head. So you can only improve the accuracy of the site of the puncture, I think, by using other techniques such as contralateral fluoroscopy with dye, or by using ultrasound, which we're commonly using these days for large bore access. And this is further, schematics showing the inguinal anatomy and the kind of puncture site where you need to get to avoid inferior epigastric if you're not using any ultrasound or just based on fluoroscopy. So by and large, if you can puncture on the top of the femoral head, things are usually safe. Even if something goes wrong, you could always compress adequately. And then other patient considerations. Before starting a PCI, always it's a good practice to do femoral angiogram. We used to do femoral angiogram after the PCI. By then, if you have done some injury to any of the vessels, you've already given full dose heparin, you've completed the PCI, it's probably a bit too late. So I think the best practice is probably to do, if you're doing any complex procedure or using 7 or 8 French sheath for PCI, I think it's good practice to take a femoral angiogram upfront before you even give heparin. And ensure the vessel diameter is more than 4 mm. Anything less than 4 mm is a contraindication for angioseal. And make sure the vessel site where you're puncturing is actually healthy with no atheroma, stenosis, or calcification. And puncture site should not be located at the bifurcation. So you do have another device called ExoSeal for below the bifurcation punctures. We don't have that available in India. So these are the pictures showing the deterrence before starting a PCI, and also kind of if you're considering angioseal. Small caliber vessels, calcium, if you have a lesionate insertion, and also if you puncture below the bifurcation. So and then a quick tip to know the size of the vessel, how you could. If you divide your sheath French size by 2, then you would get the inner diameter. Inner diameter is usually, for 6 French, is usually about 2 millimeters. And then if you can guesstimate, if the vessel is double your sheath, then you know it's about 4 millimeters. So these are the considerations for angioseal. Like I said, most of them I covered already. And one other thing which I would like to mention it here is, if you have done double or multiple punctures, then don't angioseal, because you would have closed one hole, but they would bleed from the other hole and cause issues. And then these are the various lists of access site complications which could happen. We've all probably have encountered any of these at any stage in our practice. Ecchymosis, hematoma. Hematoma is usually a problem if your puncture is below the bifurcation. Pseudoaneurysm is also a problem usually if puncture is below the bifurcation. AV fistulas, retropetal hemorrhage happens usually if your puncture is above the femoral head, usually due to injury to the inferior epigastric artery, thrombosis, infection, and arterial dissections. And usually most of these could be minimized by using angioseal and ProGlide kind of devices. And we all know the implications of access site complications, increased hospital stay, blood transfusion, surgical repair, and so on. So who are at risk of access site complications? Anything that puts the patients at risk for high-risk PCI, the same kind of cohort, females, obese patients, those who've got background of hypertension, older patients, coagulopathy, peripheral vascular disease, CKD, because they're prone for more calcification, and also those patients who are on anticoagulants and antiplatelets. What are the deterrents or the restraint in terms of adoption of vascular closure devices, particularly in our setting? I think most of the time it's cost. and then after that, it's probably about training, and most of our protocols have got manual compression. I think it's the resistance to move away from that which stops us from adopting this practice. What are the goals of vascular closure device such as AngioSeal? The main one is reduced time to hemostasis and ambulation. And it would encourage the same-day discharge or early discharge. I know most of our patients stay in overnight after PCI because of insurance issues, but at least we could ambulate them very early rather than compressing the femoral artery puncture site and keeping them in bed for long, and also keeping them nil by mouth for that long. It saves a lot of nursing time and technicians' time, and reduces access site complications, and also improves patient satisfaction. So there are two types of AngioSeal devices available. One is AngioSeal VIP, and the other one is AngioSeal Evolution. You have this available in 6 French and 8 French. So if you do a 5 French PCI, you will have to upgrade to 6 French AngioSeal. If you do a 7 French, then you have to close with an 8 French AngioSeal. And these are the kind of segments which is used routinely. We will concentrate on the interventional cardiology segment. In terms of positioning, it provides hemostasis via dual security. Materials are all bioabsorbable, and ability for immediate arterial restick, and simple ease of use and practice deployment with AngioSeal. And these are the 3 easy steps. You locate the arteriotomy sites by looking at the bleed back from the sheath, and then set the anchor at the arteriotomy site, and then deploy the collagen plug at the top, which seals the arteriotomy site. And it is beneficial in these groups of patients: older and less healthy, patients who've got bad backs and unable to stay flat for longer, and those who are on coagulopathic and are on anticoagulants and such. And probably in patients who are obese as well, because it really gets difficult to get on top of the femoral head to compress with manual compression. And what are the technical specifications? So as I've shown in the previous picture, you got the anchor, which is bioabsorbable. It takes about 60 to 90 days, and you have the collagen plug, which also gets absorbed in a similar time frame, and it's easy to deploy. And these are the device components. As you can see here, you got the anchor at the distal anchor plate. You got a bypass tube. You got the suture over here, and this is the collagen sponge, which seals the arteriotomy sites from the outside. And you have a tamper tube to get the collagen plug into the location and keep it tight. And you have the device sleeve and the reference indicators. Blue color is 8 French, and 6 is color coded with green. So this is 6 French. So again, you have this arteriotomy locator, so where you have the bleed back and then the sheath. And usually it comes with a 035 guide wire, which is 70 centimeter length. But my practice is to use your usual Teflon wire, the long exchange wire, to seal it if you have it already in place. Going through the components, once again, you got the anchor, suture, compaction tube, and the collagen. And these are the dimensions. These are pretty small. The anchor plate length is about 10 mm and less than 2 millimeters in terms of width and the height of the dome. And sorry, let's go back one. And in terms of collagen, care has been taken. It's bovine, but it's from closed herd origin because there is worry about Creutzfeldt-Jakob disease. So all sorts of care was taken to prevent those kind of issues as well. And as I said, it absorbs within 60 to 90 days. So you could actually repuncture there, or if you need to repuncture, you need to go slightly higher. And this is what the schematic looks like once at 90 days. It's completely absorbed with leaving no traces of the material. There was one study in India. There are several studies across the world, even including meta-analysis. This was done at INHS Ashwini, where more than 16,000 procedures were done over a period of 5 years between 2011 and 2016. just over 1,500 or close to 1,600 were PCI procedures, and success rate is pretty good with almost 98.5% and 1.5% complication rate. This is my personal experience as well. So complication rate is usually 1%, usually due to failure to deploy the device or embolization of the collagen plug or the collagen plug distally downwards, causing peripheral complications and requirement for surgical assistance. So same study showing you the details of the 1.5% complications. Usually it's failure to deploy, oozing, local hematoma, limb ischemia, and aneurysm of the artery. And they didn't have any surgical requirement. And vasovagal requirement is much lesser than what we see with manual compression. It can be stored in normal temperature away from sunlight. It's got a temperature indicator, and I think you just have to stick to the 12 months timeline, the expiry date that's given on the use by date, because they're all bioresorbable components. In terms of comparison between AngioSeal and Perclose, pretty similar. Only thing is it's suture-based for large bore, that's ProGlide, and AngioSeal is collagen-based and usually up to 8 French. Thank you.
Thank you, Dr. Sudhir. I think we can go for the next presentation and then we'll have discussion at the end.
I invite Dr. Abhishek for his lecture on large bore access management.
Thank you very much for inviting me, ijcto, and waiting for me. I apologize for the delay. So large bore access management, Dr. Koganti has taken a bit of detail of the puncture site and everything. So punctures in a large bore access, always keep an eye on bifurcation. Usually this patient have a CT scan in TAVI, what we do, that's my regular procedure, what I do. So always keep a puncture 1 centimeter away, because it's not only that you need a sealing site in case if you need to use a covered stand. You need a sealing zone for that particular purpose. Besides that, the plug of AngioSeal or the footplate of AngioSeal or a suture can take a bite of a bifurcation and you can compromise the profunda. So always have a practice to start your puncture and with ultrasound. And you can just, to cut down the learning curve of ultrasound, you can use a fluoroscopic marker to put your probe right in the position instead of going a long axis, short axis, and just trying to figure out how deep or how far away from the bifurcation I am. As you know, the common exercise problem is hematoma, retroperitoneal hematoma, which is more serious, small and big size pseudoaneurysm, which ranges from 3.5 to 5.5%. And it can certainly be major. So incidence is like minor complication is around 10%, and major complication requiring surgical transfusion and everything is around 1%. The predictors that is already taken by Dr. Sudhir Koganti is going to be very same for us. Manual compression is very painful. Your staff is occupied for quite some time. Very painful for the patient of compression. There's again happy and unhappy patient, unhappy resources usage, and unhappy staff. So this is a different type of vascular closure devices. I'll focus on suture-mediated devices. So this is a Perclose, is a ProGlide is a Perclose device by Abbott. It's a monoforamen suture with a needle, footplate and artery localization. So we can quickly move to the things which are already being taken care of. So AngioSeal versus ProGlide, I will not go much into the details, but only much difference is that you have more liberty of using in a larger bore access beyond 8 French. The biggest advantage what I feel, smaller ones also, that you always have arterial access with you. If you need, if there is some failure, you can use a top-up ProGlide on that. You can put your sheath back and stop the bleeding and buy some time to go ahead. And then again, you don't leave anything inside the lumen. So the smaller vessels are handled better, and there is a less chance of embolization of the inner locator of the AngioSeal. This is how the vessel looks after a couple of weeks after absorption. Hardly there is a suture, as you can see on the top of the arterial wall on the right side. And there is certainly a plate inside the artery in case of the collagen plug-based devices. So again, location, common femoral artery, which is above the bifurcation, 1 centimeter, should be ideally more than 5 millimeter, but it depends on what kind of things we are going to use. In case of the endovascular stents and everything, you need a far more larger artery size to do the procedure safely. Okay. This is a long video. I hope it doesn't hurt. So this is more about the different components. And the animation of how you use it. You use your, first you take a puncture, give a nick, make a track, because the tip of the ProGlide is very soft. So if you make a track, it becomes easy to go in. Put a sheath. The outer diameter of ProGlide is around 8.2 French. So ideally you should use a 6 French sheath, or you can either use a 7 French dilator. Get your ProGlide over a wire, and when the wire port reaches the skin, you remove the wire. Then go in. Ideally I go with a rotational movement, holding from the distance. This gives a better tactile feedback in case if you are coming across any resistance, which is very common in a pulpy patients. Take your foot plate up, step 1. Pull it back so that you are coming out of the vessel. Ensure the bleeding stops. When you go for the step 2, take a bite. Now the grip is to be focused very highly, because the left hand is being used at the black pot so that you can see the blood is stopped, as well as you can use the cutting for once you have given a bite. Once you have gone in, put the pedal down, step 4, come out till the junction of metal and non-metal part where the sutures are lying. Grab the sutures. So you can see there are 2 sutures, one is white and one is blue. So white is to lock the suture and blue is to pull the knot. So never pull the white. So what we call is white is not right. Ensure that you are not pulling the white inadvertently. Then once you are closing it, just pull the blue, let the knot slide, and then you use a knot pusher to push the knot further against the arterial wall. Initial push should be at 45 degree. In case of any confusion, just first push should be light the way you have given the puncture. The way you have puncture in the same angle you push, then you give it a 90 degree to make it perpendicular to the arterial wall. And you can grab both together and pull the white. Yeah, at this point you pull the white. This is the animation. I will show a couple of video. I will show a video of actual one also. And with the red one, you can cut the sutures. So the KVX is the vessel wall calcification. Because the vessel wall is calcified, is next to your arterial puncture site. Your suture can go through cut down, and it gives a failure rates. So why I like ProGlide once again, because it gives you a warning that you are doing something wrong. So if you are having a suture is getting broken, then you change the angle, or you can change the degree of implantation. If you're putting the one at 10 o'clock, you can again try at 11 o'clock, 12 o'clock. In case at 10 o'clock the suture is breaking, if the suture is breaking at 45 degree, you can try it like something different, 60 degree or 30 degree, something like that. So the caveats are smaller diameters, these arteries, and your punctures are above the inguinal ligament. How it fails? Because the inguinal ligament, your femoral artery dives into the abdomen, and you cannot achieve that angle to push the node right into the arterial wall. And if your angle is more than 45 degrees, that's again a challenge. Obesity, obviously, because the softer part sometimes it becomes difficult to track through. Your wire can keep on curling inside the tissue. So be careful when you're using in a pulpy patient. So you can have different kind of errors: cuff miss, foot break, suture break, poor flow, and sheath kink. So the cuff miss happens when you have calcification, scarring, your angle is not correct, you are rotating or rocking the device while using it, or you are not properly moving the lever. Foot break happens, and your suture can go away. But once this happens, you just remove this one, regain your wire access, and use a new ProGlide. The sheath kink can happen in a pulpy patient because this initial part of the sheath is very soft. So be careful and not push anything. If you have any difficulty in getting this ProGlide in, just see under fluoroscopy what is happening down there. Poor flow happens because of hypotension, clot inside the tissue, so always flush the ProGlide before you use. There's a smaller artery, puncture from the side of the artery instead of the anterior wall. Device is not properly inside the artery, clot or tissue breaking hole. So now one thing very commonly happens, the poor flow. If it is happening and you are still not very happy about revising the puncture or again getting the device out, just start again a fluoroscopy. Remember where your needle has given a stick. and get your this metal part beyond that. So that means you for sure you are inside the vessel, and then you can again start deploying the ProGlide. That has worked very well for me in a couple of cases. So use of tips, pick the puncture side very carefully. Watch out for calcification. Even in fluoroscopy, it's not really possible to discriminate between the anterior calcium versus posterior calcium. That's where the ultrasound comes into the picture. And its learning is very, very simple. Believe me, just start doing in your femoral angiograms, then femoral plasties, and then you can certainly start using in your actual large bore access devices. See for tortuosity, so not every time we have this one, but yeah, we are lucky guys of a structural that we have CT scan available all the way in all of our patients. Always make a good dilatation of a tissue. Track problem can prevent knot tightening, and especially the large accesses. So whatever you are creating a track, your device and the knot both has to pass through that. So good preparation is always helpful. So I'll not go much into the theoretical part. So this is a two deployment. If you're using a two device per deployment, you can use it 60 to 90 degree apart. Classical way we are using a 10 o'clock and 2 o'clock. But it comes with a bit of risk of compressing the artery, which is not a very serious problem, but you might need a balloon to dilate the vessel again. This is the ultrasound guided puncture. You can see the depth on your axis, and you just start. Skin puncture should be nearly similar distance how deep your vessel is. If your vessel is 5 millimeter from the skin, you start puncturing 5 millimeter or 5 centimeter, whatever is the distance from your ultrasound probe, and that's where you are going to reach, because you are creating a kind of isosceles triangle there, and this little positioning becomes a bit easy for patients, easy for us. So this is the actual use of device. You flush the side port, plus the tip also. Make a neck. Use artery forceps to create a good track inside the tissue. Remove the wire at the skin port. Here's the pulsatile flow. Put it back. Don't hold from this metal part because you don't feel the tension on the system at that point. So we draw it back till the junction of metal and non-metal part. And you regain the access. So in case if you are using a large bore access and patient starts to bleed, in a bad access, always remove and exchange should be over a stiff wire so that your sheath can be pushed back. Or again, if there is some rupture of iliacs or something, on a very same wire you can put a cover stand or a balloon to tamponade the artery and buy some time at that moment. I think we can skip this second one. We can just go to the quick video of the knot tightening. So at that time, still the sheath is inside. Yeah, and you can pull the ProGlide blue suture while removing the device, and then you can start pushing the knots. So at this point, how to see your gross failure or success? If you don't have a pulsatile flow after tightening the ProGlide, believe me, the rent is not too big. Some tickle is going to happen because there is still a wire inside which will not let the artery to close completely. There will be some oozing from the track. But if there is a non-pulsatile flow, then it's a good time that you can think of removing the wire if you don't have a luxury to take a picture from the other side. So the wire is removed, no bleed. The stickle is something very common, so give a 5-minute compression because the pseudoaneurysms and a small hematomas are still documented with suture-based device and vascular plug-based device also. So replacing tips, ensure the sutures are kept sterile. It's safe to use more than 3 devices when you are using a system more than 21 French. Clean the sutures because some thrombus can form on the suture and it can give a difficulty in pushing the knot all the way down. And always first closing should be over the wire. Don't be very careful when you once you commit to remove the wire access. Ensure that your closure is not having a pulsed airflow from that particular puncture. You're not making, clean the suture, keep it placed. Don't pull the suture too hard. When the multiple devices are used, first you put all the knots down and then tighten them serially in the sequence in which you deployed. So for the large bore access, this is more of a complication. I think we can go there. So this is a deployment error you can happen. This to cut down this. In this particular case, they could not push the suture all the way down. If your puncture is at the bifurcation in this fashion, it can take a bite of the bifurcation and it can close the SFA. So puncture is the key. Whatever device you use, whether you use a plug-based device or a suture-based device, your good puncture is the key to success. I think calcification is all again theoretical. We can skip it quickly. The mobilization for I have not used much of these devices for the plastic procedures. But for TAVI, there is a study called a MET study where they try to randomize the mobilization of a TAVI patient after 3 hours and 6 hours, but they are reverted back to the 6-hour protocol. So if you're using for the larger bore access, it is good to have a 6 hours immobilization for the patient. So again, there are different kind of outcome, but yeah, hematoma and pseudoaneurysm can still happen. So gentle compression for some minutes after the even using the closer devices is helpful. It does significantly reduces the complication, minor, even moderate, and serious complication and requirement of transfusion in a significant way with a odds ratio going from 1.7 to 2.1. So again, I have said in a different times why I like ProGlide. One is you're not putting anything inside the vessel wall. You have a bailout option. You have a wire access. You can use a top-up ProGlide or put a sheath back to prevent the bleeding. You can get all demobilization and reduce complication with either of the devices. So, in a summary, closer-based devices are useful, particularly for the large bore access. Safety profiles are good, reasonable. Improper use has given a significant penalty in terms of vessel injury, dissections, and even perforations have remaining punctures are still left. As a unique solution for large bore access, there's a large bore access is a power close. Thank you very much.
Thank you, Abhishek. I think for large bore access, we are pretty clear. There is no manual compression for that, right? We have to do some sort of closure device, whether we do two ProGlides, we do any kind of combination. That is dealer's choice, I believe. But for the angioplasty cases, for the EP cases, 6, 7, 8 French, I guess this is a question for you and for Sudhir both. When we do plastic cases here with, let's say, 6, 7, or maybe 8 French, what is your suggestion on manual compression versus ProGlide versus AngioSeal? If you could make a case, maybe 30 seconds, 1 minute each, what do you think out of the three your preference would be?
I would say if there is no financial constraint, which is a very common thing happening in our country, I would love to go back home and have my coffee peacefully. So I would love to have a vascular closure devices, irrespective of patient's anatomy. But indeed, if I'm using a plug-based device, like Dr. Koganti said, I would love to have an angiogram before the procedure, or at least at the end of the procedure before I commit, because in those cases you are putting something inside the lumen. If I have not used, if I've not taken an angiogram, or if I find that okay, my puncture side is not so great, then probably I will shift to the suture-based device for those particular cases.
Yeah, I think any complex angioplasty where you end up giving a lot of heparin, patient already was on the bed for long, I think no doubt AngioSeal up to 8 French. I'm sure you could even use ProGlide for those patients as well. But I would use AngioSeal.
Okay, I believe any questions from anybody? Okay.
I think the price is just a psychological barrier. From, I think Terumo guys will vouch for it, from 2012 onwards, every femoral angioplasty I have been closing with AngioSeal. And now you have a device from Merrill which is a little bit cheaper. It is just up to us. Like if you are trying to, we have been using balloons for post-dilatation. Why are we using balloon? The cost of balloon on cost of AngioSeal is almost the same. So if we can avoid a balloon and use AngioSeal instead, that will be safer to do it for the patient.
I think, sir, the limitation here is for learning curve for majority of our colleagues. It's not the bigger problem is not a money. it's like kind of a learning curve. A bit. This is not very big, but indeed, small learning curve is, I think, the hindering factor in usage of that.
And 6 and 7 you can close with 6 French angioceal, 8 and 9 French you can close with 8 French angioceal.
So I think it's it's in your hands, angioceal. It's predictable, but where a technician pressing on it is not predictable.
Not at all. Thank you.
Thank you, chairpersons. We conclude this session now. The next will start around 12 o'clock.
पोडियम में को ऊपर
मास्टर्स एंड लर्नर्स हो गए ना, नो लर्नर्स मास्टर्स आए तो भी कुछ फायदा नहीं है।
वो एक कैटलैब टेक्नीशियंस का एक रहता शायद।
कैटलैब टेक्नीशियंस का
रेडी है। नेक्स्ट सेशन कौन सा है?
वो मास्टर्स एंड लर्नर्स बोल के मेरे को नहीं होता।
ओके। ये फुल हो गया, ऑल V1 फुल है। V1 फुल है, वो भी ओके। दीपक ये इधर अपन टेक्नीशियंस का करेंगे। अभी बुलाएंगे। वो अपन 1 o'clock को बोला, बट एक बार बुला देता हूँ। If they are ready, I'll send them. మీరు ఎవరెవరు కూర్చుంటారు సార్ డాక్టర్ సార్? ఇక్కడ టెక్నీషియన్స్ డాక్టర్స్ కూడా ఉంటారు. I'll send the technicians. Sir, Madhu is taking care of the technicians course, everything. Okay. Our cabinet himself. Okay. He will coordinate the technicians, everything. They are ready. Doctors కూడా they are already అతనికి తెలుసు. ఈ total coordination he will take care. Only మన side నుంచి ఎవరైనా ఇద్దరు ముగ్గురు ఉండాలి. Okay. half an hour के बाद अपन start. ఎక్కడ ఇప్పుడు 11:45 है. 12:30 कल start చేసుకుంటాం. एक 15-20 मिनट. Okay sir. మెయిన్
కావాలంటే కాల్ చేయండి.
కరెక్ట్. అశ్విని వీళ్ళందరూ కూడా ఉన్నారు, కూర్చోబెడతారు.
మీకు చెప్పారు.
Learning, the first time we are conducting program only for
तेज शार्प पे
किसी का नहीं सुनता, तेज आप पे बोलो तो किसका सुनता?
यहाँ पे कल बैठ के बोल
Okay, वो participants थे maximum 6 participants थे.
चलो मेन हॉल में बैठो
Good afternoon, everybody. I'm calling the chairpersons for the session planned antegrade but finished retrograde. Chairpersons are D. Seshagir Rao, Rajiv Menon, Mahesh Fulwani, Raman Chavala, and A.K. Srivastava. Discussants Dr. M. Sai Sudhakar, Sumit Sinha, Dr. Hore, Hemant Kemanani, Manish Jha, N. Ganesh, Jafre Chua.
Okay, now we're going to have series session from Hall B1 to Hall B2, and I welcome you all. Now we're going to have first presentation, basic is plan antegrade but finish retrograde. The point is, why did we fail antegrade? Not why did we finish retrograde. Let's start with the first case, that is retrogrades RCS CTO through LAD. Dr. Asharbat Parhi. Yeah, I'm sorry if I could not pronounce it properly. Yeah, please start.
A very good afternoon to everyone. So today I'm presenting case of retrograde RCS CTO PCI, success after failure, after doing a sneak peek through the LAD CTO and doing an investment procedure in the RCS CTO. So this is a 66-year-old male, known case of status post CABG in year 2005, presented with acute coronary syndrome NSTMI, non-Q wave, with severe heart failure. After medical stabilization, he underwent CAG, which showed native triple vessel disease. There was a significant disease in the SVG2 diagonal. The RCA was long occluded, long back. There was a patent thin lemma which was supplying the LAD graft. So it was planned to do a POVA to the LCX and do a stenting to the diagonal just to tide over the crisis period. So this is the angiogram of the left system. You can see there is some disease from distal left main extending to proximal LAD. This is a complete occlusion after the origin of diagonal, and there is a distal LCX disease. This is the right system angiogram showing a proximal ambiguous CTO, and we can see the length of the CTO reaches till the crux, just before the crux of the RCA. So this is the patent lemma to LAD. It's a type 1 LAD, just doesn't reach the apex, and we can see a lot of intervention collaterals after it turns into left anterior descending artery. You can see this is a diseased diagonal. We did a PTCA to the diagonal just to tide over the crisis period. After 1 month, the patient clinically improved and also echo parameters improved. So this was the RCA CTO. This is the anatomicogram. You can see this is the RCA CTO. It's a long angulated CTO with calcification along with proximal ambiguous cap. The other problems associated with it are the distal cap is also is ambiguous. There is a bifurcation point at the distal, just beyond the CTO segment. There is a SVG graft which distorts the anatomy. And we can see other problems lying. These are good interventional collaterals, but these were after the CTO segment in the LAD. And we can use these grafts as conduits, but as we can see, there are very unfavorable angulations to get entry into the collaterals, intervention collaterals. So initially we planned for antegrade, but the chances of success was very less, as because this curve is a JCTO score was 4. It's highly likely that it will go into subintimal spaces. So another problem to tide over, we prevented the triple injection. We tried to cross the LAD CTO by giving the injection into the diagonal, saving a lot of contrast and time. So after, as expected, after multiple tries, the antegrade due to the high JCTO score, the antegrade wiring failed. It was recurrently going into the subintimal spaces. And we can see, we created some space in the LAD segment. And we can see, we got the Caravelle microcatheter into the septals. By this time already we had a processing time of 80 minutes and also a lot of 60 ml of contrast volume. Another point that we observed here, which was used subsequently in the next try, was that a very short distance of the septals, which didn't help us because it was angulated into the graft, and also not a lot of support from here. So, we initially tried to send this Gaia 2 wire. Initially, we thought in the LO view, we thought we were on line, but as you can see in the areocaudal, this orthogonal view, we are it's desynchronous with the proximal segment of the body. So next plan was to do a knuckling. Again, the same story got repeated. In spite of knuckling, it went to the same space. So we did a ping pong technique and we sent Gladius Mongo wire till the distal part so that we can do a reverse cut over here. So still the same problems prevailed. As we can see, in spite of repeated trial, we can see the same, it was getting oriented to the SVG graft because there is a loop created to the SVG graft, and also it's more in line. By this time, the procedure was 150 minute, contrast volume 120 ml, 4,000 microgyri of radiation was there, therefore we planned for future. So what plan did we do for future? We did a investment procedure. We created some space so that the next future antegrade wiring will be easy. We opened the CTO and we did a stenting, trying to nail the LM osteum so that the future intubation can be easy. So this is a preparation with a 2 mm balloon, and with IVOS support, we did a LM to LED stenting, preserving the quantity. So this is the final position. That is, you can see there is some contrast seeping into the vessel architecture. This is some place we created. So after 3 months, this is the anatomical, this is the dual injection. You can see some channels, micro channels being there, and still it's prevailing. So our plan was to first do antegrade wiring and taking it as a marker, we'll send the retrograde wire and do a we'll send a guideliner and do externalization. So this was our plan. So first antegrade wiring, then retrograde wiring, then with guideliner and do a cart, directed cart. So this is where we put the retrograde, caravel, and we can see very easily the next Gaia 2 wire went in quite easily. As you can see, it's went very easily, saving us a lot of time. So subsequently, again retrograde wiring was done with antegrade marker with the Gaia 2, but again it was deflecting into the SVG graft, same problem. Therefore we increased the tip load to Gaia 3. And we can see there is some overlap subsequently that we got. And finally, the overlap was good enough for us to plan for a reverse cut. So again, this 2 millimeter balloon we did with this Gaia 3 went in within the body of the CTO. But the externalization problem, we faced problem during externalization of the wire. So for that, we did an IVAS run. So as we can see, there's in this IVAS slides with the respective places, it was there in the true lumen now, both the wires. But as we went up, the retrograde wire is in the subintimal space. That is the reason we finally, the next plan was to send the microcatheter where the true lumen was there and to externalize. So, but still we faced a lot of problem when we were sending the caravel. We had a looping, which can cause avulsion of the collaterals, which is a dangerous prospect. Therefore, finally we changed the septal to more distal PDA, and finally, through ultimate bros, we could externalize through the guideliner. So we did the pre-dilatation, the routine stuff, and we did a wiring to the PLV. With IVAS, we checked whether we have the patent PLV opening is there or not, and we did a stenting from RCA to PLVA. So this is the final, result. So what are the conclusions we drew? Post-EVBG CT was challenging due to the distorted anatomy. SVG anastomate to precrux RCA can cause problem to wire connection. Orthogonal view helps in the differentiating between SVG and RCA. Reverse cut close to SVG anastomosis with antegrade wire kept as a marker can help us in the procedure. And again, when we are planning for the next step, we should prepare the previous lesions so that we can gain access to it easily. Thank you.
Yeah, well done. Multiple steps, very well operated and complex case. Opening LED for retrograde RCS, CTO, is it advisable when Lima was patent?
Sir, I do agree with that. The problem was the history I mentioned, 6 admissions. In spite of patent LED, we had 6 recurrent admissions with heart failure. So, and the LED was type 1, sir. Still, it doesn't explain, but due to the recurrent admissions and the long back, the graft to RCA was occluded. So that way, we did try antigrade first, but ended up in doing that.
My point was different. See, once you open occluded LED with a Lima patent graft, there's going to be competitive flow.
Right, sir. Right,
now, Lima is going to occlude, and restenosis with the LED stunting is slightly more as compared to Lima reclusion.
Right,
so that was a point of concern. I'm not saying nothing in interventional cardiology, nothing is right or wrong. It is always relativity. So if we say something that doesn't make you wrong, this is a concept what we are discussing, right? This is major discussion, any CD presentation.
Right.
It's very easy to say as by sitting here than you did at that particular time. Yes, you want to say something, please.
So what I basically feel is if you see the Lima graft, it is put on the foot of the LED. And majority of septals are coming from the mid to the proximal part of the LED. So do you think that Lima was giving any benefit to the patient per se? Because RCA was a CTO retrogradely filling, we could see already. And once you stented the LED, did you go back and check what was the incidence of heart failure episodes after you have stented the LED?
There is no recurrent, no further admissions for heart failure.
Exactly, that's what I'm trying to say.
Type 1 LED, sir.
It is a fault of, no, it's not a type 1, it is a fault of a surgeon putting a graft at a wrong place, not benefiting the patient.
Right.
You have to, that is very important point, Dr. Chawla. I wanted to make most of the cardiologists send patients for bypass surgery without seeing the lesion length and the diffuse disease. If it is a diffuse disease, early distal aspect, surgeon cannot help in any possible ways. That is why patient recovered, because once you open that LED, I could see a lot of septals which were filling.
I may not fully agree with you. What I'm saying, when Lima is given to LED, there is sufficient retrograde flow back to all septals, which you are maybe unable to look at when you're injecting Lima. So that point may not be correct, that his Lima was not that good to give blood via septals, proximal septals.
Possible.
This is what I feel, may not be correct, but okay,
yes.
point well taken. That's
yes,
it.
because
That's
it is very much.
And second point was, your good point was, once you opened LED, did you wait for sufficient time for the patient to have re-symptom to intervene RCA? That point is reasonably taken, please.
Absolutely. That's right.
Nice case, as has been told, that opening the LED just to do a RCA, is it justifiable? It's a big question to us, to me also, because Lima, we all know that it is far, far better than any stent.
So second thing was, after how much time gap was there between investment procedure and the
3 months.
3 months gap you waited. And as we discussed, patient was relatively better in these 3 months.
It was,
so indication after 3 months when patient relatively better.
Right, sir. We thought that the admissions at the presentation, it was an in-stem, and we thought it was the graft occlusion to the diagonal, sir. So we treated it and did some, we did also POBA to LCX. So, but after that, the viability was there. And there was recurrent admissions from 2014, sir. From 14 to 22, 6 admissions, sir.
So you have revascularized 3 territories, LCX, diagonal, and LED. And even patient was asymptomatic, you still felt the RCA should be opened. Slightly controversial, but yeah, please.
Big RCA.
Yeah,
big RCA.
Yes, sir.
Better open it.
Okay, better open it. Let's see. Okay. Yeah, thanks for a good, nice presentation. Thank you. Yeah, please.
After opening LED, is it advisable to put coil in a Lima to LED graft?
This is again some controversial point that Lima is going to occlude automatically because it's basically competitive flow. But occlusion of SVG is advised. Okay, it's better usually done with coils, SVG to any graft, native vessels. But occluding LED intentionally is generally not documented, not proposed.
You had done a viability assessment.
Yes, sir.
It was perfusion effect in LED or not, that will solve out this. If you had a perfusion effect in LED, there's a point of
no, sir. No perfusion
effect
effect,
in LED.
sir.
All right, very well presented. Well done. Okay.
I will invite second presenter, Mr. Dr. Gaurav Chaudhary, challenging case of successful PCI of Australia LED, CTO. If it is not there, I will invite Dr. Manohar, Chief CTO without MCS. Dr. Manu is there? Not there. Then
Whoever is the next sequence, please come up and start.
Raghav Sharma. Retrograde CTO of LED using TPN technique.
Good morning, everybody. This was a very interesting case of a 37-year-old male. It does reflect the intensity of diseases and how we deal with the retrograde cases. And TPN is one technique which is very underrated, but I feel it's a wonderful technique, saving a lot of wires, saving a lot of time, and saving a lot of hardware. So this was a 37-year-old gentleman presented with angina which was class 3, chronic smoker, hypertensive, normal ejection fraction of around 50%. So this was his angiography. You see there is a left main there, and LCX is 100% occluded. You can see there is a flow, a little bit antegrade flow is there. You've got LED which is 100% occluded, and there is a single large septal which is supplying, if you see in the next image, LED as well as RCA. So now this is the right coronary injection which I took. There was a little, so RCA looks like having a 99% lesion. I was not very sure. So decided to see, if I see the LED which is filling, that is a long segment lesion, and again I felt it was unsuitable for grafting, if you see in the second injection. So first I decided to approach and open LED. If it opens, fair enough. If it doesn't open, I would definitely send a patient for surgery or whatever is the possible option, considering the nature of the disease. So since there was no ambiguous origin and I could not identify antegradely after struggling for so long, and there was an aneurysmal segment there, I decided to go via septal pathway retrogradely, cross the lesion. This is a fine cross I am using, and I have used the wire as Fielder FC. Actually XT and XTR is a better option. It's a soft tip wire, and but it managed to cross through it, if you see. So parked the microcatheter distally, decided to proceed with further with the escalating the wire to Gaia 2, but ended up dissecting the segment there. As you can see, there are dye stains, and even the septal was very tortuous and it also got dissected. But nonetheless, since I had retained the fine cross, I was not worried. So decided to take the Gaia second wire up, going subintimally. So after this point, I was finding it very difficult to progress the wire further. So I kept the distal wire in the as a marker. I'll keep it as a marker, and let me try to go antegrade, making it a hybrid procedure if I can easily cross it, but could not. So after struggling for 10 to 15 minutes, I managed to cross and park the wire into the same guide. So it's a single catheter, so this you can see that wire has been parked there. So, and I could take the fine cross across the left main up to the guide. So, well, so this is a slide which shows TPN. Actually, I don't have the point where I introduced, but if you can see, over the same wire, there are two microcatheters. One microcatheter is antegrade, and second microcatheter is already there in the distal part of the LED. So basically, TPN technique is a technique where you take a retrograde microcatheter and you take an antegrade microcatheter and you put a retrograde wire into the antegrade microcatheter. Usually it is easy to do with XB or EBU because it is usually done at acute angles. So this is how it is. So over the same wire, I took a microcatheter and parked it distally. This was a check injection just to see whether I am in the true lumen of the vessel or not. So it was confirmed. Subsequently, the CTO wire was exchanged with normal workhorse wire. I prefer using Fielder FC. And wire was parked in the distal part of the LED. Till this point, I was very comfortable. There is no dissection in the left main or LED anywhere. As you can see, septal of the LED is flowing very nicely. So I decided to proceed with stenting the vessel. So moment I stented it and post-dilated it with 3.5 and 4 balloon, you can see there is a dissection in the proximal segment exactly where the septal is coming out. So, different views were there, whether it was a dissection already created or whether it is a dissection with the balloon or what was the reason, I'm not sure about it. But definitely there was a dissection, or is it an extension of a distal dissection, no idea. But looking at the check angiogram previously done before stenting, there was no dissection and the septal was flowing beautifully. Anyways, so we decided, and the dissection extended up to the left main. So I thought maybe I have dilated it with balloon, it would have caused it. So without losing a wire, I quickly parked the distal stent first so that I don't lose the distal part of the vessel. And this was I just removed the wire to be confirming it. There was a slow flow and a dissection in the proximal left main, which is quite evidently visible. And you can see at the mouth of the stent where it starts, there is a diastasis, pretty much observant. Maybe in the ostial part of the LED, I was not sure. So without making a delay and giving a benefit of doubt, I rewired it and placed another stent from left main to LED. So without giving it a second chance, I was not very sure. I could have left it there also, I don't know. But then young patient, you don't play with these patients. It's better to do it. Stented it, post-dilated it, everything done. This was the final result. And a nice collateral to the diagonal as well as the circ I could see coming out through the LED. Distal branches were saved, though this LED already had very few septals. One this was the biggest septal probably, which was there, but that septal has closed. And patient started having chest pain. Without a delay, I decided, because as RC I had already seen there was a 99% subtotal occlusion, within giving a second chance, I quickly crossed the wire, ballooned it, and I could see RCA nicely opened up, placed a small stent there. So did this, and in this shot you can see that septal, single large septal also was filling nicely retrogradely. And patient was absolutely fine, hemodynamically stable, BP well, and this was the final result for that RCA. Patient is under regular follow-up, doing very fine, free of angina. So the take-home message was that it is a septal to septal pathway. Pipette technique is an excellent technique, but sometimes you may have challenges, like I faced a challenge. I don't know whether it was a dissection done while I was taking the retrograde microcatheter or what is because of the balloon. I am still confused for that. CABG, of course, stands no much better option sometimes, but due to the poor targets, sometimes graft may not be beneficial to these patients. So thank you very much for your patient listening.
Complex case, right? Your starting comment was LED was not that good, that's why CABG was not advised. I will take it probably with a pinch of salt. Okay. That is one thing.
Fair enough.
Second thing, technique reasonably well done. Opinion, tip-in technique is when you can do it in coronary vessels also, not only in guiding.
Yes.
Probably cause of dissection was guiding. Why did not you prefer ping-pong guiding instead of single guide?
Yeah, that is a good question. I
Generally, it is always recommended to make it more comfortable yourself.
Yes, I do agree with you. Yeah, that's point well taken. I also thought later on could have used two guides instead of using single guide and unnecessarily creating a problem. And it is easy to take a wire out in a second guide, definitely.
Yeah, that makes your interventionist life easy, and
point well taken.
Might
That could have
prevented, it's difficult to say, left main dissection.
Yeah.
Yeah, difficult to say, but might could have prevented
Absolutely.
that. This
point
is
well
what
could have been a possible option. No.
Please.
Another point is you should do the imaging when you are passing retrograde wire, because whether it is in the true lumen or whether it is in the subintima.
See, the point is very well
Second
taken.
point is you have not done the imaging.
I'm telling you that only. How many centers do you think have imaging with that? One minute, let me come to you on that point. When you operate on CTOs, people, I saw yesterday a lot of cases of imaging. You don't want to see the anatomy of the distal vessel. Ideally, an imaging in a CTO is done to find the bud, to locate where exactly you have to cross the wire. Now, the second point is when you do these procedures, it comes with a cost. And imaging adds further to that cost. It's not easy to do imaging.
No, if it is available with you, you should do the imaging, because
that's what I said. It's
you are
not available
risking patient's left main, because if your retrograde wire, if it is in the subintima, it will be dangerous.
Yeah, but it was not.
If it is not available, then no issue.
Exactly, that's
Yes,
what I
yes.
am saying. Yes, that's the point.
Okay.
Suppose, please do not mind my words if I say something. Suppose it was me. Will you tell me to have CABG or angioplasty like this?
Okay. So The point is very clear. If I see your vessel and see the targets and decide on that, definitely I will surely first of all ask you, Dr. Chawla, being a cardiologist, you have got a disease. What is your take on that? Because the point is very clear. See, I do agree with you. I've seen a lot of patients post-bypass, good flowing grafts, having angina. And the reason is, see, if you see LAD per se as such, I think Dr. Chawla has an idea. It is the septals which are important, which supply the myocardium. It is not the tube.
You lost all the septals.
Yes.
This is also a point.
No, there was no septals, only one septal. That's what I said.
See, whole LAD now is metal jacket, except the distal part of it, which has some few branches.
Yes, distal
so
part
it means
has few
total.
branches.
How LAD can be without septal?
No, if
Septal must have been there, which has been blocked.
No. The anatomically, if you see, that's what I showed in the first part also. There was one big septal which was feeding both the vessels.
No, and you see, Raghav, as vessel was blocked already, septal was not visible. So you can't say LAD is without septals. Only septal.
Only
distal
one or
part.
two
It's not
septals.
possible.
Possible. Yes,
It's
we
not
can say that.
It's not possible. Yes.
No. That is what I'm saying. Imaging is not there in every center, so it has a challenge.
No,
and you
another
have to take that.
is, you should be because it was large septal giving lot of collaterals. At least you should be keep the wire, keep it open.
Which one?
Septal.
Septal was open till the end until unless I dissected
No,
it. Until unless I
you keep the wire, then rewire. Balloon dilatation.
The point was, you were not supposed to stunt the area where the septal was arising. There was a healthy zone just distal to that septal. Though it was a complication, it happened, it dissected. I was left with no choice. Otherwise, I don't need to protect it because there was a good zone, landing zone, just distal to the septum. Actually, if you see the first stent is placed distal to that.
At the same time, you should be try to open the septal from the LAD.
Not
through
required,
the
no, RC already opened it up. I knew one septal supplying both ways.
Going to the RC
so
is,
it becomes a two channel.
It is earlier you can open the septum if the patient have angina rather than opening the RCA.
Opening the RCA, you can open the septum.
That's my point.
I would have tried that.
Yeah, Raghav, I think one issue is generally, just 1 minute. Generally, the decision whether surgery can be done or not should be left to the surgeon because as cardiologists, always we feel probably it is not graftable. But I think it should be a hard team discussion. All of us sit down together and then decide because this looked like a straightforward surgery which could have been, the patient actually escaped almost a near disaster. So that way surgery would have been much safer. The second issue is whenever we have a proximal dissection, always better to stent the dissection first. Don't bother about the distal vessel and all. It was very clear that there was a proximal dissection, most likely guide dissection. With each injection, the dissection keeps progressing. So the best is to first make sure that we stent the proximal dissection. The third aspect is never remove wire in this situation. So again, that was very lucky. Thinking about dissection and then removing the wire, that is again quite a disastrous thing. So I think at least these basic things we should not
Can you just run the first image of it if you give me 2 minutes? So I feel giving it for surgery was quite disastrous, number one.
No, that's okay.
Let me explain you the points.
The
what you have told,
interventional aspects, let's discuss on
that is what I'm talking. So if you see, that artery was never fit for any graft.
Actually, I can tell you, because occluded vessels, these are always sunken vessels, these are underfilled vessels. See the size of LED after opening and before opening.
Yes.
So after opening, do you say that this vessel is not suitable for CABG?
After opening, you see, where do you want to put a graft? The point is that. In any artery, wherever you want to put a graft, point is that. See, entire LED is there. You can put from foot to toe and even in the proximal part. That depends on surgeon. But do you need a good, healthy area that is almost of the mid LED, where exactly a graft should be put so that it works in a better position. If you put it too distal, it won't work for you.
Most of surgeons are not putting mid LED.
So that is surgeon's problem, not mine. That's what I'm telling. No, that's the fact. Actually, if you see, that's the fact. Technically, if I speak, and honestly I speak.
Yeah, let's not go into controversy of CABG technique and intervention. Let's go to the next case. Dr. Raghav, well presented.
Thank you.
Yeah, thanks for Dr. Raghav. Dr. Vijay Trahan, boss ji, koi comment, please. We want you to say, please come here. Sir, we want to learn actually. It's a question of learning from your point, please.
Next case.
Okay. Sir, yahan baitho na. Yeah.
Go ahead, no problem.
Yeah, we are going to invite next presenter, that is Dr. Vinokota, retrograde CTO PCI through epicardial collaterals. Yes, Dr. Madam Vinokota.
Good afternoon, everyone. This is a case of 62-year-old male
admitted with functional class 2 angina, is TMT positive, good LV function, normal sinus rhythm, is hypertensive and diabetic. This is the left angio. There is a proximal LAD, complete total occlusion with ambiguous cap and with a side branch, septal side branch. And this is his right injection. The distal LAD is filling retrogradely, predominantly through the septal collaterals from the PDA. And there is also an apical epicardial collateral. So, the proximal cap being ambiguous and the long length of the lesion, we have decided to go through the retrograde approach as a first approach. And we have engaged the left coronary artery with the 7 French EBU and the right with AL1, both through the femoral axis. First, we have tried to go through the septal collateral with a fine cross microcatheter and the run through up to the septal collateral. And to cross the septal collateral, we used a Sion. And there was difficulty in passing the Sion guide wire. And so we have changed it to the Suho 03. And that was also not going through. So we shifted to the next collateral, that is the epicardial collateral. With the same fine cross and Suho, we could cross the epicardial collateral up, and the wire could easily pass up to the mid LAD. After that, there was difficulty in crossing. And at this point, we have tried with the Gaia 2. That was also not crossing the lesion. So we tried a antigrade approach, and we took a Corsair Pro XS and run through, and we tried to penetrate the proximal cap, but that was not possible. So we again shifted to retrograde, and now we tried a Miracle 3. And with the Miracle 3, we could able to cross the CTO lesion. After that, the fine cross was not crossing the lesion. So we shifted to the Corsair Pro XS, and there was also difficulty in crossing. And so we used an anchoring balloon technique, and with anchor balloon support, we could cross the Corsair microcatheter into the antigrade guiding. After that, exteriorization was done with the RG3 guide wire and followed by pre-dilatations with 2 and 2.5. The lower panel is the result after pre-dilatation. And it was stunted, the proximal to mid LAD was stunted with 2.5 44 and the osteoproximal LAD with 3 into 18. And post-dilatations were done with 2.75 and 3 in the 2.75 and in the mid to distal part, and the 3 and 3.5 in the proximal LAD. This is the Iverson post-dilatation. The distal edge was fine, but there was under expansion in the mid part and also in the osteoproximal LAD. So we went with further post-dilatation in the mid part with the 3 and osteoproximal LAD with 4. And this is the final result. The take-home message being, in diffusely diseased and poorly visible distal vessel, which makes re-entry into the distal true lumen challenging, upfront retrograde approach is preferred. And use of contrast-guided technique reduces the risk of perforation by evaluating the tortuous and curved branch portions of the septal channel. And Suho 03 guide wire is preferred in crossing these epicardial collaterals, and adjuvant imaging helps in achieving the optimal results. Thank you.
Even if I know that it was stumpless, even if it was stumpless LED, I still feel that there was no harm in trying initially antegradely by keeping dual lumen catheter, by keeping one of the vessels in septal branch. Septal was a reasonably good size vessel, and you might have tried with Crusoid or any double lumen catheter, which you are comfortable with trying antegradely. This is one point. Second thing is that you tried only one septal. There were other septals also which was available. Okay.
Only proximal septal was there, so that was a very small septal. And
see, sometimes what you see might be different when you are crossing retrogradely. So it's not only the size, but it's visible to your eyes. It might be something which is uneven, collateral not visible. You can take the surfing technique. You commented that contrast injection vis-a-vis surfing technique, contrast injection gave rise to more perforation. Or you said surfing gives rise to more perforation. Probably this may not be true. Surfing generally gives less perforation as compared to contrast-driven septal collateral.
Even for epicardial collateral.
Epicardial collateral, you don't need the contrast injection at all. It's
Yes.
so obvious that it is talking to you that I'm here. So you don't need anything for the epicardial collaterals. And third thing is going directly to epicardial collaterals. Probably I may not have been comfortable. I'm not saying you did wrong. I was still not comfortable taking epicardial collateral in this situation. Please.
See, I have just one comment here. You tried antigrade, right? And then subsequently you went retrograde with the miracle wire and came into the catheter, right?
Yes.
I would have been very, very skeptical in doing that because you are almost at the proximal part of the LED. And when you are crossing with the miracle wire, you do not know whether you are in a false lumen or a true lumen. The ideal technique in this situation, whenever you have a proximal LED or a proximal mid LED lesion, you should go with a reverse cut. You should never try to cross that lesion with just simple wire and going into the left main. You may have gone true false and come into the guiding catheter, and if there is a wire in the false lumen in the left main, and you will end up closing the circ. So in this situation, you should have, after crossing a little bit, you should have gone antigrade, did a reverse cut, and tried to cross in this lesion only and come back into the catheter rather than taking the same wire right into the. It's a really, really tricky situation. Those who have faced it, they know it. So I will never recommend going just like that with the same wire. You were lucky, but if on the day when you are not lucky, you will be in a deep trouble.
Or you can take guide liner distal to
Yes,
distal
you could
part
have taken a
of the
guide liner and done a crossing inside the liner rather than waiting in the ostium of the left main.
No, sir. It was a guideline and telescope was used actually.
Okay. Second thing, we used microcatheter as what was first microcatheter you used?
Fine cross.
Fine
If you're
cross.
trying to have epicardial collaterals, yes,
Yeah,
please you
fine
can comment
cross.
first.
See, what Dr. Challa was saying that epicardial, I would have not used it. So fine cross going through epicardial is big no.
It's not.
Big no. Because fine cross is a cheaper catheter. It is very good for penetration antigrade. But if you have to walk through the epicardial collaterals, and fine cross, nowadays if you take Caravelle or you take even Corsair Pro, I think they're much more, say,
It was later exchanged to Corsair.
Caravelle is better actually.
but in this case, one simple trick which at times can be done. You see, you had a collateral which was a distal PD going epicardial into the LED, which was a kind of major collateral. And one simple trick which can be done in such cases is, balloon include the distal part of PD, and then you try and check. Some of the proximal septal which were not visible, they will be visible. They'll become a little bigger. Give some nitro, and you'll start seeing them. You'll be able to surf. Surfing through septals is more forgiving. There's no doubt about it.
The message conveyed is that you should not try epicardial unless you are very sure septals does not
And
exist.
epicardial with fine cross, probably not.
Is that was probably not a good choice. Still very well presented case. Yeah, please. Thanks, madam. Thank you. We're going to have.
I think it would be a last case, I think. Stump place CTO by Save Kit.
We'll close the session. Before we close, I'll request Dr. Trehan to give us some couple of comments about retrograde.
No, I just joined here.
Doesn't matter. Just general comments about retrograde.
No, I think that will be out of context. Let the cases come. We can.
Cases are not there. It's all over.
Session's also over.
Yeah, absolutely fine.
So, good afternoon, everybody. I'd like to invite chairpersons for next CD session. I'll invite Dr. Vijay Trehan sir, Mamta Reddy, Joel Shah, Ajay Mahajan, Madhusudan Asava, Rajshekhar Verma. The discussants, Mata Srinivas, V.S. Bharati Lakshmi, K. Dipti, Shrenik Doshi, Gauri Shankar Reddy, and Hari Ram. So all the presenters are there in the hall. Can I invite first presenter, Kiran Kumar, L. Kiran Kumar? So we have 8 minutes for presentation and 2 minutes for discussion. And we have scoring pages with the moderators. They will give the marks accordingly. I invite first CD presenter.
I will not mark because my son is presenting here. So that conflict is there. I will be here only for comments. Or I can sit there. That may be better.
No, it's okay.
No. It may be better. No, it will be all right to sit here and give comments. Commenting is not an issue.
Kiran Kumar.
Good afternoon, respected seniors and my colleagues. I'm going to present a post-CABG RCA CTO, which is opened by antegrade approach. So this is my patient's initial presentation. Patient is 63 years male, diabetes and hypertensive. So he presented with unstable angina. Echo showed no RWMA and good LV systolic function. Angiogram done showed triple vessel disease. So given options for multivessel PCI or CABG, patient opted for CABG and underwent CABG. Later, recent clinical presentation, he was on regular follow-up for the past 5 months and treatment with dual antiplatelets, statins, ACE inhibitors, beta blockers, and aldosterone antagonists and anti-anginals. He presented with difficulty in breathing for more than 10 days, admitted and medically managed. And ECG showed no new ischemic changes, but echo showed RWMA with moderate LV systolic dysfunction. So plan for graft angio in view of the new onset LV dysfunction and his symptoms. So this is the initial angiogram pre-CABG. So LM is normal, LCX proximal has mild disease, and at the OM junction is having significant stenosis and distal total occlusion of the distal LCX. LAD at bifurcation of the major diagonal showed around 80% stenosis with the osteal stenosis of the diagonal. This is RCA showing mid 80% discrete stenosis in the mid RCA segment. And there are good retrograde collectors flowing to the distal LCX. In this. So patient underwent CABG with the SVG to LAD and D1, OM and distal RCA. So after later presentation after 5 months, this is the angiogram, post CABG graft check angio and graft angiogram showing the native vessel LCX where we are not seeing any flow in the OM. And the LAD, there is a flow from the graft and the stenosis is 80% at the D1 bifurcation. And RCA is mid-tight stenosis and proximal diffuse disease is there and distal no flow seen except in branch. This is the SVZ graft to RCA showed osteal stenosis and distal also narrowing, and after the graft there is no flow seen in the distal RCA. This is a graft to OM where we have seen stenosis at the osteal origin and also the distal anastomosis site of disease in the OM also. This is a graft to LAD and D1. Graft is patent, but when you see the normal LAD vessel, it showed diffuse negative remodeling and thin streaky vessels as compared to the first angiogram. So I discussed with the surgeon, so what are the reasons for graft failure to RCA? They initially experienced one graft failure to RCA on table and placed another graft also, but not having a clear idea what is the second graft status. And also having difficulty after grafting to LAD, so they face some hemodynamic disturbances even after LAD grafting, but somehow it was settled and they didn't re-explore the LAD graft even after that. This is a discussion between the surgeon notes. So in view of this is his symptoms and decrease in the LV function, as LAD and diagonal flow is seen and OM flow is seen, and there is no RCA flow, so I thought to do initially RCA stenting. So these are the dual contrast injections. I had seen a reasonable good collateral flow from the LAD from the graft vessel rather than a native vessel. So I had taken a dual contrast injections from the LAD graft and the RCA. We are seeing it's reasonably around less than 20 mm stenosis which was seen. There is a distal flow seen into the RPDA and RPLV branch. So I had taken a run-through wire or a microcatheter initially up to the tight stenosis at the graft site. So I initially tried with the Fielder XTR, but I am able to negotiate partially into the distal RCA. After that, I am not able to negotiate distally. So I exchanged whatever the available wire for me is Gaia 3 is available. So I had taken Gaia 3 and I negotiated the wire distally. So the distally wire passed into some branch. It was confirmed with the distal retrograde injections. So I removed the microcatheter and taken a very small balloon, and initially I dilated the balloon so it is going, and then dilated at the tight stenosis where it was very tight. So after that I noticed the flow from antegrade injection, and the wire was in the distal true lumen, and I exchanged the wire for workhorse wire and redirected into the major branch, and then I had done pre-dilatation with 2x12 SC balloon in the distal RCA. It got a reasonable good flow after pre-dilatation, and I proceeded for stanting. So initially I stanted the distal RCA with 2.5 into 48. I wired even the major branch which is giving distally. Then I stanted from mid to proximal RCA with 3 into 48 serial stent at 15 atmos PS. And then done sequential post-dilatation with 2.75 into 12 NC in the distal RCA and 3 into 12 NC in the proximal RCA. So after final stanting and post-dilatation, achieved a good TME3 flow in RCA and all branches. So graft failure rates that are at 10 to 25% and repeat revascularization rates at 2% depends on the type of graft and other risk factors within 1 year. And early graft failure may be due to poor surgical techniques or thrombosis or ischemia reperfusion injury and rapid intimal hyperplasia. The dual contrast injections from native vessels and graft angios will delineate the situ anatomy. Native vessel PCI is better than graft PCI as graft interventions with high rates of distal embolization, neurofilament, pre-procedural MI. And graft vessel sacrifice may be considered to terminate the deleterious effects of competitive flow by case basis. Thank you.
This was how many years post CABG?
So 5 months only, sir.
Okay. So that means a pretty aggressive atherosclerosis.
Yes.
So, but in these cases, you did not think of attempting the osteal lesion in the.
See, even the distal, I feel graft vessels, all three are gone rapid degeneration of the graft vessels. Even if I attempt graft vessel PCI, I feel further degeneration will be there. Rather than that, I thought to open the native vessel, which is better.
Did you ever
because based on first
understand.
angios, what I am seeing, the very good vessels are there in angiogram.
Yeah,
but after grafting, all the three vessels has been diseased very much. So I felt native vessel PTC is better than.
Did you ever think of doing an imaging to check why all this happened?
I don't have such facilities.
Okay.
So I just need your comments on the graft vessel closure after opening the native vessel, like whether to close necessary or we can leave it.
See, if you have a competitive flow, automatically the graft vessel will close. But generally, we have seen that if the grafts have been recruited well over a period, then sometimes they fail, sometimes they may not fail also. You can still see over a long term, both the vessels are still flowing. But in such an early stage, when you have already have such a tight disease at the ostium, you will continue to see the retrograde flow going into the graft rather than antegrade. It will, over the period that antegrade, that stenosis will progress and it will close up automatically.
Yes, sir. That's why.
It was very tight stenosis.
No, I didn't think. I am just asking you any advice. That's why I don't. Yes, sir.
It will keep flowing retrogradely only. So what about the other vessels? You tried the other vessels or you did only the RCA?
Right now only I did RCA, but he may require future interventions.
Because in all the vessels, the LED also you can see after the graft there is a disease. The circumflex also you can see there's a tight lesion there.
You attempted the RCA, which was a very good one, because the LED was already having some competitive flow.
Yes, sir.
But later on, I think
it may also require this.
So one fact check. You said close to 20-25% patients will have vein grafts closed at the end of 1 year, which is correct. No, which is correct. 12% will close, nada band karne se pehle in the ICUs only. But another check, maybe important for all of you. 45% of patients who undergo bypass surgery 45% patients who undergo bypass surgery will have some vein graft close at the end of 1 year.
1 year, yes.
They have 3 or 4 vein grafts. So if you have 3 or 4 vein grafts, then of course the percentage will come down to 20% of the vein grafts. But almost half of the patients who undergo bypass surgery will have some vein graft closed. Let me tell you, so many stents do not close in patients. So if you have to contest against surgery, it is only if you receive an internal memory. If it is a vein graft being given, then of course your stents are better than vein grafts.
What about redo in this patient with?
I think even in the first instance, there was no compelling CTO. It was a relatively smallish last OM, and the only thing in this situation was a large parallel LED D1. If you are confident in doing that kind of a bifurcation lesion, then probably this patient shouldn't have gone for surgery. At least I would have not offered him surgery. I would have told him equal.
Patient is refused at that time.
Yeah, it's okay.
Would have left at that stage.
Yeah, you just leave
RCA
L6.
and LED,
Leave LCX.
Because rest of the things were more or less doable. And you have to realize that somebody who has a dual LED and a lesion at bifurcation, lima will be given to only one.
Yes.
So he becomes a worse candidate as far as surgery is concerned.
Yeah, diabetes and diabetes.
Is it in the recent years we are seeing more aggressive atherosclerosis in the vein graft?
No, they have been like this. This patient was relatively unfortunate that everything closed. So he came to you. Had it vein grafts to circ and other only RCA close and LEDs were otherwise fine, he would have not come. See, many times after surgery, you just take care of the sensory system so well, the surgeon once doing surgery, that sensory system is gone. And he gives you a pain of this sternotomy, so he forgets about the inguinal pain. वो होती नहीं उनको बिल्कुल भी. So they remain. So angina relief is always more after surgery.
Sir, I just want to know your experiences, like how many surgeons are doing the total revasculature? Because when I'm discussing with my young
Total or total arterial?
Total revasculature, not arterial, sir.
So if this circumflex kind of a thing is concerned, let me tell you, most surgeons will leave it. Most surgeons will leave it. They just look at a good arterial graft put to the LED. And after that, they have assistants. Laga dena beta.
As they want to do more of beating heart, so don't go posterior.
Yeah.
I think we can go to the next case.
Thank you, sir. Thank you very much.
Dr. Siddharth Tayan, step-by-step reverse cut.
Good afternoon, everyone. First of all, thank you for letting me present my case today. So he's an elderly gentleman who has significant symptoms. He has a lot of comorbidities. Previously had claudication. Now claudication's gone because he's started developing angina. Before that, he's a short of the peripheral system. SFA is occluded. We also see there's a stent over there, which is also occluded. So when you see this, you know that the coronaries are going to be hell for us. So moving on, took a shot of the coronaries. We see diffuse disease, calcification everywhere. There's a lot of stenosis in the LED proximally. There's a lot of proximal stenosis in the diagonal and in the circumflex. And then if you look closely, the right coronary artery is filling through collaterals and it's filling up till the crux. So looking at the right coronary artery, this is the silhouette. We can see there's heavy calcification from the proximal right coronary artery up till the crux. It's tram track calcification all the way. Luckily, there's not significant tortuosity over here. And if we look towards the top right of this shot, we also see the left system's heavily calcified. And like Dr. Trehan's always taught me that whenever you want to see calcification of the left system, always look at iliocranial for the right and you'll see calcification in the left system. So heavy calcification all around. And this is the RCA. So distal cap close to the crux, proximal cap in front of you. Probably this is the longest CTO segment, which has been showcased at ijcto. And heavily calcified, probably a blunt proximal cap. JCTO is obviously very high. And considering such an anatomy, because I can keep my catheter there at the ostium, I do see tram track calcification. Would definitely start with antegrade first and keep a very low threshold to switching over to retrograde whenever I need. So started antegrade. For all complex cases, I prefer going femoral. Used the 7FAL1 because I was pretty sure I would need a lot of support. My microcatheter was Caravel. Used a Whisper extra support wire because that's my first wire when I use for all CTOs. The wire was not progressing despite a lot of try. Eventually got a guide extension in, and we had a balloon as well, so that I could just probably dilate the proximal part a little bit. Finally, with a little bit of maneuvering, my Whisper reached the mid RCA, which allowed me to maybe dilate the proximal part a little bit. And here we can see the guide extension catheter. We tried inchworming. It's still kinking a lot, so that's telling us the amount of resistance that was there. And still found a lot of difficulty, but eventually did manage to get the wire into the distal RCA. So dilated the proximal part as well. And now that my wire was in the distal RCA, I was trying to hope that my wire will break through into the luminal space. But unfortunately, my wire started buckling close to the crux. Now the problem is the wire seems like it's wrapping around the artery. And there's also a bifurcation at the distal cap. And when there's a bifurcation at the distal cap, I don't want to break into either of the arteries because then I'm probably going to lose one of the branches. So try to do maybe a parallel wire here, which was again being a little hopeful. Brought down another Whisper. Unfortunately, because I dilated the proximal part, that Whisper kept going into the same track. And once it reached close to the distal cap, I thought, let me just now, because I'm somewhere close, let me just take a retrograde injection and see. So here's the retrograde injection on the right side of the screen, and we clearly see that there's a bifurcation at the distal cap. My wire was definitely wrapping around the artery, and it was sort of like very difficult. I still tried, maybe the wire might go, but the wire was still sticking a lot in the proximal segment, so I thought, let me just dilate the proximal part. So I dilated the proximal part with a 2.5 millimeter balloon. That did allow my wire to be a little free and, for me to maneuver it a little bit close to the distal cap. Got a little aggressive, got a little, just with the rush, I tried to do a little bit of power wiring. And unfortunately, you know what the problem is with power wiring. The wire is just going to have a lot of tip load and it may just exit. So at this point, I felt that the wire has exited because it did just go out a little bit and then I had to pull it back. And I was like, fine, my proximal antegrade part has been done. It's not an issue. Let me just switch over to retrograde now. And now, because I had probably visited the pericardium, I did not want to do retrograde in the same setting because I don't want to risk a tamponade. So took the patient out, reversed the heparin, and called him 2 days later. So now we're set up for going retrograde. I took a femoral approach, used a 7 French EBU system. Started with an injection of the left system. We see there's a very good septal, first septal, which is connecting to the distal RCA. But there's also a lot of disease in the proximal LAD, and it's heavily calcified. So to start off, first did a selective cannulation of my first septal, did a tip injection. And one thing to note, whenever you do any sort of tip injection anywhere, always aspirate your microcatheter first. Because if you do not aspirate your microcatheter, you're probably going to finish your case right there and then itself, because you've done a Carlino while not even knowing you're doing a Carlino. So anyway, so my first septal has decent connections, and I've chosen that one as my go-to septal for my retrograde crossing. But before I do that, I want to make sure that my proximal LAD is dilated. I cannot afford donor artery ischemia in this case, because donor artery ischemia is end of the case, end of the patient, everything's over. So opened the proximal LAD, then got my Caravel into the first septal, used a Sion black wire. If we saw the septal shot previously, it's quite a little bit tortuous, and the septals are very small and have significant bends. So use the Sion black. It took a while, but my surfing finally helped me, and I reached the distal RCA. And once I'm in the distal RCA, now I'm a little comfortable. So now, considering the calcification and the tortuosities in the septals, it wasn't easy to get my Caravel down into the distal RCA. But then with some guide push and a lot of counter and clockwise talking, I did manage to get my Caravel into the distal RCA. And when I'm there, now I know, considering I've already prepared an antegrade bed, I'm set up for a reverse cart. I'm comfortable right now. So I taken a 7FJR from the right radial system, and now that's my antegrade catheter, and I'm set. My catheter was just facing the conus first, so I just put a wire in the conus, disengaged my guide. Now I took a second wire into the anti-grade system. And if we see on the second side, we have the anti-grade wire which is coming down. And when we look at the two wires, the anti-grade and retro wire, both of them are dancing in sync, which is telling us that they are in the vessel architecture. But because they're on two different sides of the wall, that's also telling us they were in two different planes. And there was no way that I could have crossed this anti-grade because I'd been going on the greater curvature of the vessel. So here we can see on the right side that I did take my guide extension down, took the balloon down, did a classic guide extension assisted reverse cart. So after doing the guide extension assisted reverse cart, my Sion black wire progressed into the guide extension catheter. And if you look closely, there's a balloon as well in the guide extension. So with that balloon, I trapped my wire there. With the trapped wire, I pushed or progressed my caravel into the guide extension catheter. And once that's done, now I'm set up for externalizing. So I externalized an RG3 wire, did my initial pre-dilatation on the externalized wire with a 2.5 millimeter balloon. Once I'd done my initial pre-dilatation, I took down a workhorse wire and did subsequent pre-dilatations. Then I just put in 3 long stents, which is probably the easiest part of the case. And once all the stents were put in, this was my final result. I do know there's another CTO in the PDA, but I thought I'll probably come back to that another day. My patient was better, comfortable, most importantly, no complications as of now. Got him out of the lab, and I think decent result, except for maybe a little bit of stent under expansion due to calcification. So the key points for this would be that such a long, tortuous, calcified CTO segment is almost impossible to cross luminally. But you still can try it. The best way to usually do this is doing it with a short knuckle. Preferred wire in current times is a Gladius Mongo. Otherwise, there is a chance that your wire may visit the pericardium, which probably did in my case as well. If ever there is a doubt about you having visited the pericardium, stop your case. You can very easily reverse your heparin, come out. Unless you have not taken your bigger hardwares through it, it's still forgiving. So reverse the ACD, come back, do it another day. And while doing retrograde collateral crossing, please respect the collaterals, because any sort of injury to the collaterals is going to cause ischemia to the artery that you're trying to fix. Preferable wire for crossing such collaterals is going to be a lightweight polymer jacketed wire, unless there's insane amount of tortuosity, when a SUO3 would be a very good choice. And like I mentioned previously, donor artery ischemia is something that should be prevented at all costs. Any donor artery ischemia, any tip dissection, any ischemia in the main artery is just going to be catastrophic. So now this is a line which I say that a CTO never ends till the artery is really open. So I want to talk a bit more about this. When a lot of us talk about that, my case failed, it did not work. That's incorrect, because the case did not fail. It's just that technique at that point in time failed. So as a CTO operator, we must be well versed with antigrade wire escalations, antigrade dissection re-entries, retrograde wire escalations, retrograde dissection re-entries, when to call it an investment, when to maybe, send the patient back home, call him back later, and just know when to quit, and also be able to manage complications whenever they come along. And, and a live patient with a closed artery is always better than a dead patient with an open artery. So that's about it. Thank you very much for your time.
So what about LAD? Did you dilate something?
I did later. I did a rota and then stented the LAD.
LAD. The same setting or like next setting?
Patient's creatinine was a little off, so I did it later. In calcified segments,
You dilated something, no, in LAD?
So what? There's no dissection. You have an IVUS and did an IVUS. So
Did you do any imaging?
Yeah.
This case?
Yeah.
Imaging.
90% of my cases are with imaging. Do not like to not image. Third eye, always use it.
See, I just wanted to ask you about the choice of wire which you took for the antigrade, the whisper wire. I'm not sure how many of us with such a long CTO would take a whisper as the starting wire.
I
because there are so
100%
many,
agree, sir. But
because
it's
nowadays
about
with
the
all these
training.
Asai wires
It's
which
about
are
where you're
available.
trained.
Antigrade was tried by me.
Yeah.
And next day I was doing other CTO when he finished his retro on this side.
Then second thing is,
I usually try this
when we have crossed this antigradely to some extent, and we are not able to go, we know that in the distal part we are almost at the outer curve.
Yeah.
When you saw that injection where
Yeah,
you can see the calcium tracking and the wire is outside.
buckling and it's wrapping
Why
around.
we did not think of pulling the wire back and change to a little stiffer wire which has more turkability like a Gaia second or a Gaia third, which you can easily maneuver. And because you have a tram tracking calcium, you can know whether you are in the outer car, you are going out or not. You can still keep it in the center of the wire, and those wires have a 1-to-1 torque, and you can easily go through rather than, because whisper will continue to go is the easiest part.
So at
That's
this point,
probably the reason why it just went out of
out
of the artery.
It is one of the ways to go about it, but like whisper went out, a sharper wire would go out more commonly.
No,
And
see,
so
you have to understand, see, there is a difference between a whisper and a sharper wire. The whisper wire, the tip torqueability is different. It's a polymer jacketed wire.
Yeah,
It's a
but
very
my proximal
lubricious
part
wire.
is dilated,
You
so I
will
don't
not
have
have
an issue.
tactile sensation where it is going. But in a Gaia 2 or a Gaia 3, it doesn't have that polymer jacket which
So,
is at the tip. It is, you can still feel the tactile sensation, and you will be able to rotate it, and that is why whisper is
Sir,
similar to your Fielder XTR or XTA, which are almost similar wires.
so in a long
Wait,
segment
wait, hold
CTO,
on. See, when you are taking a long CTO which is so much of calcium, you know the whisper is not going to take the track which you want, because the calcium and the stiffness will prevent it from puncturing it. You need a stiffer wire. You cross the proximal track fine, but long CTO with a whisper, I am not comfortable, because there are so many other experts. They can also
so
come into
ideally
it.
we should go with the Gladius Mongo. So the point about tactile feedback, if your CTO segment or plaque has been dilated a little bit, you will get your tactile feedback. And if it's such a long segment, even if it's my Gaia sticks more in segments, long segment CTOs compared to a polymer jacketed wire. So, I mean, I agree with what you're saying, but in such a case, the other option could have been just throw down a knuckle. Finally, if eventually I had to sort of, puncture
Once
through.
again, knuckle is again going to create a subinterminal dissection and all this thing. Here you are not wanting that. See, if you take a microcatheter and take a Gaia or something like this, the tip which is there, you can manipulate the tip in the middle and keep going with the help of a microcatheter. The choice of microcatheter of Caravel, I'm not sure, because such a long, hard calcium, you need a catheter which has more pushability, like a Corsair.
Tonus or
Corsair
Turnpike
would have
Gold
been a
would have
much
been a better
better,
one.
not even the Corsair XS. Corsair XS is
that
more
is
for the fine cross.
Tonus
Corsair
or
XS,
Turnpike Gold
Caravel
for this
are
would be
more
good.
for the tortuous and flexible, because they don't have that pushability. A simple Corsair Pro with a crossing with any wire which you want, whether it's a Fielder XTR or a whisper. And once you're in the CTO segment, take a little stiffer wire so that you can torque your wire properly with the help of microcatheter and go. That I would have preferred rather than that.
See, as far as the microcatheter is concerned, I think it was not at all difficult. You have seen that I had walked with a balloon and even with a guide extension till almost short of crux. Now the issue here was the whisper was visiting outside the bounds of the vessel many times and with great ease. In such a situation, it was not at all difficult to deliver any microcatheter close to the crux. If you look at the vessel which is filling retrogradely, it is just at the bifurcation. There is not a big stem of the vessel in the AV groove. If you had that, then it would have been pretty easy to escalate it beyond your whisper wire and try to get back. But because the wire had moved out of the line 3 or 4 directions and the target was at the crux or beyond, so I thought it will be probably better that we go retro rather than continuing antigrade. And since the wire had visited outside, so probably don't go retro right now, because if you go retro right now, sometime your procedure will be successful, only couple of hours later you find that that bite of the whisper wire creates a problem to you. And it was already late in the evening. So I said, in the interest of safety of the patient, stop it, come back the other day. So other day, I think things were relatively easy. They were, because a lot of work had been done. See, the point here is that in the absence of imaging, in the absence of best of the catheters, in the absence of Mongo wires, if you have a heavily calcified wire, a heavily calcified vessel, even with some tortuosity, a careful inch by inch progress of your wire, followed by a microcatheter and or dilatation with the balloon and then with a guide extension will make your way. And ultimately, if in this case there was a sufficient vessel size proximal to the bifurcation, means AV groove proximal to the bifurcation, we would have just ended up the same day. But because the wicket was very difficult to bat on, and the second thing is, if you look at the PD, even after the result, PD is only a short distance which is filling antigravity. Rest of the PD is again bad. If the PD was good, it is possible I would have ventured in the same sitting deep into the PD. But because the distal target was not so good, PD was also only, PD is fully diseased, only a few millimeters of, maybe 3 centimeters of PD is filling antegrade liver disease. After that, the PD is totally knocked off. So I thought, come back the another day. And I think the point in this case is, the whispers can be used through all this. You do not need very heavy gadgets.
sharper wires.
And whisper with a microcatheter with some way, and pull out the microcatheter, take a balloon, keep continuously dilating, and have your guide extension moving. That will be kind of, if my guide extension, like, see, next time this task was very easy because the preparation or the investment had already been done.
The first wire would have been a fielder.
Yeah. My workhorse wire is whisper, and I do most of my CTOs with whisper. Antegrade, retrograde, all of them with whisper.
I think we move on to the next case. Next presentation by Gautam Swarup.
With this, we end our CD presentations actually. Now we have regular talks from now. If any person who is not presented his CD wants to present, he can be allowed to present. If not, we'll continue with the talks. Thank you.
So thank you and gratitude for the organizers to giving me the opportunity. A lot of good cases we have seen right from since 2 days, and I have given the topic of the osteal CTO PCI. So again, the challenges of the osteal CTO PCI is totally different. We most of the time encountered the ambiguous proximal cap, large size branch, mainly LCX, most of the time sizable LCX that is emerged from the distal left main. And again, we most of the time encounter with the anatomical ambiguity, multiple side branch parallel to the CTO segment. So we have to carefully analyze that the which branch we have to try for the antegrade escalation and again the retrograde. So these are the basic anatomical challenges of the osteal LAD CTO. Definitely the large myocardium at the risk, any false wrong strategy or any wrong method that impose the patient any time with the occluded circumflex or left main. So we have to carefully analyze the meticulous LMCA and the LAD anatomy. And again, most of the time you need to have a retrograde gear, and you should have a rich experience with your retrograde strategy. So these all things should be kept in mind while attempting the LAD osteal CTO. So again, the basic approach is like if you are attempting this, the key step is most of the time if you want very precise, you have to have IVUS. And again, if you are thinking that your cap is ambiguous, definitely you have to go to the retrograde. And again, you have to very be precise regarding the which point you are your reverse cart positioning. So you need to have a guide extension catheter to mark the precise localization of the reverse cart. So these all things are the basically procedural planning if you are doing the osteal LAD CTO. So you need specific tools, like you can have a 7-app at least, or if the LMCA is good, you can 8-app guiding catheter if you want to do the IVUS guided puncture. Then you need to have a dual lumen catheter, either Sasuke or Crusade. Then IVUS is mandatory tool if you are be very precise. We have a lot of talk inside CTO regarding the IVUS guided puncture. And again, you need to have guide extension catheter to for a extended reverse cart or a guideliner based reverse cart. So these are the specific tools that you should have in your cath lab before attempting the osteal LAD CTO. I will start with one case, And this case is the patient having the ambiguous cap. There is a very faint channel that you can basically assess, and we are not very much sure that the is it the true osteal CTO or is it some small branch. And again, if you see the collateral are still there, but again, you can try with the antegrade wire escalation, but you should prepare for the retrograde entry as well. So these are the analysis, and again, we went with the this is the angiographical analysis. You can appreciate that the LCX is again disease right from the ostia. Most of the time, if you see these kind of the cases, they involve the LCX as well. So you have to prepare for the bifurcation. This is the retrograde, and this is the spider view, and this is the. So you can appreciate at the very distal end of the this CTO there is a bifurcation. So definitely we will struggle right from the proximal cap puncture to the distal cap puncture, and you have to prepare your policy accordingly. So we took a fine cross microcatheter. Definitely in these kind of cases in which you have a tiny channel and you just want to test the swell, you should have the low profile of the microcatheter. So we started with the fine cross, took the Fielder FC wire, but most of the time you start struggling right from the beginning because your wire is not going to the precise direction. Definitely it is going to move in a larger artery. So despite of the various struggle, we got the proper channel, and we throw our microcatheter there and we fix that. Then again we escalated the wire with the fighter, but at some point of time we were not able to move further because the lesion was probably calcific. So again we took the pilot, and the pilot made his own way. But again the problem with the pilot is it is not having so much this controlled movement as the Gaia series, but again we were able to pass the lesion, but again we are in the side branch. The microcatheters most of the time in the calcified lesion, and sometimes you use Ox hardwares do not go, then the basic idea is to dilate with the minimum possible balloon, and again I took another wire, that is a Fielder FC wire, and then I tried to rewire to the main LED. So after this, the pre-dilatation, we have to make the policy of the bifurcation, which way do you want to do. I've choose the mini crush, and then you can appreciate the various steps of the mini crush here. And this was the final result. So this was the case, that was the osteal LED, faint and dubious channel, and we attempted this case in a antegrade fashion. So my second case is again a similar kind of the case, but again there was no clear-cut anatomy, as you can appreciate. You are not able to show where the origin of the LED, where it is this or this. So these kind of cases, again, there is less chances that you are going with antegrade and you are able to successful. So ambiguous cap, uncleared course, long segment, bifurcation at the distal end, but again the retrograde collateral is good. But it is visible that in certain these kind of the cases you should attempt directly retrograde rather than going into the antegrade. So we, right from the start, we take the retrograde path, and with the this Caravel catheter and this wire we went through, and then with the Gaia 2 we entered and we crossed the CTO segment. But again, this point is very crucial point in which it is possible that you are not entered to the desired track. You might take the subintimal channel, And if you dilate these kind of the lesion without evidencing with the IVUS, it can be a catastrophic for you. So again, we externalize the wire, but we didn't pre-dilate until we get the IVUS confirmation. We pass the IVUS at the side branch and we confirm that we are entered through a true lumen, and then we basically dilate it, and then we complete this case with the mini crush. So this was the final result. So again, the take home message with the osteal LED, that the approach of the osteal LED CTO, it needs special attention in terms of the hardware, in terms of the planning and the strategy. And again, IVUS guided anti-grade cap puncture is again, it is mainly essential, which also acts as the anti-grade preparation with the retrograde approach. Guide extension, again, it is a very important part of the osteal LED CTO, either in the reverse cut or the anti-grade preparation, and it poses you the favorable retrograde wire entry. And again, you need to be prepared for the bifurcation stenting, and it needs to be the dynamic and the decision-based planning, mainly on the IVUS. So thank you. Thanks for your patient listening.
So the key point in Dr. Swarup's, first, very, very nicely done. The two things, when you're dealing with osteal stuff, I think it is critical that what you talked about imaging to confirm that you didn't go subintimal, and because that would be catastrophic. I think that's a very important point. And the other thing that he did, which you didn't specifically state, was having a wire in the in the ramus or in the circ. You always should have a safety wire, especially when you're dealing with osteal stuff, etc. Because in case something happens, you misinterpreted the IVUS, etc. That's your lifeline. So.
Yeah.
Good job. Nicely done.
Sure. Thank you, Dr.
And thirdly, if you have wrongly entered, let's say you entered
You have told the
no,
previous
that's
presentation again the same cutting balloon concept.
So if you have wrongly entered, have a cutting balloon ready with you.
Yes.
Yeah. That will kind of
that was a very
bail you
impactful
out.
presentation for the younger generations guy. That cutting balloon, it should be ready for that.
Because if you look at your crossing, retro crossing.
That is what I'm saying.
If you look at it,
yes, it was not
the
seen
lumen is above and you are crossing below that.
So we are not sure at that time. So without doing or confirmed IVUS, you should not pre-dilate these kind of lesions. You never pre-dilate.
Or sometime you can pre-dilate them with 1.5 millimeter balloon, no problem. And then you can take an IVUS rather than into circumflex into the LED only, LED D1. So that can give you a fair idea about your distal LED beyond the diagonal, prox LED and the left main. So at the time when you're coming back, you have to put a stand, you know a fair idea about how the playground is.
Yes.
So even you can pre-dilate with a 1.5 millimeter balloon, no issues, absolutely no issues. But you should not kind of fully dilate and then put a stand there and make it a covered stand in front of the circumflex.
So anytime you have to do the IVUS, so why to pre-dilate? First do the IVUS, then do anything.
No, 1.5 millimeter balloon to have your IVUS go, because many times we are reusing the IVUS. So if you take a new IVUS, it will go. But if you want to reuse the same IVUS, you can pre-dilate all these things with a 1.5 millimeter balloon. Nothing, absolutely no problem. If you are on a subintimal plane in left main, you dilate that subintimal plane with a 1.5 millimeter balloon, nothing will happen. Only once you have a stent which is the size of the left main. Then of course things will be bad. Short of that, nothing will happen. And once you have safety wires in circ and diagonal, nothing can happen. But even if I have a safety wire, if there is a flap in front of it and that flap gets outside the stand, nothing will happen. You cannot do anything. Even a cutting balloon cannot do anything. That you have to do, you have to kind of preempt first.
Thank you.
Next session is by Dr. Arun sir, instructing CTO PCA.
Good afternoon, everyone. So I'm not sure why I'm presenting here, but I'm happy to present. So I've been asked to present an ADR case, so I just thought I'd kind of give you a glimpse of like two interesting ADR cases, which okay. I mean, I think it's within the realm of possibility. The thing about these two cases was that I kind of thought, okay, this is not going to be too hard, and that's, again, we all know. I mean, we always tell people any case can go anyway, et cetera, but you know, it's one of those things where you think, okay, I'm probably going to get this done, like, really quick. So anyways, so it is important to know that although antigrade usage is increasing, this data from the Progress registry that we just published earlier this year, And but I do want you to know that antegrade doesn't work, especially when you have proximal cap ambiguity, blunt cap, when you have longer lesions, all the usual suspects when you have tortuosity. And interestingly, when when you do have a good landing zone, antegrade actually works better because you can typically end up parallel wiring it or something like that. So this is an old bypass graft which is kind of degenerating, failing, and they tried to open it, couldn't, etc. So we just ballooned opened it. That's the RCA CTO itself. And on retrograde, I mean, as you can see, it's there, but it's like, okay, this is not super hard. And by the way, I'm showing you a slightly older version of this talk because my file got corrupted, so I just had to, that's why I kind of switched the order, etc. So I apologize if it's not the most current version. But the long and short of it was that I kind of thought, all right, I'm going to do this as antegrade wire escalation. If that doesn't work, then we'll try some kind of a antegrade parallel wire redirect, something like that. Doesn't work. I got a decent landing zone. It didn't look terrible, so I thought I could probably do ADR. I've done a lot of ADRs, and I should be fine. If that doesn't work, I still got retrograde. And yeah, and that's that. So I kind of thought, all right, this is the sequence in which we're going to go. I'm sorry? No. Oh, yeah. That's certainly like that. Those were all there, options. So started wire, didn't work. That's what you see up there is with the dual lumen catheter, parallel wire, tried really, I mean, I'm kind of like going through stuff really fast because I'm just bored. And then I tried, okay, I thought it didn't work, so I just got a knuckle going. Interestingly, and I didn't want to go too far down, so I'm trying ADR here. That's a stingray balloon in the wrong projection. There, I thought I was in, but I actually wasn't. So the long and short of it was, my options 1, 2, 3 all failed, but I failed fast. The thing is, fail quick, fail efficiently. So now I thought, okay, let me just switch, let me just go through the graft. I've already done all the antegrade work. I'll just go through it. Getting in through the graft was a bit of a, actually, the anastomotic site and making that turn was a bit of a challenge, but I was ready to use a dual lumen catheter, but then it just went. So I'm like, okay, now I'm in the game. It's not too hard. I should be able to do reverse card pretty fast. And so there, I tried reverse card. Interestingly, we always think longer lesions are harder, but when you're doing reverse card, it's actually easier to do it in a long CTO segment because you can do it anywhere within the body of the CTO segment. So this is some variation of an extended reverse card or wherever, but I tried, this is just a snapshot showing you that I tried in multiple segments. And I wasn't making as much progress, and it was like, okay, not working. But then I kind of thought, okay, I'm just going to flip the whole thing, put the balloon retrograde. So this is going old school. So what we did was, I just got the balloon retrograde. I mean, this is just card, but now what we can do is, I already have a stingray balloon, so I didn't use new equipment for this. So take a balloon, go retrograde, balloon it, and then basically use your antegrade stingray to basically re-enter into the true lumen. So, and I mean, the rest was just PCI. You exchange it for a workhorse wire. Once you're into the true lumen, confirm that. So now you'll just see the workhorse wire coming in at some point there, hopefully, yep. So, I mean, the rest was just the case. So this was done. I didn't have to coil. The graft was already dying, so just let it be, die a natural death. So the key points are you go through your options fast. And and this was an options case. But I think it was kind of like, for me, the take home was like, I kind of underestimated how hard it was going to be. This was another case, and this is from like maybe 3-4 years ago. And this guy had to do it in another hospital because of insurance reasons. And I'm sorry, like all my blacking out has not come through, so I apologize. But this was a prior attempt, LAD CTO. Again, I knew a decent operator had attempted before and failed, but I thought it's like, okay, it's not a big deal. This is just a short LAD segment. I'm like, what's the big deal? How bad can it be? So I knew the proximal cap. You can kind of see it up there. I'll see if the arrow points. It's right there. Shouldn't be too hard, right? Distal cap was like this, a small branch, which I thought I could live without. And the CTO segment itself is short, so I'm like, no big deal. There was some calcium, but such is life. So plan was wire escalation, doesn't go, maybe go retrograde. If that doesn't go, do ADR. The best collateral was probably an ipsilateral collateral from the diagonal. So once again, started wire escalation. I could not even penetrate the proximal cap. I mean, I knew this was 8 minutes, so I think I'm good. I'm not showing you the various failures, but wire escalation basically didn't work because I just couldn't penetrate. And at that time, the hardest, they didn't have a 820, was a CP12 with guide extension catheter, with all the stuff for increasing backup, fail, fail, fail. Then retrograde wire escalation, I managed to wire it. I got in, but I could not get my retrograde microcatheter into the antegrade guide, which is what you need to do. I think Siddhant just showed for your reverse card, right? So good job. So it didn't work because I just couldn't get across. I did tip in, got an antegrade microcatheter. I still could not get anything to cross that one bad area. And such as luck would have it, this is a big hospital in Chennai, but like for some reason that day we didn't have rota, or it wasn't available or whatever. And so they were like, okay, because I thought I would just pull out everything, put a rota wire, drill the thing, and be done. And this is before laser was even launched in India. So what I basically did was here, you can kind of see the wire go all the way. I mean, this is here. So I kind of said, okay, I'm going to use my retrograde wire as a marker. And I'd already knuckled, etc. So antegrade, I just decided to go subintimal, bypass this one area where it's like supercalcific. That's just this thing right. So here. So right side wrong projection, left side correct projection. You can actually see the, so this is the ping pong guide, obviously. Diagonal, blah, 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 into the LAD. You have the wire in the LAD. So I know what my target is, and that you can really see it in the projection up there. So you're basically using a retrograde as a marker, and then this area, which was like impossible to cross because of calcium or something evil there, you just bypassed, you went into the subintimal space, and then you just re-entering, and that's a stick and drive. And so then the rest is just you're advancing your microcatheter across it. Because once this one area was crossed, the rest was actually fairly easy. And once again, just exchange for a workhorse wire, imaging, blah, blah, blah. And then it was done. So the key points are when reverse cart fails, you could actually use your retro conduit as a way to basically cart is still not dead. Let me kind of take a step back and say this. Cart still has a role. If you haven't done a lot of retrogrades, you could still take balloons over failing grafts, because your bailout is if you're failed in your retrograde, you can still stent the graft and walk out. Just don't stent the anastomotic site. So that's one option, right? The other thing, obviously, there are lots of cases where you have to go retrograde, and you can take balloons. I've taken 3.5 balloons through septals. You can actually take it through epicardials. You just have to be careful. You still have, I mean, I'm sure Dr. Trehan's done this crazy stuff. So you can do over-the-wire balloons. They generally are better, more pushable. Avoid RX balloons if you can. So I still have a couple of OTW balloons in the shelf just for this purpose. So you can, and the other simple thing is to use your retrograde wire as a marker. And when do you use that for doing antegrade, either parallel wire or ADR or anything like that? When you want, let us say you've just given heparin, and I think this is distracting, I'll just stop it. Okay, when you've given, let's say heparin and your anticoagulation is not great. Or the second thing, when you're taking a microcatheter retrograde, patient has hemodynamic compromise, low EF, etc. These are cases where it's actually a good idea to use your retrograde wire as a marker and then somehow finish the case antegrade because the risk is much lesser. So anyways, that's that. Thank you. Are we good? Okay, thanks. If this completely went over some of the fellows' heads,
any questions? I think it'll be interesting to ask him questions.
Two more talks are there.
Two more talks are there.
Next by talk by Dr. Hanumanth Reddy regarding role of cardiac CT in CTO procedure planning.
Good afternoon all. Respected Vijay Teran sir, Purohit sir, Gautam sir, and all my colleagues. We will be seeing role of cardiac CT in CTO planning. In general, the talk will be how the cardiologists need to use the CT in day-to-day practice. If you come to the advancement cardiac imaging which was taking place, the advancement in cardiac CT is taking at a faster rate when compared to any other investigation. If you got an echo in 1880, it came into clinical relevance after mostly 50 years. But if you take an X-ray, it came within that 40 years. But if you take a CT scan, 1960 once it came into a clinical trial, by 10 years it came into a practice. The advancement CT, if you see initially we were discussing about 4 slides, 16 slides, 64 coronary CT. Nowadays, even single breath hold, you can get in a 360-degree volume scanner. No need to do for any breath hold. The heart rate control is the only thing, still the limitation. But even then, that can be come down. Canon scanner, water 360 volume, just the patient lies in the table, 1 second shot out, and he will be giving the result in the next 5 minutes. That's the way the advancement is taking place. You need to be thorough. What really the CT is going to tell for a cardiologist or intervention guy is whether coronary blockage is there or not. We are good at ruling out. Negative predictive value of CT is very high. If it is there, we are in a doubt that it's a mild, moderate, or severe. But if it is a severe, we need to be confirmed with a coronary angiogram or invasive coronary. But if it is not there, you can certainly say that patient, you are very good. Your detection negative predictive value is very high. No need for further test. But if it's any moderate or it's a severe, depending on the patient clinical condition, if he is having any angina or other imaging tests, they should go for an invasive angiogram. Next, if my future prediction will be not wrong, the AI is going to take role of a CT reporting. Next 10 years, most of the job is done by screen by even the radiography technicians. Then if it is only positive, then he is going to enter in a cardiac suit. And other things where we are good at detecting in a fatty deposits. We are not good at calcium deposit because of a calcium, because of white blooming artifact, even if it a mild lesion, because of a calcium, it can show in a moderate or a severe lesion. Once you do a coronary angiogram, you will talk to your radiologist or the cardiac imaging guy, you say that the lesion was very simple, but while you're reporting in a cardiac CT, you cannot clearly delineate it. And other things, what you are doing for a screening where software guys, when they're less than 40 years, it's like coronary calcium score. Now it's already entered in the insurance sector where they are giving, and even in small hospitals are doing in a multi-MNC job, they are even doing a coronary calcium score just to see the fitness of their life when they are giving a lifelong insurance. So you are going to report this coronary CT's calcium scores. Whether it is the atherosclerotic plaque in coronary artery, whether you are evaluating for coronary arteries. When you are coming in other part of an CT, aortic aneurysm or the TAVI and other structural heart interventions, TMV, where it is going to play a role. The most important diagram is we are good at ruling out if there is no coronary artery disease, it is good. The way we stuck is there is a non-obstructive coronary artery disease. Nowadays, the FFR CT is going into plan error. Still, it is going to hit the market because of the cost issues, and it is only the only few company, one company which you are doing. You need to do a data set DICOM. You need to send to the US, and they will be giving the result. It is very costly. That way, the FFR CT is not hitting. But the FFR CT once going to hit the market, most of our invasive angiograms is going to be decreased. When the FFR CT is more than 0.8, I am absolutely fine that there is monitoring of plaque progression if you are going to give any lifestyle modification. Other thing is, if a functional disease, whether functional 1 or 2 vessel disease, once you diagnose a CAD, functional severity assessment, then you are planning for a PCI, it is going to. And the last thing is CABG or a PCI, if it is a triple vessel disease on a CT, if it is associated with LMCA or triple vessel disease, then what the role of CCT8 is going to decide is, nowadays the trial is going on. Before CABG, even in younger setup where we are doing invasive coronary angiogram sending for surgery, for all patients they are doing in a CT CAG. If there is no any coronary artery disease, directly they are taking into for a CA, other MVR surgery or other. Still it is going to hit in other things when because if positive predictive value is going too high, they are going to even do it for other diseases. And mostly threat and exclusion of CABG. This is the most important slide which has changed our practice. And this is the most important thing. Once the ischemia trial has came into once it is launched, it has changed our practice how it is going. If any patient comes to your chest pain, you are not going to want to any soup, just do a CT CAG. If there is no LMCA disease, you can keep him on a medical management. There are many fallacies about these studies, but this is going to be changed. If there LMCA disease was there, he is going for invasive coronary angiogram and the treatment is appropriate. If there is not an LMCA disease, you are going to an ischemic trial pathway, you are going to do a CAD-RATS, you wanted to see whether a CAD-RATS 1, 2, 3, 4 or 5. CAD-RATS 1 indicates it's a mild disease less than 25, CAD-RATS 2 is up to 49%. Still up to CAD-RATS 2, still 49%, you can do a risk factor control and secondary prevention. If it is CAD-RATS 3, where the lesion is 50 to 79%, 50 to 69, this is the where the FFR-CT is going to tell you. If you really wanted to stent, you can go ahead with an SFR-CT. If it is positive, you take him for an invasive coronary. If FFR-CT is negative, just monitor him the progress. If CAD-RATS is already 4A, already more than 70% stenosis, this is going to help you planning. What is the way it is going to help in planning? I can assess clearly delineate the plaque pathology. It is still going to come whether it's a lipid laden, what's an ischemic, or it's going to a calcific. If it's a lipid laden, you are going to expect slow flow in your thing. So you can plan, okay, this patient is getting to slow flow. I need to be cautious, or you're going to intracoronary vasodilators, you will be required. If it is CADRATS 4A, it's an ISR. The ISR, still the CT is going to, it's not good. The photon CT which has came into the market, it is hitting, but still because of radiation is very high and the cost is very high, we are not using the photon CT, is only available in the fee centers. And the CADRATS 5, what we are discussing for today is the CTO. So once the patient surpasses this all in his lifetime, the CADRATS 5 is the one which we are dealing in our ijcto. But the junk of patients, what you are dealing with, your setup will be 95% will be, you will be stopping 50% will be CADRATS 2, only 25% will be CADRATS 3 to 4A, only less than 5% will be CADRATS 5. Mostly the CT takes a role, this 50% will be junk, will be lost by the coronary people. What the CT coronary angiogram is stated, mostly diagnosis of CTO, it's a CADRATS 5. It's a non-invasive imaging modality. I can know the extent and severity. We can know the assess plaque morphology and composition. Diagnostic accuracy of CTE as good as compared to invasive angiogram. It may not be 100%, but it can be on par. Most important limitation with this modality is calcification, blooming, and difficulty in visualization of the lumen exists. Most important CT coronary angiogram is because of an retrograde collaterals, you may not able to delineate the how much is the extent of the pathway correct CT is there when compared to an invasive angiogram, but it can give the good distal architecture. The CTCAG, because how you are going to diagnose CTO in a CTCAG is, once you scroll the dicam images, there will be lumen will be with, it needs to be opacified with the contrast by the absence of lumen opacification. Most important thing is due to retrograde collateral flow, calcification of artery next to stenosis. So it is mostly underdiagnosed. You may not able to see the correct delineation segment of the how much CTO length is there, which you are able to see an invasive angiogram, but it is going to see the distal vessel. The new CT scanners, as it is a volume scanners, is a single breathole you are able to do. And nowadays, because of many software reconstructive programs, you can able to track the CTO segment, and it will give the automatically the computer does the role, and the 3D volume rendering and CTO easily. Software for vessel diameter analysis and vessel segmentation. And the CTO planning in procedural CTO, you can divide it to pre-procedural planning and the post-procedural planning. In pre-procedural is, I can able to know the complexity scoring, and I can see the viable approaches, whether what can I plan, whether I can go with an antegrade or retrograde, what is an appropriate equipment required, distal vessel anatomy. If in a CTCAG, if the patient gets a severe calcium, you are into sure that I wanted to get a hard wires, you are going to a Gyanex or the Congress Pro, and you are able to also be able to kept a rota ablation ready, because already the CT was showing severe calcified block and you may not be successful. You can adequately counsel the patient that because of severe calcified block, my success rate may not be as good as a normal patient. This can able to tell you. Other calcium strategies and the wire to cross always makes in a good role. There are the scoring systems, pre-procedural complexity scoring, the JCTO score, CT rector, KCCT, Korean, and the recharge. The recharge CCT a better predictor the success rate of 30-minute wire crossing than conventional angiogram. When a patient went to a coronary angiogram and the patient the same as in a CTCAG with coronary angiogram, the success rate for intervention guy predicting a success rate by doing in a CT with coronary angiogram will always high when compared to in a plain invasive angiogram. These were the different scoring system. The JCTO score has called the tapered or the blunt. This is the same which we will be using in the same in CT also when compared to invasive coronary angiogram. The JCTO score is CT is JCTO bar CT scoring system. Whether tapered or the blunt tip, whether it's a calcified or it's a bending, how much is the bending in the segment, whether the occlusion length. And most important thing is the CT rector score is whether it's already duration of CTO plays a role. When the duration of CTO is more than 1 year, you are able to see that the plaques will be calcified and the fibrotic, you are able to, the success rate will be low. If your duration of CTO is less than 6 months, then the microchannels will be exit, where the fielder FC can easily track to the pathway. And the KCCT score, the definition and the scoring is the same. What is the pre-procedural CT is also going to help as intervention guys. It can able to minimize the contrast depending when you are planning. The radiation dosage already you know. What is the procedural duration can be meant. And most important, plaque morphology and CTO length. Other things what the CT can help is if there is anomalous RCA origin. If you are going to already, if you have done a CTCAG, you are able to see whether it's an intracoronary and what is his scores and what is his termination. Whether it's an recently we have done in a course which was anomalous RCA, but when done in a CT CAG, invasive angiogram, it was looking an anomalous RCA coming from the left coronary sinus. When a CT CAG was done, it was between the transmural between aorta and pulmonary artery. If you are able to see an anomalous coronary artery, don't think that the invasive angiogram is enough. CT coronary angiogram is a mandatory to see the whether it is an intramural part or it is going in between the aortas, because the even if you do an open CTO, mid RCA CTO, if it was coming in between the aorta and pulmonary artery, patient is going to die. So always CTCH is mandatory if you see an anomalous coronary arteries. And most important graft vessel is post CABG graft intervention in CTO. Most important thing graft intervention is the anastomotic side, the distal anastomotic side, the kink will be there. You will able to see the track how you are going. And most important thing in a post CABG graft interventions, if lima is patent, the survival of patient is as good as possible if patient is not having any limiting angina. Don't open any arteries if the patient is not symptomatic and the lima is patent. It is survival benefit is as good as it is not there. And most important thing is the ISR in CTO to assess the length. If the patient underwent stenting in past maybe 20 years before, the CT can help us to know what stent has kept if you are planning. If you wanted to take and if a everolimus stent was deployed, if you wanted to keep another depth, the CT can help you in the size and length of that. If the and CTO in a post CTO is patient already underwent a CTO, procedure was not successful. If you have done a CT after 4 to 6 weeks or after 8 weeks as an investment procedure, what the CT can able to tell is whether the new tracks has developed, whether dissection was over there, what is the dissection plane if it is extending, how far is the distal entry cap, and what is the degree of calcification which has failed in your prior setup. And most important thing is post CTO PCI to assess the patent. If you have kept an ostial LAD stent or an ostial RCA stent from LM to an LAD stent, CT CAG is mandatory after 1 year to see the LMCA stent patency. Even if a normal coronary angiogram, invasive angiogram, if LM stent was kept after 1 year, CT CAG is around class 2 recommendation to see the LMCA patent. Even if the patient may be asymptomatic, but better to rule out and you can say your stent is patent. And whether really there are the studies to can able to see, sir, I will not don't do CTA because it's a cost procedure 15,000 for the patient. This is the small study by the Rolf et al. And Hong et al. Where they have done a prior CTCA and they no CTCA. When the prior CTA was done, the success rate was around 90% when there was only 60%. So your success rate is more than 2/3, 70% majority when you are able to do a CTCAG and you plan your session when compared to without doing a CTCAG. This is the just 2-3 slide. This is an LAD was normal mild lesion. This was an RCA CTO. LAD is good. How the CT has changed? If you see the CT, the extent, if you are able to see the mild distal calcification, at the same time the length is okay, the angulation was normal when compared, it's not any 45 degrees angulated. Only one thing is junk is around more than 20 mm. And most important thing is you may cause the proximal segment easily. Most important thing is after causing a proximal segment, there is a distal side branch. Maybe your right repeatedly will be going to distal side branch. Depending on this, you can able to plan your session. You can use a dual lumen catheter. After entering this, you already there was imprinted in your mind after crossing this much extent. I used to use dual lumen catheter. Instead of going this, I am targeting my wide to this other side. This is one of the doctor who has underwent a PTCA stent to an RCA. It was stented for an ACS and stable angina at other center. He was having a mid LAD short CTO. He was not interesting for going for an CABG. How best we can give the RCA stented at other lesion? They have referred to us for an LAD CTO. How it has helped the CT CAG is I can make sure to the doctor that RCA stent patent is there. Even after 6 months, it is good. So now I can plan an LAD CTO in your case. If an RCO, when I was done an CT CAG, already if there is a lesion in RCA stent, I should have told that already stent in the RCA is blocked with an ISR. Already LAD is a CTO. Better I can renegotiate him and say that better you go for a CABG instead of doing a repeat CT intervention. This also can help you in your practice. And most important in this case, you see, this is a mid LAD short CTO, 6.mm length. Proximal cap is calcified, so I'm always worried that already it's classified. I may not be succeed, so I'm always going to, I can negotiate the wire very fastly instead of going in a fielder FC. Directly you can go in a tough wire. And mostly distal is also calcified. Most important thing is there is no significant angulation and there was no large side branches. Only the bad thing in was proximally it was a calcified part. This was after his stenting and he is doing very well. This was an ostial LAD CTO. Most important thing is when you are doing an ostial LAD CTO, the CT CAG helps to know whether how it is there, any significant side branch. Initially, when this angiogram was done, we really got it out whether it's a ramus or the large LAD CTO. But if you have taken a LAO caudal view, that's the where, okay, we have missed this part of tertiary, then it has helped. Then the CT CAG was done. This is a clear-cut diagram. There is no need of science in that. There is a non LAD is very good. There was a significant gap at the ostial part. The collateral is nicely filling an LAD. So this is the diagram where you can easily pass if you are not able to do an antegrade. But the epicardial coronary collaterals are there. You should always be careful. This is an ISR CTO. There is a distal lumen. This is the image I kept for your understanding. The proximal part of an it was normal. There was a distal LAD ISR CTO. This is how it looks in a lumen ISR CTO. The take-home message from the talk, assess CT iotogram if you are doing. The most important thing is, if you are planning for any circulatory devices, impella, I wanted to know what is the peripheral vessel size. If the femoral is bad, if you are planning for a high-risk cardio severe LV dysfunction, you should always be knowing peripheral vessels. And other thing, aortic calcification. If any severe calcification is there, if the patient is having severe atheroma, don't take any devices which are very different, because once you pull the atheroma, they are going to develop stroke. So you always be careful if the severe calcified porcelain aorta is there when compared to a normal aorta. This should be your hearing. And coronary artery origins, course and termination is clearly delineated. CTO block assessment, length and distal vessel is and side branch. Most important thing is, if there was an aortic dissection during the procedure, how CT is going to help. If you are doing an ostial RCA, if there's severe calcified, when you have dilated, there's an aortic dissection, always if patient monitor is hemodynamics and you do a CT CAG, now you see the extent of dissection, whether it is extended down to the aortic wall causing a severe AR, or it is extended to the cranials to plan your surgeries. And most important while doing CTO is wire entrapment. The guy is going to get notorious because once it's stuck into the block, wire entrapment. If the already wire is broken, sometimes you may not able to see it. If it is broken into any other cranials, you can able to delineate with this. And post-end assessment for ISR and peripheral vessel dissection, CABG graft patency and interventions planning. These will be the future of all interventions. What I feel is, before entering into a cath lab, you will be seeing the CT, and then you will planning your strategy, and then you will be doing the case. Depending on this, what you wanted to see the block composition, then you plan, okay, this patient is getting to get slow flow. Oh, this patient is severe calcification is there. Please, technician, keep ready of rototripsy or IVL because this is the patient. And next will be ostium position and catheter selection. Already, instead of planning in the cath lab and wasting the contrast, already in the CT has shown this, whether you are planning for a Judkin, whether you plan an Amplides or AL or a different, you can able to plan. Or most important, the 3D coronary overview. This will be always reflected side to the angiographic registration is coming into the future, where you can able to see the cath lab and the CT images, where you can listen, you can minimize the contrast. And other thing is function on table functional significance. You can able to done if you can match with the CTFFR, you can see, oh, this is the CTFFR at this area, it was around 0.80. But the same area, if I do an OCT co-registration, the severe calcified like lumen area is less than 4 mm, you can doubly sure and stent it instead of sending the patient. And other thing is the online procedural guidelines. Nowadays, same like Google Baba, just you can send there, you feed it, it itself will give you what to be done, what your strategy, what is the next. That is the way software you can develop it. And we are working, when we are doing in Singapore, we are developing a SynLab bank where we are screened around 1 lakh population. Now artificial intelligence reports the CT CAG of the patients, and we are monitoring with this. Already live study is going on, Apollo study, where we are going to publish that maybe in the next 1 year. No need for any human interference. Patient get the CT CAG, because in Singapore everyone needs to go for a mandatory military. So they will do an extensive investigation. You go for cardiac MRI, cardiac CT, because if patient is stable or the person is stable, then only they will be sending for an army recruitment. Because the patient will be getting the data. Now they are monitoring with an artificial intelligence monitoring. The artificial intelligence is very high, because to report CT in other parts of countries is very high when compared to the cost in India. That way the artificial intelligence will take on our role. Thank you. I thank ijcto and my team members for helping me. Thank you. Any doubts are welcome. I hope next session we can carry on.
Thank you, Dr. Harmanth Reddy, for the talk. The last talk by Dr. B.V. Purohit regarding collateral navigation.
Yeah, I think it's already time, and we are all hungry for our. So the most important thing in any retrograde CTO is how do we identify a collateral, how do we navigate it so that we can cross the collateral and go to the distal cap. So that is the most important aspect of any antegrade or a retrograde CTO PCI.
This concept started since way back 1990 when it was done through SVG, but really picked up. What we are seeing today is from 2006 onward when Kato et al. They published their paper, and then that is basically it revolutionized the whole thing. These are the 10 steps which we do when we go for any retrograde PCI. First is we decide whether we have to go antegrade or retrograde. Then we select the collateral. Then we take the microcatheter, enter into the collateral. Then we cross the collateral. Then we put the wire into the distal part of the retrograde. Then collateral is crossed with the microcatheter. So only crossing wire is not enough. Then you have to cross with the wire microcatheter also. Then you cross the CTO segment retrogradely, whether you use various technique, cart, reverse cart, whatever, ping, rendezvous, anything you would want. Then the retrograde wire is externalized, and then you dilate with the balloon, and then the retrograde equipments are gradually removed. So these are the 10 important steps. So this is how we decide whether we have to go retrograde or not. This is the global CTO crossing algorithm we are all familiar with. In last 2 days we have seen multiple times people talking about it. This is how you grade the channel to select which channel you are going to take, because there will be multiple channels. So there are various scores, J channel score, the CC score. So each have their own advantage and disadvantage. But what I prefer is keep it simple. Just see what is the size of the channel, whether they are less than 1 millimeter or more than 1 millimeter, and how much is the tortuosity. If it is very tortuous, then you have to select your wire and equipments accordingly. If they are a little less tortuous, you can go with a little simpler wires. So that is how you decide. You look at how many bends are there, how many 360-degree rotations are there. So that will tell us whether you are going to progress or not a progress. So these are the various scores which you have. These are the various channels which happens. If you have a RCA CTO, you can have a channel from the septal to RPDA, the circumflex to PLV, the bridging collaterals, the apical LED to the RPDA, the LED to RV, the RA to distal RCA. So all these various channels you can see. So if you have a LED CTO, this is how the channels will be. The most important are the PDA to LED, the RV to LED. You can all get all these things in. There is a Euro intervention journal is there. You put it collaterals for chronic CTO. You can see all these pictures there. So don't worry about it. So the point which I will be making is you keep on seeing all these channels. But only one point I'll tell is, if it is the LED CTO, the most important channel will be coming from the distal part of the PDA. If it is a RCA CTO, the most important channel will come from the first septal. You can have other septals also, but the most important, most of the time it will be the first septal. Even if you are not seeing it, if you do surfing, you will find some channel which will connecting there. But if you have a good distal septal also, then you can track that also. So this is the circumflex channels. So this is what I was telling. The LED, PDA, PDA, LED, 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 all these channels will be there. What is most important is you need to check what is the entry point and how is the exit point. So that will tell us which catheter you need to take to enter the channel, and what catheter will help you cross the distal part. Because if you take a very stiff catheter like a Corsair Pro, you may not be able to cross the distal bend. If there is a very sharp angle at the entry point, you need to take a dual lumen catheter, something like that, or you have to take an angulated catheter. So this is how this will decide you. So you spend enough time in analyzing the collaterals before you start your procedure, because the moment you have decided what you are going to do, your procedure is going to be very simple after that. So these are the various channels which we take. The bypass channel, which were the initial part, even now also you saw there are so many people they did it. Then you have the septal channels and the epicardial channels. They have their all plus or minus. Earlier we were very scared about using this epicardial channel, but nowadays with the catheter, the soft wires and the easily trackable low profile microcatheter, we are not hesitating to take a epicardial if we are finding little tough with the septal. But still the most preferred is the septal channels. So what are the equipments? The three most important is guide wire, microcatheter, and last is the guide extension. If your microcatheter is not crossing, then only you take it. Next come to how do you select the wire, which wire you should take in which type of things. Most fundamentally, you have to understand there are two types of wire. One is a polymer wire, another is a non-polymer wire. Non-polymer wire will be nitinol or stainless steel. Polymer wires are very, very slippery, and one of the wire you saw in the last year, there is the whisper wire. That used to be when I started my CTO way back in 2008-9, I used to cross with the whisper wire. At that time, the other wires were not there in India. And then you have to look at what is the core to tip, because if the wire is core to tip, that will have a good trackability. If it is not core to tip, that means the torqueability will be less. Most of these SI wires are core to tip, stainless tip. Stainless tip will give you a very strong support. If it is a nitinol core, then the support will not be good, but it will have a good torqueability and flexibility, and it will retain back its shape. But stainless steel wire will have a good torque. So all the SI wires, if you see the Gaia and all this thing, they're all stainless steel. And on top of that, they have some additional mechanism which gives us a better one-to-one torque. So stainless steel is good for support, push, torque, but it is less flexible. Nitinol is very elastic. You have this BMW wire. They are basically nitinol wires. So these are the workhorse wires. You look at the highlighted ones, the composite core, the Sion, which is a workhorse. But one thing you have to understand, there is a difference between a polymer and a hydrophilic. A non-polymer wire also can be a hydrophilic, but a polymer wire, invariably, it is more lubricious than a hydrophilic wire. And then the polymer jacketed wire, which we commonly use, are the CN block, the filler XTA, XTA or XTR, because these are the wire which are very trackable. They are very, very lubricious. But most common wire which we take in the initial days was the SUO. Nowadays we are using. It is not a polymer wire. It is a non-polymer wire, but it is very hydrophilic and very soft tip. So that is all. So this is how the channel should be looked, and based on this you decide which kind of wire you are going to take depending on the tortuosity. So if you have a very tortuous, you should take a very soft tip wire, that is the SUO 3. The conventional SUO is 0.5 gram tip load, but the SUO 3 is only 0.3. That's why it is SUO 3. It is the softest wire. The tip is also soft. The shaft is soft. It is very, very trackable because it's again a stainless tip. So you can torque it and you can cross most of the highly tortuous channels with this wire itself. So this is what you should do. Make sure that you don't damage the channel, avoid the perforation risk, and when you are trying to cross the channel, you need trackability and the tip flexibility. So that is all comes with this core to tip wires. And make sure that the tip of the wire doesn't get raised. If you have such highly tortuous wire, the trick is you go to the first bend, take the microcatheter right up to that bend and take the softest tip wire and allow it to gently go. If it is an epicardial channel, it will go with the cardiac movement. I'll come to that later on. And then the tip bend will automatically try to cross it. Don't keep your microcatheter too far away and then try to cross this highly tortuous channels. So this is the set of wires which we take if you are trying to cross the septal collaterals. You can see if it is a very, very tortuous, continuous tortuosity, the wire of choice becomes SUO 3. The XTR, again, it is a taper tip wire, but if it's a very tortuous wire, then you may perforate the septal channel. So what you need to do is you need to make a bend on the tip of the XTR wire, so that many a times we make a J bend so that the wire doesn't perforate. If you don't make that J bend, then wire will perforate through the septal channels. If you are taking a SUO 3, it is not a taper tip wire. So you can have around 70-75 degree angle will be there, and then you can cause this very tortuous wire. If you have a very, very small side branch, then probably you will prefer, or if you have a very small channels, the size is very not big, then you have to take a taper tip wires. If you have a very acute bend, then again you need to take wire which has got more pushability like a Sion or Sion Black. But again you need to remember these are all lubricious wire. Sion Black is very lubricious. So if you are not careful, you may perforate. So you have to be very careful. So I will suggest if you are a beginner, start with a SUO wire only. And then take a Sion Black only if you are more confident, because Sion Black has a lot of pushability. It can go through these channels. When you try to push it, it will go. But you may perforate also. If you are trying to do surfing, that is invisible channels, earlier we used to depend mainly on the XTR only. But nowadays, even with SUO wire also, there are people who have been doing surfing. So you can see here in the algorithm, the most common wire which people have taken. This is for collateral channel success. You can see here the overall collateral. You can see the most common wire is still the SUO wire, and the Sion is the next. If you are going for septal collateral, again the SUO wire is the most common and the Sion is the next choice. If you are going for epicardial, non-septal, what we call is that, again you can see the SUO is the most common and the Sion is the next common. So this is how the most CTO operators they prefer. So, and this is also how after coming of SUO, we have all changed our our technique. Earlier we used to take Xeon or Xeon black for all the channels, but nowadays our first wire is a SUO wire. This is how you try to make a tip bend. Most important, you need to make that there should be a second band, because if when you are trying to go into any channel, if the second band is not there and if there is a plug, the wire will go into the plug. So the second band, the first band will actually keep the wire into the middle, and that is how you will be able to navigate. So always try to have second band, and the first band will depend on what is the size of the initial artery. If it is a narrow artery, the bend will be short. If it is a bigger artery, the bend will be big. And the second bend, the first bend, as I said, is basically, this is the first bend. This is basically to keep the wire away from the sides. It will keep the wire in the center of the side vessel. And the first bend will, the second bend actually, which is there, which is more proximal bend, which should be the size of the proximal artery. Then only you will be able to go into the side channel. And what is the angle? That angle will depend on how is the takeoff of the side branch. And before you do, it is always mandatory that you do a dual injection so that you can see all the channels properly. And for septal to septal, the most preferred angle is the RA or radiocranial. That is where most of the PDA gets opened up. The distal part of the septal channel you can see, and the channel which is connecting into the LED also you can see there. So this is how. One thing a lot of operators do, and many of, if you are more experienced, you may not do, is a safety wire. Because when you are going from this, if you dissect the donor artery, that is the LED, then your safety wire will come into the picture. If you are a beginner, you can use it. Otherwise, you can omit this step also. Next, after channel selection, wire selection, the next is the selecting what kind of microcatheter. Again, the microcatheter selection depends on what is the tip crossing profile. Whether it is a small channel, whether it is a pushability is required. So based on that, you see. If you see here, the most common catheter which we take are the Corsair Pro, the Caravel, the Fine Cross, Turnpike Elke, all these things. I'll tell you one simple thing. Most of the time, except for Corsair Pro, which has got a little higher tip entry profile, the Corsair Pro XS, the Caravel, the Turnpike LP, all these have a tip entry profile of 1.3 only. You can see here. You can see all this Caravel. The tip entry profile is almost I went in. The tip entry profile you can see here, 1.4, 1.3, 1.3. So these are all Corsair, Corsair Pro and Caravel. But what makes them different is Caravel, the mid size is 1.9. So that makes that if you have a smaller channel and you have more tortuosity, then this catheter will easily track them. But if you have a bigger profile in the mid shaft, then the catheter may not cross. If it is a bigger profile, it gives you more pushability because it is more robust. That is where the plain Corsair comes into the picture. The mid shaft is 2.6 and the Corsair Pro also has 2.6. But if you look at the Turnpike LP, where it is, yeah, there it is. The mid shaft is 2.2 and the distal shaft is 1.6. So this is how you choose the catheter. If you have a more epicardial channel, then you need a catheter which is more flexible. So that means the shaft should be a little smaller. That is around 1.9. So Caravel comes into the picture. The Turnpike LP comes into the picture. The Fine Cross comes into the picture. But if you want a very calcific lesion, the antegrade CTO is there, or the retrograde is not crossing at all, then you need a catheter which has got more robust power. That is the Corsair Pro or the plain Corsair which we have. So that will be giving you more pushability. So I hope you understand how you select your catheter with this. So this is the entry profile of, you can see here, the tip entry profile of Caravel is 1.4, entry profile of Pro is 1.3, Pro XS is also 1.3. But what happens to the shaft, and this has got a braided strap, so this actually helps in preventing the kinks, and you can easily cross all those things. Coming to the difficult collateral, if you are not able to enter, as I said in the beginning, if the entry is very angulated, you can take a dual lumen catheter, angulated catheter, and try to take a polymer jacketed, which are very lubricious wire. You will be able to cross them easily, like a Filter XTA or Filter XTR. So that will help you go through the sharper bends also. And this is the special catheters which I told about. And crossing, how do you cross? Most common is the contrast guided. Go into the septal channel, give a contrast, delineate the entire channels, and then go. If you are not very clear, you can do with the surfing also. So what are the wires for surfing? As I said, Filter XTR or SUO3. How do you surf? Just keep giving antegrade, retrograde. Don't make it 360-degree entry into the inside the channels. And you try to give gentle pushing and stop immediately when you feel resistance. So you keep going in, coming out, and give a forward, backward, clockwise, anti-clockwise, and then try to cross into the invisible channels. As I said, you can select the channel which one you want to do based on the experience. That, as I said, most likely the first channel will have something which is connecting, and if it is RCA to LED CTO, most likely the distal part of the channels distal PDA will have channels which can surf. And when you are trying to do surfing, it's a very small channel, so you have to take a catheter which is the lowest profile, like a turnpike LP or a caravel we can take for this. Now, what are the wires for septal channel? As I already said, non-polymer wire, which we take generally the Sion, or the polymer wire, or the Sion black, filter FC, XT, XTR, all those things. So this is the slide I already told you. Now these are the complications. Coming to the last part, there is the epicardial channel. As I said, epicardial channels are very prone for perforations. So the wire which we choose are the polymer wire most of the time. They are the Sion black or filter XT or XTR. And nowadays, with the development of SUO wire, that has become the wire of the choice. You can see here in this which wire you have to change. Most common is the SUO 3 followed by Sion, and if at all you are going for the smaller channels, then you have to take a XTR. If the epicardial channels are small size, then you need a wire with a little sharper bend. But if you are taking a XTR, make sure, because epicardial channels are very tortuous, almost corpuscular, you are not supposed to have a 75-degree or a 90-degree bend. You will perforate. You must make it is almost like a J-shaped, and then you try to cross it with this. So you keep it at the tip, allow with the diastole, because in the diastole the channels will open, and keep a firm push. Don't push, just keep a firmness. With each diastole your catheter will take turn and it will keep going. You don't have to do much, you just have to keep a forward push. Automatically the wire itself will take a turn and it will keep going. So make sure that is how you should, you will get it with experience how you are going to cross it. And as I said, shaping, SUO 3, make a short 1 millimeter bend of almost 60 to 75 degree. If it is XTR, make a J-shaped, and try to keep your microcatheter as close to the bend as possible. But don't go deep inside. Close it, allow the wire to take a turn on its own, and it will automatically go. Don't make vigorous 360-degree bend inside the epicardial channels. So these are the catheters. Again, fine cross, caravel, Corsair XS or Turnpike LP. These are the catheters which you prefer. And before I close, this is a simple algorithm how you can choose the catheters, and what happens if one wire doesn't work, go to the other wire. If the other wire doesn't work, take switching of the wire and switching of the microcatheter will help you in crossing it. So with this, I close. Thank you very much.
CD presenter, sir. All done. CD presenters. You present it. ఒక్కసారి మంచిగా తీయం. హనుమంత్ రెడ్డి భయ్యా, ఈ IJCTO ఇట్లా వచ్చేటట్టు జస్ట్ నేను చెప్తాను, ఒక్క నిమిషం. స్క్రీన్ ఈ చైర్లు వస్తున్నాయి ఏంటి? వచ్చిందా అది? నెక్స్ట్ ఒక్క 2 నిమిషాలు. ఇది ఒకటి ఇది ఒకటి, అంటే నేను కూడా వచ్చి జూమ్లో Just I play one video. Ah.
వీడియో ఫార్మేట్ ఇస్తాను సార్
ఫోటో
ఈ వీడియో
ఇది
సార్
ఓకే
వచ్చేది సార్ ఫోటో కూడా
ఫోటో
ఎస్ చేసి కట్ చేసి తీస్తాను వీడియో సార్
ఇంతవరకు మనం అయిపోయిందని ఒక ఫోటో కూడా దిగలేదంటే అందుకే మనది ఇట్లా జూమ్ కావాలంటే అది ఇట్లా తీస్తారు ఏదన్నా ఏది బెటర్ ఉంటుంది
గుడ్ వన్ సార్
ఇది కొంచెం ఇట్లా
సార్ సార్
మంచిగా
ఇవన్నీ వస్తాయి సార్
అవునా దాని రాకుండా ఎలా ఐ థాట్ దట్ అందుకే ఈ చేయడం పక్కనట్టు అయిపోతుంది కదా
అదే రివైజ్ కూర్చాక బెస్ట్
మన కన్స్ట్రక్షన్ లేదు
పర్ఫెక్ట్
ఓకే అంటే వేరే స్లైడ్కి వెళ్తాం 1 minute
సార్
మనం ఇది ఇట్లా ఇక్కడ పేరు ఇట్లా
ఆడు లైట్ వేస్తున్నాడు తినేసి రా ఫోకస్ పోయి థ్యాంక్ యూ సార్ అది ఫ్యాన్ అయితే చేయలేదు వీటి కాడ పేటు కదా అదే వేసుకున్నాడు కౌంట్ తాగాలంటే మనం రోడ్ ఎఫెక్ట్ పడుతుంది చూడు ఎట్లా ఇది పక్కకే బ్రేక్ఫాస్ట్ ఏడు ఉందాడు స్వీట్ ప్లేట్ ఎంత వేసుకుని రాత్రి ట్యాక్సీ పడుతుంది